Clear? Yes? All are okay? To start with, the basic wave, that is the P wave, that is the P wave. Last person is able to see? Last person able to see?
Mic correct irukka?
Yes sir.
Mic audio.
So audio correct ah irukku. Audio so this is the normal anatomy of the heart. Okay.
Audio record
that is come from to the right from the
ஏனா நான் லைவ்ல
superior vena cava and the inferior vena cava. Audio clear ah and inferior vena cava from where it goes into the right atrium and then it goes into the right ventricle, then it enters the pulmonary artery, that is the lung for the paramedics and for the interns. So this is the basic anatomy. Then from the lungs it enters into the left atrium through the pulmonary veins, gets oxygenated, the left atrium it goes into the left ventricle, then to the aorta. This is the basic systemic circulation of the heart. So knowing this, we will go into the depth of the ECGs. So the sinus node and the interventricular conduction system. So these are the two ventricles and these are the two atriums. This is the right atrium, this is the left atrium, this is the right ventricle, this is the left ventricle. The in between one is the interventricular conduction system. So the system starts from, you would have seen in physiology, from sinus node, that's from the atria, then it goes to the AV node, then to the bundle of His, then to the right bundle branch, then the left bundle branch. From the right bundle branch, it goes into the Purkinje fibers and the right ventricles, and the left bundle branch will go into the left anterior fascicular and right anterior fascicular Purkinje fibers and the left ventricle. This is a normal system. It starts from the SA node, AV node, bundle of His, Purkinje fibers, all those things. This is a normal conduction system of the heart. So the activation of the atria, the first wave of the ECG is the P wave. So this is the normal waves that we see in the ECG. So first wave is the P wave. I will be covering the P wave. The other faculties will be covering, each segment will be covered by each person. So now we are concentrated on the P wave. Clear? We are concentrated on the P wave. So what is the activation of the P wave? So activation of the P wave starts exactly from the SA node. So the first half of the P wave, that is the first initial activation, is from the right atrium. The second part of the P wave, P wave is a contour surface. It's a contour surface, it is a curved surface. The first part of the P wave is from the right atrium. The second part, the terminal half of the P wave, is due to the activation of the left atrium. So this is the contour of the P wave, this is the activation of the atria. That is what we see in the ECG. So you see, this is the P wave that we are talking about. This is the P wave. So first half will be because of the right atrium, the second half will be because of the left atria. So suppose you have some pathology in the right atria or in the left atria, so you can see either in the first half of the P wave or in the second half of the P wave. So you all know how to position the leads. Just to brush up, this is the ECG workshop, just to brush up where to place the chest leads on the chest walls and what are the different chest lead placements that you should be knowing. Understood? So lead positions, ECG is one of the most useful investigation in medicine, that is bedside, even in the ER, and electrodes attached to the chest or to the limbs. We will attach electrodes to the chest and to the limbs that has a potential voltage that changes the difference and that is transposed. Okay. So this is the basic landmark for the all paramedics. This is the basic landmark where you are going to basic anatomy, where I am going next slide. I am going to show where you are going to place the leads. So this is the manubrium sternum. This is the sternal angle. That is the second rib. This is the costal rib. And you draw an imaginary line. This is the clavicle bone. You draw an imaginary line, mid-clavicular line. Then the anterior axillary line on the axilla, anterior axillary line, and the mid-axillary line. So there are different systems of electrode placement. First system is 3 electrode system. 3 electrode system uses 3 electrodes. That is the right arm, left arm, and the left lower limb. Okay. This monitor displays only lead 2, 1, and 3. Okay. This is one type of variant. And next one is the 5 electrode system. 5 electrode system uses 5 electrodes. That is the right arm, left arm, right arm, left arm, right leg, left leg, and the chest wall. So this displays bipolar leads of 1, 2, and 3, and a single unipolar lead depending on the position of that is the brown one. You see the brown one here, B. This is the brown one depending on the position of the brown one. That is the chest lead. This is B1 to B6. This is the normal you see in all the hospitals. Different clinics will have different things. They have 3 leads, they have 5 leads. This is 12 lead ECG that we have in our hospital setups, where we place the V1, V2, V3, V4, V5, V6 as shown in the anatomy here. You see here, this is the anatomy. Clear? So the 4 leads, the 4 electrodes, okay, are placed on the right arm, one on the left arm, right lower limb, and the left lower limb. Then 6 electrodes, that is from V1, V2, that is the chest leads. That is from V1, V2, V3, V4, V5, V6. This is the common interpretation. So, specific interpretation of the areas of the heart using the leads. Lead 2, 3 and AVF will be inferior leads. Lead 2, 3 and AVF will be inferior leads. Lateral leads will be 1, AVL, V5 and V6. And anterior leads will be V1 to V4. Clear? So, inferior leads is 2, 3 AVF. Lateral leads is AVL and V5, V6. And anterior leads are V1 to V4. This is an important thing that you should remember because we are going into it deep in the later part of the day. Okay, so where do you place the V1? V1 you place on the 4th intercostal space, V2 on the 4th intercostal space along the left margin of the sternum. You see, both are on the, this on the right, this on the left, on the 4th intercostal space. Be very specific. You can draw an imaginary line on the nipple. You see the 2 nipples here. Just above the nipple, to draw a line, straight line to the nipple, there you place V1 and V2. It is very important to know this placement, even for doctors, all those things. If you change the leads and you place, you tend to misinterpret ECGs. Understood? So, next is V3 somewhere in the midway, V4, V5, V6, all in this pattern. So, additional lead placements. What other lead placements for the PGs and interns? So, what are the additional leads placement that you are going to see? One is right-sided ECG electrode placement. Then is V4R ECG lead placement. Posterior leads, Levy's leads, and then Potter leads. Understood? So, right-sided ECG placement. So, similarly, how do you place on the left side? Similarly, you place the V1 and V2. Don't change the position of V1 and V2. Just reciprocate it on the other side, just a mirror image of the normal ECG. That will be on V3, V4, V5 and V6. Where it is used for? Where it is used for? This kind of ECGs to see for right side extension, RV extension. If you have a myocardial infarction, you want to rule out any RV extension, then you are going to do a right-sided ECG. So other one is, which is more usefully, that is we just shift the V4 alone here. You put you want a right side, just shift the V4 alone here. You see most of the ST elevation V4 has sensitivity of around 80% and diagnostic accuracy is 83% in inferior wall STEMI. Understood? If you want to diagnose the inferior MI with the right exterior extension, just place the V4 alone on the other side on the midclavicular line. You will get a right-sided ECG. Next is the posterior ECG. Posterior ECG also is required when you have an inferior MI with the right side extension. Be very clear, tell your paramedics or your staff nurses to place exactly here. You see, this is the scapula. You see, this is the midline of the spine. From here you have to start. From here you have to start, you have to place these leads to look for posterior extension. When you have a myocardial infarction with the right RV or inferior wall, then you have to look for posterior extension. We label it as V7, V8 and V9. So, coming to my topic, to the P wave. So we see many of our residents or our faculties, our interns, might feel this is a new thing that they have to know. Where the atria, that is the P wave, is not seen in the ECG, then you use this method. So what you do? You put the RA, that is the right arm electrode on the mandibular sternum, and the left arm electrode on the 5th intercostal space. and the left leg electrode on the right lower costal region, and the right leg is on the standard portion of the right leg. So you see we have a clip, no? In our disc we have a clip. When you have a clip, it is very unlikely to put this on this leads. So you have to get extra bulbs. The bulbs that are going to place on the chest leads, you just disconnect the clips and then you connect the bulbs. You connect the bulbs and then you place like this, and the hidden P wave, exact morphology of the P wave, where is the P wave, you can see in this view. I'll show you an example. This is an alternate position. This is an alternate position. After several studies and papers published, you just put the RA on the mandibular left, LA on this thing, and then right and left will be same. Still you get a good P wave in the ECG. You just monitor the lead one. Just monitor the lead one in the ECG. You will get a P wave. This is an alternate of Lewis placement. This is a simplified one. Understood? This is clear? Yeah. Okay. So these are the most common methods. You see, this is the 12 lead ECG, 5 lead, 3 lead, and this is the basic anatomy where you are going to place the leads. These are the additional lead placement. So I will show you an example of P wave where the Lewis leads are used at the end of the slides. Okay. Going to characteristics of the normal P wave. Going to my topic. Going to normal characteristic. It is a smooth contour. It is monophasic in lead 2. The P wave is always biphasic in V1. It will be biphasic. I will show why. So the axis will be covered in next slides. So remember, the P wave axis is usually between 0 to minus 75 degree. Understood? So the duration of the P wave should be less than 12 seconds. These are all theory part. That is 3 small square boxes. 3 small square boxes. You all know one big box is there in the ECG paper, and then inside it small square boxes are there. Understood? Paramedics. So these small 3 square boxes is the normal duration of the P wave. What is the amplitude? In the limb leads. Limb leads is the right and the left and the lower limb. We keep the limb leads 2, 3. The limb leads for the amplitude it should be less than 2.5 nm, and whereas the precordial leads, that is V1, V2, V3, V4, V5, V6, the amplitude should be less than 1.5 mm. Understood? If the patient is having any atrial abnormality, if there is any atrial abnormality, it is most commonly seen in the inferior leads, that is 2, 3 AVF and lead V1, as the P wave are most prominent in these leads. When you are looking for any atrial pathology, look for the inferior leads, P wave in the inferior leads, that is 2, 3 AVF and V1, where you have a prominent P wave. There you can exactly differentiate the morphology, and depending on that you can come to a diagnosis what is the atria going into exactly. So this is the waveform relationship to the P wave. So atrial depolarization proceeds sequentially from the right to the left with the image that I have showed you. The first half will be the first 1/3 corresponds to the right atrial activation, and the final 1/3 will be the left atrial activation. This is the image that I have shown you, the similar thing. Yeah, the first half is the right atrial and the left, the second half is the left. So V1, however, in lead V1, the right and the left atrial waveforms move in the opposite direction. So only there is a biphasic P wave. I told you, there is a biphasic P wave in this one. See, you see, this is a normal morphology in lead V1. You see a biphasic P wave. Here, this is a biphasic P wave. Why is it so? Why is it so? Because this produces a biphasic P wave in the initial positive deflection corresponding to the right atrial activation. Subsequently, there is a negative deflection relating to the left atrial activation. Okay. This is because this is why we see lead V1 where you have a biphasic P wave. Understood? Okay. This is a normal morphology of a P wave in lead 2. This is a normal morphology where this brown one is the right atrial activation and the blue one is the left atrial activation. So the combined depolarization wave, that the P wave should be less than 120 milliseconds. Theory part 120 milliseconds wide, and the height should be less than 2.5 millimeter. This is the normal morphology of the P wave is always seen in lead 2. Okay, suppose there is a right atrial enlargement. What happens? You see, suppose there is a right atrial enlargement, the red part becomes decreased. You see here, the red part becomes decreased and the blue part widens up. The blue part widens up. this is the morphology of a P wave when you have a right atrial enlargement. You see lead 2 and the P wave looks like this, then you suspect that there is a right atrial enlargement. So when there is a left atrial enlargement, you see it is peaking. It is peaking in right atrial. The height increases, whereas in the left atrial enlargement, the breadth of the P wave increases. The width of the P wave increases. That means there is left atrial enlargement. You see, this prolonged. The left atrium is prolonged. Sometimes it might be notched. This is called as V mitral. Sometimes a broken notch can be seen. That is called as V mitral. This is the normal morphology of the P wave in lead V1. Don't think that is abnormal. It is normal morphology. It is always biphasic. So in this ECG, you see there is a right atrial enlargement that causes increased height. You see that causes increased height because of the right atrial enlargement. I told you increased height in right atrial, and there is an initial positive deflection of the P wave. Okay, and there is also a right ventricular hypertrophy. Just miss that one. Just for the part you see right atrial enlargement in the ECG. You see, everybody is able to appreciate the P wave is peaked here. This right atrial enlargement. Yes. So this is left atrial enlargement. Left atrial enlargement in lead V1. Lead V1. You see, it is broader. It is broader. That is called as, it is wide. Basically, it is wide. Okay. So when there is biatrial enlargement, so this is the normal P wave in lead 2. This is the normal P wave in V1. When there is right atrial, RAE is right atrial enlargement, left atrial enlargement, and when there is biatrial enlargement, what happens? When there is biatrial enlargement, you see there is a peak notch here, then again there is a widening. This peak notching denotes that the patient is having a right pathology, and this widening denotes that the patient is having a left atrial enlargement. Okay, you see V1 it is always biphasic. It's always biphasic. You see here, this is the biatrial enlargement. This morphology will be seen. Understood? So common P wave abnormalities that you should know is P mitral, that is with the left atrial enlargement, and P pulmonale, that is with the right atrial enlargement, and P wave inversion, that is seen in ectopic atrials and junctional rhythms, and variable P wave morphology, that is multifocal atrial tachycardia. The morphology of P wave keep changing in every part of the ECG. So this is the example of a P mitral. Everybody is able to appreciate P mitral in lead 2. That is because of the left atrial enlargement. You see here, this is the P mitral. Okay, so this is P pulmonale. This is because of the right atrial enlargement. That usually clinically the patient might have a pulmonary artery hypertension or pulmonale, or patient can be a chronic COPD. This finding will be there in the ECG. So inverted P waves. Inverted P waves for the PGs. Inverted P waves is inversion of the P wave in the inferior leads. You see here, inferior leads indicates a non-sinus origin of the P wave. So whereas in the PR interval, you have to differentiate. When you have an inverted P waves, see the PR interval. The PR interval is less than 120 seconds, or the PR interval is more than 120 seconds. If the PR interval is less than 120 seconds, then it is accelerated junctional rhythm. That is called as AJR. If the PR interval is more than 120 milliseconds, then it is ectopic. Then it is ectopic atrial rhythm. For the PGs, it is AJR. If it is less than 120 milliseconds PR interval, if it is more, then it is ectopic atrial rhythm. So other variable morphologies of the P wave. One is multifocal atrial rhythm and multifocal atrial tachycardia. When you say it is multifocal atrial rhythm, the presence of multiple P wave morphology and multiple ectopics within the atria. Okay, so if less than 3 different P wave morphology are seen, then it is multifocal atrial rhythm. If the rate is more, than 100, then you call it as a multifocal atrial tachycardia. This is called as just multifocal atrial rhythm. This is multifocal atrial tachycardia. You see the rate is more than 100. You see the morphology of P wave? It varies. Yeah, here one morphology, here one morphology, here one morphology. The morphology of P wave keeps changing. Yeah, something called as for the PGs, that is focal atrial tachycardia, that is FAT. This is a form of supraventricular tachycardia originating from a single ectopic focus within the atria, not outside the sinus rhythm. You have to identify this one. So this is a variant of a SVT. So it has only single ectopic. and it is within the atrium but not outside the sinus node. Okay. So why it is important to know all these things, this fat, atrial flutter or multifocal atrial tachycardia, because the management of all these three varies. So only it is important to distinguish between fat, atrial flutter, multifocal atrial tachycardia, all those things are very important to clinically treat the patient. So pathophysiology of, to be very simple, it is due to a single ectopic focus. I've already told you, it can be paroxysmal or it can be sustained. It can be because of digoxin toxicity or atrial scarring because of a previous ischemic heart disease, or any catecholamine excess release is there, or alcohol or congenital abnormalities or idiopathic reasons. Understood? So ECG features of atrial tachycardia. Atrial tachycardia, atrial rate is always more than 100. Abnormal P waves, you know, morphology keeps changing. And then unifocal and identical P waves, isoelectric baseline. Unlike atrial flutter, there will be isoelectric baseline, and the normal QRS morphology will be maintained. And AV block may be present, that is generally physiological response to the rapid ventricular rate. Be very clear, PGs, AV block may be present when you have a atrial tachycardia, except in digoxin toxicity, other areas AV block may be present. This is because of the rapid ventricular atrial rate, because of the rapid atrial rate. So I am told about the Levy's lead. No? Levy's lead for looking into the P wave, for the hidden P wave. You see, this is the ECG. I think many of you will be able to appreciate. This is an ECG where the P wave is not able to see. You have placed a Levy's lead, and then in lead 1, you have just highlighted here, you are able to see the P wave. So lead 1, the configuration amplifies the P wave in strip lead 1. The atrioventricular dissociation, that is, there is no oscillation between the atria and the ventricle, confirming that the patient is having a ventricular tachycardia. You have this rhythm and you don't see any P wave. You need to see where is the P wave, then you put this Levy's lead and look at lead 1, you will identify the P wave. This is what we are talking about, Levy's lead, why it is important to find out the P wave. So AJR, I have told you, accelerated tensional rhythm. So this situation arises when there is an increased atomicity in the AV node coupled with decreased atomicity in the sinus node. This is the basic thing that is happening behind it. Okay, so anything that disturbs the electrical activity in the SA node can precipitate the AJR, that you remember. Common causes are digoxin toxicity. Any RST patient who is on digoxin, long-term digoxin can have digoxin toxicity or poisoning can be there, or an MI or myocarditis or recent history of any cardiac surgeries. This is AJR. This is ECG features of AJR. The normal QRS complex, I have already told you, QRS complex will be narrow. Ventricular rate will be 60 to 100. There will be retrograde P wave may be present, and AV dissociation may be present with the ventricular rate usually greater than the atrial rate. I have already told you the dissociation between the AV that has been differentiated in the previous ECG. Okay, clear? Thank you. Any doubts? Any doubts? Thank you.
For the day is Dr. Ashwin, Assistant Professor, Igmc on the topic QRS morphology and interpretation.
I think the pointer has some issues, but yes, you can see the pointer right now on the screen. We'll try to point it out here. Fine. So you can see this. You have an ECG here. Which part looks very big there in that ECG? Which part looks bigger? QRS. Okay. That doesn't have any relationship with the size of the faculty. It was just routinely was placed. Okay, so don't have any of those relationships. So basically, just see about our QRS. Now, I'll take it very slow. We are just going to have only the basics of the QRS, because since P and P are There are no separate pathology class, so I had to discuss everything there. But QRS, I have our Indian faculties coming up who will be teaching about hypertrophy, enlargement and all those things. So we'll just see the basics, we'll take it slow, you will be taught them later, okay? Okay, so basically what is QRS complex? It's for your depolarization, right? Depolarization of your ventricle. No doubt in that, because depolarization is like your electrical activities will happen at the cellular level, so the activation of the ventricle is going to happen. That is going to cause your QRS complex. Fine, that much done. So as I have told, it is the largest deflection in your ECG, and how it is going to happen, basically, which is causing this activation. Sir has showed you the this thing, right? Conduction pathway. So this is your conduction pathway. So you have your SA node, then your AV node, bundle office. Then you have your left and right bundle branch. After that, you have your Purkinje fibers. So this Purkinje fibers are actually present in the endocardium. So your activation will be from endocardium to the epicardium. Okay, that is one point which you have to remember. So then it will be like, so as I told, the impulse spreads from endocardium to epicardium in an outward direction. Fine. So now, QRS. So from time immemorial, from your first year or something, you would have learned like QRS is QRS. Doesn't mean that all the leads should have your Q, R and S. It's not going to be QRS in every lead. Just the complex is named as QRS. You might have only one deflection, you might have two deflections, you might have three deflections. So you will have to know how you are going to label the QRS complex. Okay? So any positive deflection after your P wave is going to be your R. So the positive deflection is your R wave. And the first negative deflection is your Q wave. But if the negative deflection comes after your positive deflection, then it is your S. Okay? So Q, R and S. So QRS doesn't mean that all the leads you are going to have all the three waves. So just make sure that you know that the positive deflection is going to be R, the first negative is Q, and after the positive deflection, whatever negative wave comes, that is going to be your S wave. Okay, if you are going to have one more positive, then you will say that it is an R dash or R prime. If you are going to have only one deep Q, only one deep negative, then you can say it as QS complex. Anyways, you just see the images. Fine. So what is that? I think it is self-explanatory. Only one positive deflection is there, means it is just R. You have one positive deflection and then a negative deflection. Though this is the first negative deflection, this negative deflection is coming after your positive deflection. So this is labeled as RS. It's not RQ. Okay, it is RS. And of course the R is bigger enough, so that's why the caps, and S is a small letter because S is smaller. This is small r and S because R is of lesser amplitude and S is of a higher amplitude. And here is your always told as QRS. This is your QRS because you have as negative deflection, then a positive, and then again a negative. Then only it's going to be your QRS. So this is going to be your Q and R. This is QS because one deep wave is there, then you can label it as QS. This is going to be a QR. So as I told, again two positive deflections are coming, so it is going to be R, then you have a negative deflection S, and then you are going to have an R dash. Okay? So then this is like one small Q is there, then after that you have a positive wave, so that is your QR. So now you know that how you are going to label the QRS complexes. Of course, it's going to be different in each lead. It has significance when you go into your pathologies because you will have to compare with the normal physiology with your whatever is in the ECG to find if it's going to be a pathology or not. So just make sure that you know how you are going to label the QRS. Next we will see why that happens, why it is not always QRS, why it's going to be different, why each one is different deflection forms in each lead. So that we will discuss for the next some 5 minutes or something. So basically ventricle is a very thick muscle, right? Thick muscle is there. That is why you have your big QRS complex is formed and all. So it's a thick one. That is why it is not going to be depolarized at the same time. It will take some time for depolarization of the entire ventricle. So that is why you have your QRS complex formed. And so what is the time for the entire QRS complex to happen is 0.06 to 0.10 seconds. What each box, small box, what is the seconds and all will be discussed in the next session. So the overall QRS duration is your width of the QRS complex, and it starts from your initial wave and ends in your last wave. Let it be Q or R or S, whatever it is, the entire deflection is going to be labeled in that way. To have the rule simple, these are the 2 points. You have seen the lead placement. There are V1 to V6, so many things were there, and there will be some location of your vector. If it goes towards the lead, it's going to cause a positive deflection. If it goes away from the leaf, it's negative deflection. Very simple, nothing else. Just you are just going to have this in your mind and proceed with the further slides. Okay, so towards is positive and away is negative. Fine. So we will discuss mainly about the chest leads, which will carry some significance. So if you are coming to your chest leads, one we will see towards your V1, other we will see towards the V6. Okay, of course, like how the lead placement was shown, V1 will be on the right side and V6 will be towards the left end. So based on that, we will be seeing that. You can see that, right? So you have your V1 and V2 in this side. You have your V1, V2 here and V5, V6 this side. Okay, and see what is the orientation. This yellow color is your septum. So this is your right ventricle, this is your left ventricle. So we'll see how it is going to be activated step by step and why the deflection is going to happen. Okay, so first is, so one is your V1, other is your V6. The first one to depolarize is your ventricular septum. Okay, because from the Purkinje fibers, from the left side of the left bundle branch, the supply for the Purkinje fibers for your septum arises. So your septum will start to depolarize first, and it starts from left to right. Clear? So septum is the first to depolarize, and it will be from left to right because the Purkinje fibers for the septum will come from the left bundle branch. Done? Clear? Fine. So it's going to start from left and go towards the right. So if it's going to come from left to right, the septum from left to right, what will happen to V1, V2? It's towards V1, V2 or away from V1, V2? From the septum, it's going towards V1, V2 or away because it's coming from left to right, right? Left to right. So it's going towards V1, V2 or away from V1, V2? Towards, right? It's going towards V1, V2. So that is why you are getting a positive deflection in your V1. Whereas for V6, it's going to be away from your this thing. The vector is going to be away. So that is away from V5 and V6. So there it is going to be a small negative deflection. Done? Fine. Next, what is going to happen? After your septum is depolarized, next your ventricles are going to depolarize. With respect to ventricles, the right ventricle is very small compared to your left, right? So because of that, whatever vector is getting generated because of your right ventricle is going to be cancelled by the left ventricle. So whatever extra is of the left ventricle, which is getting depolarized, that is only going to be represented as your deflection. So ultimately, whatever deflection you are going to get for the ventricle is basically your left ventricular deflection. That is what is going to happen. Fine. Now, when it's going to start, so left ventricle is on your left side, right? Fine. Left ventricle is on your left side. So the more muscular part is your left ventricle. That is only going to cause your this thing. So if that is a vector towards V5, basically left, what is the orientation of your left ventricle? It will be somewhere oriented like this, right? The oriented retrosternally, it will be oriented this way. It is going to be this orientation. So when that vector passes, it will be towards V5, V6 or away from V5, V6? It will be towards V5, V6 and it will be away from V1, V2 because it's going to be on the left side because it's for the left ventricle. So that is why you are getting a negative deflection in your V1, V2 leads and it's going to be a positive deflection in your V5, V6 leads. Okay, done? Fine. Then after that, the last part is your basal part of your myocardium, basal part of your left ventricle is getting. So that will complete the cycle of your QRS complex. Just know this so that we will put it all together for V1 to V6. Same thing which I have discussed, just in a bit elaborate way. The first vector is for your ventricular septum. The first portion is activated in the middle third of the left side of the ventricular septum. It is from left to right. Because of that, in V1 you are getting a small positive deflection R. Then in your that is because it is towards the electrode. Whereas on the other side, it's going to be a small Q wave. That is a negative deflection. Because first negative is Q and first positive is your R. Next, so this Q wave, okay, just one additional point. This Q wave is called a septal Q. Because we should be knowing whether Q can be pathological also. That we will discuss towards the end of the session. So basically this small Q is called as septal Q wave. Since it is due to the septal activation, it is called a septal Q wave. And the total duration should be very less. It's just 0.03 seconds. At least just know that it's called a septal Q. Second is for your ventricle. It's for both ventricle, but the right side is getting cancelled, so only your left side is going to act. As I discussed already, you know what is the direction. For V1, V2, it is going to be away, and for V5, V6, it's going to be towards. And third is the terminal one, basically just for the basal part of your basal part of your left ventricle. This is your third one. You can see that this is your arrow for your septum. So that is why V1 has a positive deflection, V5 as a negative 1, and here this is your vector for your ventricle. That is why V1 will have a negative 1 since it's away, and V5 is going to have a positive 1. So the location of the leads which has been already discussed. Okay, so just to whatever you have seen that, just we are putting it all together from V1 to V6. This is important because later in MI they will be discussing this is a normal RV progression, then they will be discussing what is poor RV progression. So you should know how the RV is going to progress in your limb leads. Okay, from V1 to V6. As we have discussed, what is it? In V1 it is more of a negative 1. Just a small positive deflection followed by a negative. Whereas towards V6 it's going to be mainly a positive deflection and a small negative deflection. Okay, done? Fine. For other limb leads it's mostly a positive deflection. Just remember that way. So this is your normal ECG. Nothing wrong with this, just to show you the same points. V1 a small positive deflection followed by negative. When it progresses, see here, towards a V5, V6 you have more of a positive deflection. That is, you have mainly a R wave. Okay, it is going to be just an R and small s. It will be in that way. Fine. Now we'll go to the amplitude. So this we have just labeled the waves, and we have just seen how it is formed. Fine. Now coming to the amplitude, what is the normal amplitude? Okay, just remember these values. The height of the QRS complex in the limb leads should measure more than equal to 5 mm in at least one lead. Okay, and for your chest lead it should measure at least more than equal to 10 mm in at least one lead. Okay, fine. Just know that the entire QRS amplitude. Okay, this also has some significance. Just make sure that you remember these values. 5 mm is basically one big box in your height. Okay, so that will be also there next. So when you are going to call it as a low voltage, when same values, if normal is more than 5, then obviously abnormal is less than 5. Same. So low voltage is if the tallest QRS in any limb lead is less than 5, or the tallest complex in any chest lead is less than 10 mm. Okay, done. The same point, just in the other way. Fine. So when you are going to say it is low voltage, okay, whenever this is your criteria to say if it's a low voltage complex or not. When you are going to have a low voltage complex? Actually, why low voltage? Why there is going to be low voltage? Basically, it's all electrical activities. Like you are getting some, you are connecting leads. Your electrical activity is transmitted to the leads. When do you think there can be low voltage? Okay, so from heart it has to get conducted. So something is obstructing between your heart and your leads. That's where it is going to be called as low voltage. So if there is going to be fluid around the heart, pericardial effusion. If the patient is very obese because there is so much of subcutaneous fat, hypothyroidism also there is more of connective myxedema, connective tissue and all will be added up. So these are some common causes which are going to cause low voltage complexes because the electrical activity is not going to be transmitted fully. Okay. So this is basically so much of edema is there, or COPD because your lungs are so much inflated, so much of air is there, so it's not getting transmitted. Obesity, pericardial effusion, pleural effusion, and hypothyroidism. Okay, so can you see this low voltages? If you are actually calculate, it will be less than 5 mm. The tallest in your limb leads will be less than 5 mm. Okay, so this is an example for your low voltage complexes. Fine. When it is going to be increased voltage, that has a separate session. Whenever ultimately it is muscle, right? Muscle is only going to cause your all this QRS depolarization and everything. So you have so much muscle, your amplitude is also going to increase. So much muscle is of course ventricular hypertrophy. Okay, so that will be discussed in separate session. But you can see right how the QRS complex is there. It's very big. Like how big it is means even it is overlapping over the other leads. So that much amplitude is there. This is for your high voltage complexes. That is for your hypertrophy. Okay. Then there is one more thing with respect to amplitude, that is your electrical alternates. I think it is self-explanatory. Electrical and alternates, that is alternating amplitude. Okay, you are getting an alternating amplitude. For example, you see here, small, then a bigger one, a smaller one, a small one, a bigger one, a smaller one. So this is called as electrical alternates. There is alternating amplitude. Why this happens? Where it can happen? Same electrical activity, same thing only. You have pericardial effusion, heart will be ventilating inside. So heart will be, there are chances that heart will be moving inside. So this is your wall, your heart is there. Whenever your heart is going near your chest wall, the electrical activity will be captured more. Then again the heart is going to move away from your wall, the amplitude is going to be less. So that is why you are getting an alternating amplitude, sometimes in your pericardial effusion, and this is going to be like this. Okay, so this is called as your electrical alternates. Fine. This is their amplitude. Then again, broad QRS. So you see the amplitude, what is the duration I was telling? 0.06 to 0.10 I was telling. If it is more than 0.12, then we say that it is a wide QRS. Okay. Again, that will also be discussed with your bundle branch block and other during your discussion. They will be discussing that. Just know that when you are going to call it as a broad QRS complex. Of course, these are the causes: bundle branch block, hypokalemia, and some drugs will be causing your broad QRS complexes. Can you see this? Your normal QRS duration. This is how it is. This much is only your QRS. In contrary, you can see this. So what is how wide it is? How the QRS is wide compared to your normal set. Fine. Fine. With respect to poor RA progression, as I was telling, just know that how it is going to progress. As I have discussed already, during MI they will be discussing if it is poor RA progression, how it is going to look. And one important thing which you have to remember in that is your MI. So that is why we are giving importance for that RA progression, how it is going to progress. Fine. One last thing about your Q waves. This is my last slide, okay? Don't worry, I'm not going to bore much. So Q waves. Q waves, what always you are saying that QRS complex. So Q waves is there. But doesn't mean that Q waves is going to be always physiological. Anything, whatever it is, it should be within some limit, right? Even if you do some bad, you have some bad habit, it should be within limit. Same way, Q waves also, it should be within some limit. If the Q wave is deep enough, then it is not going to be physiological, it is pathological, and it is very, very important to know that because in MI, till then, was I audible? Now only I feel the difference with the mic. Maybe my voice must be louder. Fine. So just know about your pathological Q waves because with respect to your Q waves, it is not like always physiological. Don't think it is always physiological. Just know some points like, okay, in the first point there has been mentioned about V2, V3 and all, right, initial leads. Generally V2, V3 you have a Q wave, what will be there? What is the first reflection in your V1, V2 as I was telling? First reflection is in V1 or V2, it is, first is your positive reflection, right? Because it is the first thing, that is your septum is towards the V1, V2, so it's going to be a positive reflection. When will Q wave form? Only if it is the first negative wave reflection, then only we are going to call it as a Q wave. So any Q wave in leads V2 to V3 or a deep QS complex, as I was telling, QS is a deeper complex. In those initial leads, that is initial precordial leads like V2, V3, then it is going to be pathological. This is one. One more is, if at all, Q wave, just know the seconds, but it is very difficult. 0.03 is very, very minimal. It might be difficult for you to interpret. At least you can see that more than 1 mm deep QS complexes in leads 1 to ABL, ABF or V4 to V6. Okay. Because in all these, mostly Q waves should be small. It should not be deep enough. Okay. In any two leads of a contiguous lead grouping, basically contiguous is continuous. How we are going to grouping, that is also given in this. 1 ABL, you can consider as 1 contiguous. V1 to V6, basically precordial, you can consider. Then 2, 3 ABF, you can consider. So these are the different groupings. So if you are going to have in any two leads of contiguous lead, means in 1 ABL or in V1 to V6, any two contiguous ones, or in 2, 3 ABF, any two contiguous leads. If you are going to have a deep QS complex, then again that is also pathological. Why we are specifically telling about this is, in myocardial infarction, you will have pathological Q waves. So Q waves are not always physiological, just have that in mind. So these are some of the causes. Very important thing is your myocardial infarction. Right. So these are my references. Thank you.
Thank you, sir. Our next speaker is Dr. Ramesh Ji, Consultant of Emergency Medicine, ESI Hospitals, Hyderabad, on the topic ST segment morphology. Sir, please.
Hello. Good morning. We have discussed the P wave and the QRS till now. We know that whenever you see ECG, we always speaking about this ST segment, which is very important and very complicated also. That's the reason why the multiple speakers are there to speak about this ST segment. Okay, I'm going to discuss only basics of ST segment, and I'll speak very simply, very neatly. Okay, just see the basics. After that, you go further. Okay. So these are the topics we are going to cover in this: J point, J wave, ST segment, T wave, and U wave. Okay, all the waves we are covering in this only. After that, we are going to discuss further. You see here, till now QRS complex they have discussed. What after the QRS complex? The starting of the ST segment. Okay, then the end of the QRS complex and the starting of the ST segment is the J point where you are seeing here. Okay, this is the J point you are seeing. J point which you are seeing here, which is at the end of the QRS complex and the starting of the ST segment. Next, this is the ST segment you are seeing. After that, the positive deflection, whatever you are seeing is the T wave. Okay. So what is J point actually? We start at the end of the QRS complex. This is actually the sometimes you see the elevations are also very common in the J point normally. Why there is elevation in the J point? When there is a difference in the repolarization of the epicardium and the endocardial cells. You know, right, that was epicardium, myocardium and the endocardium. All the muscle cells will get repolarized at a time. So when there is a difference between the epicardium and the endocardial difference, repolarization, that time you will see the J point elevation, which is a normal phenomena sometimes. Okay, sometimes in hypothermia and hypercalcemia, this difference will become more and more and more, where you can see the positive wave that called J wave. I'll show you what is the J wave also. Here you see, this is the J point what you are seeing here. Okay, this is the J point elevation. This is the one parallel J point elevation where you are seeing the concave type, and here also absolute type of the J point elevation along with the ST segment elevation you are seeing here. Here you see the J point depression is there along with the ST segment depression. Here the difference you are seeing now, the J point whatever is there is some separate wave is there. This kind of J wave will be seen in hypocalcemia and hypothermia when there is prominent difference between epicardial and endocardial repolarization. Okay, this is J point. So how does J point elevation looks in ECG? Can you see this one in the lead? Can you appreciate this one in the lead 2? The lead 2 along with the ST segment, the J point is also elevated. In ECG, if you are seeing these kind of elevations, you can see the J point elevation properly here. Okay. See, this is the Osborn wave. As we were discussing the J wave. J wave is nothing but Osborn wave. So you see here in the V4 and V6, this is the ECG of hypothermia patient where the J wave is prominently seen. Can you see this one? The J wave. Generally J wave we don't see. J point only we will see, and the elevation we can see in some patients. But in some cases you can see the J wave, which is a positive deflection which will be seen at the end of the ST segment. Sorry, at the starting of the ST segment, end of the QRS complex. Okay. This is the J wave, this is the patient of hypothermia. Okay. Another wave which we will see before the starting of the ST segment is epsilon wave. Actually, you can see this is the QRS complex here. You are seeing this is the QRS complex. After the QRS complex, there is one small positive deflection you are seeing here. Can you appreciate that? Can you appreciate all of you? You can't see it. See, this is the positive deflection which you are seeing after the QRS complex. The positive deflection is called epsilon wave. This is mainly because of the late depolarization of the right ventricle. Sometimes in conditions like arrhythmogenic right ventricular cardiomyopathy, the right ventricle is very big, where there is a late depolarization which will be depicted as one of the positive waves at the end of the QRS complexes, which will be appreciated very common in V1, V2, V3. Okay, see, this is how it looks. This is the QRS complex you are seeing here. At the end of the QRS complex, you are seeing the epsilon wave. You got it right? Okay, so this is seen in ARVC, arrhythmogenic right ventricular cardiomyopathy. Okay, so till now we have seen what is J point, J wave, and what is epsilon wave. This and all will be discussed later also. Just I am giving this basic information about these waves. And the most important wave which we are going to discuss is like ST segment. ST segment is nothing but here we are seeing the cardiac cycle, the depolarization, plateau phase, and the repolarization. Like the 0, 1, 2, 3, 4 phases are there. The ST segment will represent the plateau phase of the cardiac cycle. The phase 2 of the cardiac cycle is nothing but ST segment. Okay, so ST segment will be considered abnormal when it deviates from its normal position. The baseline, what is the baseline actually? Whenever we take the ECG, to tell that it is ST segment elevation, ST segment depression, PR elevation, PR depression, we should take one base point, no? One baseline should be there to compare with the, to compare whether the elevation is there or not. What is the base point in ECG? Anyone? TP segment. The TP segment, the end of the, no, I'll show you, wait. See here, this is the P wave you are seeing, this is the QRS complex you are seeing. Okay, this is the T wave which you are seeing, okay? And this is the second heartbeat where P wave and the QRS complex and the T wave is there. So, at the end of the T wave and starting of the next P wave, one segment is there, no? This is called the TP segment, which is the base of every ECG. With that only we are going to tell that it is ST segment elevation or depression. Okay? So, any deviation from that baseline more than 1 mm is like defect in the ST segment. Okay? So, like these are the causes of ST segment elevations. We are going to discuss ST segment elevation, depression, all these things. So, these are the causes. All these causes will be discussed in the upcoming presentations. So, what are the patterns of ST elevation? How ST elevation looks? Generally, we should know how it looks. So, these are the patterns of ST elevations. You see, this is a convex type of ST elevation. I'll show the A series also, don't worry. This is a convex type of ST elevation. You can see this is the elevation here. Straight upsloping type, horizontal type, downsloping type, and concave type of ST elevation is also there. You can see the ECG here. Where is the convex type of ST elevation here? In which lead? In which lead you are seeing that one? V5. See in the V5 ones, it's exactly like convex type of ST elevation. So this is one pattern of ST elevation. The diagnosis and all will be discussed later in the upcoming these things. Okay, and you see this one, straight upsloping type of ST elevation. Where you can see which lead? You can see in the lead 2 and 3 and AVF, inferior leads. Okay, lead 2, 3, AVF, you see exactly this upsloping type of ST elevation. Okay, and you see straight downsloping type of ST elevation. You can see in the lead 2, 3 and AVF also, here also. The ST is like downsloping type like this. Okay, this is one more pattern of ST elevation. This is another pattern, the coving of ST elevation you are seeing. Generally you will see the Brugada pattern, pattern will call this one. You see the V2 and V3 here, generally. Okay, it's a coving type of ST elevation. It is not the convex, it's not like the concave, it is not like straight upsloping or downsloping. It's like coving. The ST elevation is like coved like this. Okay, this also will be discussed. So basically you should know how the ST elevation looks. So why I am discussing this benign early repolarization and pericarditis means generally whenever you see the concave type of ST elevation, main differentials are these two only, benign early repolarization and pericarditis. So concave type of ST elevation is there, and what is what? Whether it is a benign early repolarization or pericarditis. For that only we have these differences. ST elevation in only precardial leads is PER. ST elevation which is generalized is pericarditis. ST elevation associated with the PR depressions is pericarditis. No PR depression is PER. Okay. T wave amplitude which is like very prominent T wave is PER. Normal T wave is pericarditis. And the STT ratio less than 0.25, more than 0.25. And fish hook appearance that I will show you next ECG is there, which is seen in benign early repolarization. So whenever you see the convex type of, till now we discussed this like convex, upsloping, downsloping and straight. Whenever you see concave type of ST elevation, you think of these two mainly, BER and pericarditis. And you should differentiate between BER and pericarditis. Okay? So this is the pericarditis which you are seeing. So see, along with the limb leads and the pericardial leads are like, pericardial leads also you are seeing the ST elevations. Okay? This is the BER which we are seeing here. The fish hook I was speaking about, V4 you see at the starting of the ST segment, there is small notch kind of structure is there, that is the fish hook type. So remember this, whenever the convex type of ST elevation is there, that is MI, myocardial infarction. Whenever you see the concave type of ST elevation, think of these two diagnoses. Okay, now you understood now? So now we are going to ST segment depressions. Okay, this is also like different morphologies are there, upsloping type, downsloping type and horizontal type of ST depressions are there. So horizontal and downsloping type of ST depressions more than 0.5 mm in 2 successive leads is myocardial infarction. Okay, And D witness T wave, I'll show the ECG also. Whenever you see the upsloping type of ST elevation with the prominent T wave is occlusion of LAD. You can see here ST segment depression, type of ST segment depression. So this is the baseline which I was speaking about. This is the baseline they have taken. This is the baseline. This is the baseline. And you see when you draw a line from the J point through the ST segment, the line is upsloping type. Got it? And here you see the ST segment depression is there from the J point through the ST segment. This line is downsloping type. This is the horizontal type of the ST depression. These are the patterns of ST depression. Generally, you will see in ECGs if any abnormality is there. Okay. So now you see where is upsloping type of ST depression here? Kindly speak. Kindly speak. Which lead you are seeing? V2 and V3. Okay, upsloping type only, no? And you can see the positive T wave, which is like very prominent. These are D witness T wave, which implies occlusion of LAD. Okay? You can see horizontal here. V2, V3, you see, this is the horizontal type of ST depressions, which will be seen in posterior wall MI. That will be discussed later. And this is another type of ST depressions. Where you are seeing ST depressions here, downsloping type. In AVL, you see. These are reciprocal changes also. Actually, if you can see here, 2, 3 AVL, ST elevations are there. Along with that, AVL, ST depression, downsloping type of ST depressions are there. Okay? This is one type of ST depressions. One more time, as we were discussing, ST elevation, the COVID type of ST elevation is there. Like that in ST depressions also one like this type of ST depression is there, which will be seen in toxic toxicity. You can see in V5, V6. Got it? V5, V6, the depressions are not upsloping type, not horizontal type, not downsloping type. It's like COVID type. Got it? Another wave which we are going to discuss is the T wave, which is one of the very important waves. Generally, ST segment we were telling that there is the phase 2 of the cardiac cycle we are telling, and the T wave is the repolarization of the ventricle. All the depolarized ventricle should be repolarized. Got it right? So the phase 3 of the transmembrane potential is the repolarization, that is the T wave, represents the T wave. Here you see the T wave, whether it is symmetrical or asymmetrical. Symmetrical or asymmetrical. The starting point of the T wave is like slowly, nicely it is going up very slowly, and the later half is like steep, very steep, falling down very steeply. Why it is there? We were discussing about the J point. J point elevation is mainly because of what? J point elevation is mainly because of what? There is difference in the epicardial and endocardial repolarization. T wave asymmetry is because of left ventricle and right ventricular repolarization differences. Got it right? The first part, the first half of the T wave will be because of the left ventricular repolarization, and the second half of the T wave is right ventricular repolarization. Both the ventricular it won't get repolarized, some difference will be there. So that difference will be represented as asymmetry of the T wave here. Okay? And T wave shape should be rounded, smooth and slightly asymmetric. Any deviation from this kind of structure of the T wave is abnormal. If it is symmetric, abnormal. If it is not rounded, abnormal. Got it? So what are the abnormalities of the T wave? We see the shape becomes peak, notch and distorted. That is abnormal T wave. We'll discuss that how it looks also. Okay? And the amplitude. Amplitude more than 5 mm in the limb leads and more than 10 mm in the precardial leads. That means T wave should be less than 5 mm in the limb leads and less than 10 mm in the precardial leads. Okay? So it is a normal T wave. And the normal duration is also about 160 milliseconds it will be there. And then the T wave becomes symmetrical or inverted. It should be asymmetrical. Then only it is normal. If it is becoming symmetrical, it is abnormal. Remember that. And it is concordant in the QRS complex. What is concordance and discordance? We'll be discussing. LBBB when we see that concordance and discordance also we'll be discussing that one. So you see here, this is the QRS complex and this is the T wave. The net positivity and negativity we have to see. See, this is the green labeled one is there, Q and S. These two are labeled with the green ink and this one is the yellow ink. If you see the net positive or negativity, positive or negative this one? It's a positive. So, if the QRS complex is positive, T wave also should be positive. That is called concordance. Got it right? So, T wave should be concordant. If it is discordant, then it is abnormal. Okay, you see here. The Q and S wave, whatever you are seeing here, and the T wave, R wave you are seeing. What is the net? Positivity, negativity? Negative. This is discordant. Got it right? This you have to remember because they are going to speak about this later. So the checklist should be there. Whatever we are seeing, whenever we are seeing the T wave. So in AVR and V1, T wave will be negative. Okay, and 2, 1, 2, V5, V6, T wave should be positive, along with V7 and V9 also. Okay, and if you are seeing 3 and AVR, occasionally you will see isolated T wave inversions. Either in lead 3 or in AVR, if you are seeing T wave inversions occasionally isolated, then it is fine. But if you are seeing T wave inversion in both the leads, then it is abnormal. Okay, so we should know this is a normal T wave actually. Then we should know what is abnormal T wave. As we were discussing, T wave should be round, smooth, like that. No? So peaked and hyperacute T waves. You can see the diagnosis is like this. Peaked T wave is like a hyperkalemia, and hyperacute T wave will be seen as the transmural ischemia. This is how it looks. Here you see. This is seen in hyperkalemia. Okay. Here the T wave is large, pointed with a short base. This is the base you are seeing, which is a short base. Here the base you see. This is a very large base and a very rounded. Got it right? This is the peak T wave, this is the hyperacute T wave. You got it right? So this implies the hyperkalemia. This is transmural ischemia. Okay? So you can see T wave peak here. This is the peak T wave with a short base and then peak T wave here. And you can see the broad base and the rounded T wave here. So both the diagnoses are different and the treatment will be different, and you should know what is peak T wave, what is hyperacute T wave. Got it right? Okay, this is also hyperacute T wave. Hello? Hello? Okay? Audible? Okay. This is the broad base with the rounded T wave you can see here. This is the transmural ischemia ECG. One more thing is that T wave should be positive always. Sometimes you will be seeing the biphasic T waves also, where you will be having the positive deflection and the negative deflection also. So if it is the first positive, next is negative deflection, it is because of the myocardial ischemia. You can see the ECG pattern here. And if it is first negative, after that the positive deflection is there, that is because of the hypokalemia mostly. Okay, this is like up and down, this is down and up. You are seeing the difference, right? Here and here, these are biphasic T waves. T wave will be like both, positive and negative deflection will be there. Clear? This is the ECG which we are seeing. Okay, you see the V3. What is there V3? Biphasic T wave is there. First is negative, after that positive deflection is there. Implies hypokalemia. And you see this one V2 and V3. Biphasic T waves are there, where first is positive deflection, next is negative. So implies myocardial ischemia. So biphasic T waves means you should remember these two things. One is hypokalemia and one is myocardial ischemia. And large T wave means you should think of two things. One is hyperkalemia, myocardial ischemia. You know hyperkalemia, myocardial ischemia T waves, and you know hypokalemia and myocardial ischemia biphasic T waves. Now T wave inversions. This will be discussed later. So I just given the diagnosis of the T wave inversions: pediatric T waves, myocardial ischemia, bundle branch block, ventricular hypertrophy, HOCM, pulmonary embolism, cerebral T waves. All these things will be having negative T waves. T wave inversions are always abnormal. T wave flattening also mainly we will be seeing in most of the conditions. Mainly we have to think about this ischemia and electrolyte abnormality like hypokalemia. Okay, you can see the T wave here in the AVL and the V1. AVL and the first lead you see there is no proper T wave. Positive T wave is not there. It is a flattened T wave, which is abnormal, which will be seen in myocardial ischemia or hypokalemia also. Because right, repolarization is mainly because of the potassium. You know this, right? Repolarization of the heart is mainly because of the potassium. Whenever there is potassium abnormality, whenever there is potassium, hyperkalemia is there, hypokalemia is there, definitely there will be some abnormality with the T wave, because the T wave will represent the repolarization. Okay? And the repolarization is because of the potassium. U wave. After the T wave, one positive deflection we see, that is U wave, a small positive wave after T wave. More prominent in V2 and V3. I'll show you how it looks also. Generally, U wave should be like T wave only, and the size should be less than 25% of the T wave, and it should be heart rate. Whenever the heart rate is low, that time only you will see the U wave. Okay. So these are the causes of the prominent U waves and the inverted U waves, hypokalemia, bradycardia, any electrolyte abnormality or bradycardia, you will be seeing the U wave. This is the U wave which you are seeing here. This is the T wave. And next to the T wave, the positive deflection before the P is coming the U wave. Can you appreciate this one? This is the U wave which you are seeing, which will be seen in electrode abnormality and bradycardia also. See, this is the ECG of the hypokalemia. This is the ECG of the hyperkalemia. Hypokalemia, there will be inverted or broadened T waves will be there along with U wave. Hyperkalemia, you will be having peaked T waves. Okay? So hypokalemia, this one is hypokalemia, this one is hyperkalemia. Now you see, which wave you are seeing? V3 you see, V3. Look for the T wave. T wave is inverted. Next to the T wave, one positive deflection is there, which is U wave. Exactly like that. The ECG is looking like exactly like this only. Correct? V3 you see exactly like this only. Somebody is pushing the T wave down. So this is this positive deflection is U wave and this is T wave. This is case of hypokalemia. Okay, here one positive deflection you are seeing after the T wave. This is also U wave. Got it? So till now we discussed what is J wave elevation, and ST segment, what is the normal ST segment, how the ST elevation looks and the ST depression looks, and T wave, what is the normal T wave and the abnormal T wave, and what is U wave also we discussed till now. If you remember these basics, next further we'll go for MI, all these things, electrode abnormalities, MI, everything will be discussed in detail. So these are the basics you should know before knowing all those things. These are my references. Thank you.
சரி நீங்கள் உடையம்லே பார்த்துக்கோங்க டிஸ்பிளேல உடையாமல் இருந்தால் போடுங்க கொஞ்சம் நோண்டுவோம்
The next session is a very basic session on rate, rhythm and axis. We finish as soon as possible. So, how to calculate heart rate in ECG? So, as you see here, this is how you get the rhythm strip, right? So, you will be having many large boxes, and within the large boxes, you will have many small boxes also, right? So, what is the standard paper speed that we have? That is 25 mm per second, which means 1 second is being recorded as 25 mm in an ECG, right? And consider this is a large box. So each large box is 5 mm, and within that there will be 25 small boxes, and each small box is 1 mm. Okay, so each large box, that is 5 mm, is equivalent to 200 milliseconds, and 1 mm, that is one small box, is equivalent to 40 milliseconds. Okay, so then what you have to know before calculating heart rate, whether it is a regular rhythm or irregular rhythm. First strip is regular, that is interval between two RPMs is constant in all, full rhythm strip. Otherwise, the second ECG, if you see, the RR interval is varying. Okay, so this is irregular. If you see the third strip, the RR interval is varying, but in this irregularity, there is a regularity. Like this RR interval and this RR interval is same, and this RR interval and this RR interval is same. So it is a regularly regular rhythm. So first is regular rhythm, second is irregularly regular rhythm, third is regularly irregular rhythm. We'll see the 1500 method. So if you are finding that it is a regular rhythm, the ECG you are seeing, first it is regular or irregular, you are finding that it is a regular rhythm, then you will be using either the 1500 method or 300 method. So for 1500 method, we know that the standard paper speed is 25 mm per second. So it means over 1 minute, it is 1500 mm, right? So what is heart rate? the number of cardiac cycles in 1 minute. That is what you are calculating in your heart rate, right? So over 1 minute you will be having 1500 mm, and so 1500 small boxes in 1 minute. So for calculating heart rate, you are taking 1500 as numerator and the number of small boxes between two RR waves as the denominator. So this is your 1500 method. Similarly, if you are taking the large boxes instead of small boxes, what do you know? For per minute, how many large boxes will be there? 300 large boxes. So in the 300 method, the numerator you will be taking 300 and denominator you will be taking number of large boxes between two successive arrays. So crossly you can remember, if there is one large box between two arrays, the heart rate will be 300 beats per minute. If there are two large boxes between arrays, it is roughly 150 beats per minute. And if there are three large boxes, it is 100. Four large boxes, it is 75. Five large boxes, it is 60 beats per minute. So what if the heart rate is irregular? If the heart rate is irregular, how we are going to calculate the heart rate? So what you can do is you can take either a 6-second strip or 10-second strip. Okay. So if it is a 6-second strip, how you can identify it as a 6-second strip? There will be 30 large boxes. And how you can calculate the heart rate? You can count the number of RAs in the 30 large boxes and you can multiply it by 10. So that is your 6-second strip. If it is 10-second method, what you can do? You can similarly count the number of RAs in the 10-second strip and multiply it by 6. Simple only, no? So first you will see whether it is regular or irregular. If it is regular, you will see whether it is a slow rhythm or fast rhythm. If it is slow rhythm, you can very well use the 300 method. Count the number of large boxes, 300 divided by number of large boxes between two RAs. If it is fast rhythm, you can use the 1500 method. You can count the number of small boxes. So 1500 divided by number of small boxes between two RAs. If it is irregular rhythm, use either the 6-second method, count the number of RAs in 6-second strip, multiply it with 10, or use the 10-second method, where you are going to count the number of RAs in 10 seconds and multiply it by 6. In this strip, what is the heart rate roughly? There are almost like 4 large boxes between two RAs. So 4 large boxes. So 300 divided by 4, it is going to be 75 beats per minute. If you are using 300 method of this, there are almost 2 large boxes between two RAs. So 300 divided by 2, 150 beats per minute. Okay. But fast rhythm, it is better to use 1500 method to be more accurate. So in this, if you are taking, there are roughly around 8 small boxes between two RAs. In that case, it will be 187 beats per minute. In this strip, first you will see whether it is regular or irregular. No, it is irregular. So this is a 10-second strip, and there are almost 23 RAs in this 10-second strip. So I will be calculating the heart rate multiplied by 6. So almost 138 beats per minute. Okay. Now we will go into rhythm. I think everyone is clear about how to calculate heart rate from ECG. So normal sinus rhythm. How you will know that it is a normal sinus rhythm or not? Now, what are the features of normal sinus rhythm? There should be a P wave. There should be a P wave. And every P wave should be followed by a QRS complex. And every QRS complex should be preceded by a P wave. And PR interval should be constant and it should be normal. So what is the normal PR interval? 120 to 200 milliseconds. That is 3 to 5 small boxes. And P wave should be positive in lead 1 and 2 and negative in lead AVR. P wave should be positive in lead 1 and 2 and negative in lead AVR. Okay? And P wave rate should be 60 to 100. All P waves should be of same morphology in a single lead. You will see a single lead and you will see whether all P waves are of same morphology or not. If all these features are fitting in, it is a normal sinus rhythm. Throughout the day, there will be multiple sessions in which you will be knowing the abnormal rhythms. for now we will stick on to only whether it is sinus rhythm or non-sinus rhythm. That much you identify. So rhythm analysis, you will be seeing whether the rhythm is regular or irregular. Then you will be seeing what is the rate, if the P wave is present or absent. If the P wave is present, what is the PR interval? Then you will be seeing the QRS complex. What is the morphology and what is the duration? And what is the relationship between the P wave and the QRS complex? And you will be seeing the T wave, if anything is different. And you will be seeing if there is any ectopic beats, and you will be determining the origin. So can we go through the ECGs? Whether it is sinus rhythm or not. You are able to see P wave. P waves are present? Yes, P waves are present. What is the next point? Every P wave should be followed by a QRS complex. Is it happening? See this one lead and tell. Every P wave is followed by a QRS complex, and every QRS complex is being preceded by a P wave. PR interval is constant and it is normal also. And lead 1 and 2 P waves are positive, and lead AVR P wave is negative. So it is normal sinus rhythm or not? So what is the last 2 points? Heart rate and P wave morphology. If you are seeing this lead, all the P waves are of same morphology also. So we can very well tell that it is a normal sinus rhythm. See this ECG. P waves are present or absent? P waves are present. There are P waves, right? Every P wave is being followed by QRS complex. Yes. Every QRS complex is being preceded by a P wave. Yes. Take a single lead and see it. PR interval is normal and constant also. What about P wave in lead 1? Is it positive? No, it is negative. Lead 2? Lead 2 also P waves are negative. Lead AVR P wave is positive. So is it a sinus rhythm? No, it is not a sinus rhythm. What about this ECG? P waves are present. Yes, P waves are present, but P waves are found here. These are retrograde P waves. Okay. So again, this is not a sinus rhythm, because P wave should be followed by QRS complex, and QRS complex should be preceded by P wave, right? But here P wave is like after QRS complex, P wave is following. That is retrograde P waves. So what about axis? Axis is the last thing. So what is axis? What do you mean by axis? Axis is the average direction of the electrical depolarization of heart. Okay. So you know that the electrical impulse arises from sinus node, from there to AV node, from there it goes to the bundle branch, right bundle branch, left bundle branch, and to the Purkinje fibers, right? So the average direction of electrical impulses you will be taking, then that is your axis. So these are the frontal leads. So you will have to know only about the frontal leads for detecting the axis. So frontal leads are your standard bipolar limb leads, that is 1, 2 and 3, and augmented unipolar limb leads, that is AVL, AVR and AVR. Okay. So here if you see what is lead 1, you will be taking the negative electrode in right arm and positive electrode in left arm will form your lead 1. And what is the rough axis? Like what is the axis? Minus 180 degree to 0 degree. That is the axis of your lead 1. So if lead 1 is having positive deflection, it means the electrical impulse is passing towards 0 degree, towards this axis. Similar way, lead 2, negative electrode is in the right arm and the positive electrode is in the left lower limb. So coinciding axis is minus 120 degree to plus 60 degree. Lead 3, negative electrode is in left arm and positive electrode is in lower limb. So coinciding axis is minus 60 degree to plus 120. Similar way for augmented limb leads, that is AVL, AVF and AVR. your exploring electrode of AVL is in left arm and ground electrode is the central terminal. So rough axis is, coinciding axis is plus 150 degree to minus 30 degree. Lead AVR, exploring electrode is in right arm and central terminal is your ground electrode. So the axis is plus 30 degree to minus 150 degree. Lead AVF, so negative electrode is in ground electrode, positive electrode is your placed in lower limb. So minus 90 degree to plus 90 degree. So normal electrical axis ranges between minus 30 degree to plus 90 degree. That is this one. Minus 30 degree to plus 90 degree is your normal electrical axis. If it is plus 90 degree to plus 180 degree, you will term it as right axis deviation. If it is minus 30 degree to minus 90 degree, you will term it as left axis deviation. If it is minus 90 degree to minus 180 degree, it is extreme axis deviation. Normal axis is minus 30 to plus 90, left axis is minus 30 to minus 90, right axis is plus 90 to plus 180 and extreme axis is minus 90 to minus 180. For axis interpretation, we have three methods. One is quadrant method, free lead analysis and isoelectric lead analysis. We'll keep it simple, we'll see only the quadrant method. When you will tell it as positive QRS, when R wave amplitude is more than your S wave amplitude, then it is positive. When you will tell it as equiphasic, if amplitude of R, like the R and height of S is equal, then it is equiphasic. If the height of R is less than height of S, it is negative QRS. So if the QRS is positive in any given lead, it means the axis is pointing roughly towards the same direction as the lead. If the QRS is negative in any lead, the axis is opposite direction to the given lead. If QRS is isoelectric, then the axis is 90 degrees to the lead. Okay. So quadrant method, we will be seeing the lead 1 and lead AVF. In this lead 1, QRS is positive or negative? Positive, which means the axis is towards the lead 1, that is towards the 0 degree. Okay. Lead AVF also it is positive. So axis is towards 90 degree. You will be shading this and you will see where the shading coincides. That becomes your axis. So it is normal axis or not? Yes. See this one, lead 1 is positive, lead AVF is negative. So lead 1 is towards 0 degree, whereas lead AVF it is negative. So it is away from 90 degree. So the upper part is shaded. So the coinciding thing is left axis. So it is left axis deviation. In this, if you see lead 1, it is negative QRS and AVF it is positive QRS. So it is away from 0 degree, right? So this one is being shaded and AVF it is positive, so towards 90 degrees. So this we are shading and coinciding, it is right axis deviation. Lead 1 is also negative, lead AVF is also negative. So you are shading away from lead 1 and away from lead AVF. That is towards minus 180 degree and towards minus 90 degree. So coinciding is extreme axis. To keep it simple, if both are positive, it is normal axis. If lead 1 is positive and lead AVF is negative, it is left axis deviation. If lead 1 is negative and lead AVF is positive, it is right axis deviation. If both are negative, it is extreme axis deviation. So left leaves away from each other. If you see, both are leaving away from each other, whereas right reaches towards each other. Okay. So these are the causes for axis deviation. We go to the ECGs. So lead 1 and AVF you will be seeing. Lead 1 is positive. Lead AVF is positive. So it is normal axis. Lead 1 is positive. Lead AVF is negative. It is leaving away from each other, so left axis. Lead 1 is negative. Lead AVF is positive. It is reaching towards each other, so it is right axis deviation. Lead one is negative. Lead AVF is negative. So it is extreme acid leakage. Any doubts?
Go to the previous slide, it's projected causes of that.
Any doubts? Okay, thank you. We will go to the simulation session. So you will be having 10 ECGs in which you have to
Everybody
see what
sitting
is
in
the
allotted zones. Please go back to allotted zones.
You have been divided into 10 groups, right? So you will be having 10 ECGs. Each group will be analyzing one ECG. And what you have to see is what is the range, whether it is a normal sinus rhythm or whether it is a sinus rhythm or non-sinus rhythm, and what is the axis. So first ECG will be interpreted by first group, that is Aurobindo Ashram. Second ECG will be interpreted by White Town Tea. Third ECG will be
Faculties are
interpreted by
requested to go to the
New
respective.
Lighthouse. Fourth will be interpreted by Sand Dunes Paradise Beach. And fifth ECG will be interpreted by Electrocardiogram Paradise. Sixth ECG will be interpreted by Long Beach Tea. Seventh ECG by Serenity Beach Tea. Eighth by Ponte Marina Beach Tea. Ninth ECG will be interpreted by Bharati Park Tea. And 10th ECG will be interpreted by Aurobindo. Is it clear? We'll be given 5 minutes time. At the end of 5 minutes, we'll have a discussion.
Faculties, please go to the respective stations.
At the end of 5 minutes, one from each team should be discussing about the right range, rhythm, and axis of ECG allotted region.
All team members sit together. All team members, please sit together. You have been allotted an ECG. Discuss among your team what is the ECG, and one of you has to interpret the ECG. You can discuss with your faculty. If you are having any difficulty, you have one faculty with you. You can discuss with the faculty. Please go to your respective teams. Whoever has been allotted to some team, please go to the respective teams. Faculties ensure each team there should be around 14 to 15. Faculties ensure that you have 14 to 15 candidates in your team. If you don't have, please let us know. How many of you doesn't know your team? Please raise the hand. Please raise the hand. You have signed a registration, no? Behind that one we have written the teams. Please be with them for all these days. Thank you.
Give them a good round of applause and we'll move on to the next team. Rock Beach team. Who is going to be the representative from Rock Beach team? Moving on to the 6th ECG. Yes.
Hello, myself Henry. Looking at the ECG, it has a regular rhythm. It has a regular rhythm. From the rhythm ECG, we can calculate the since it's a regular rhythm, we can calculate the rate with 300 by number of large squares. Since it has 3 large boxes, 300 divided by 3 is 100, so 100 is the rate. And coming on to the quadrant, in the first quadrant, the negative deflection for there's more amplitude for S wave, so it's negative. And hello. In NVF, it shows more amplitude for S wave, so it's also negative. So coming to the quadrant, it's extreme deviation is there.
Yes, rate is correct and answer is correct. What about the rhythm? Rhythm analysis?
Rhythm is not.
Normal. Okay. Okay. Anyone is having any difference of opinion? Any doubt? Everyone is clear? So it is rate is around 100 beats per minute. Rhythm is sinus rhythm and axis is extreme axis deviation. Give them a good round of applause. And next is the serenity beat. Who is going to be representing?
Good morning, my name is Manishwar. I am from Igmc.
Please keep the mic close.
It is a regular rhythm because every RR is equally phased.
No, I don't have.
Going on the rate,
I gave it to
the
somebody.
rate is the number of hard boxes between the two R's, which is 4 hard boxes, hence 300 by 4 is 75 beats per minute. Next is it's a sinus rhythm, non-sinus rhythm, because the rhythm you can see every PA is not following the QRS complex. The rhythm should.
Some periods are not being followed by QRS complex. Yes, it is a non-sinus rhythm.
Next axis and lead one it's positive and AVF is negative, hence left axis deviation.
Yes, it is correct. Any other doubt is there? Give them a good round of applause and next team. Please interpret the ECG number 8.
Mic or
Interpret the ECG number. This is a regular rate is around. Hello. I'm Shavan. I'm going to interpret the ECG number 8. So this is a regular rhythm because all the periods are followed by QRS and QRS is preceded by P. And in lead 2 and lead 3, the P waves are positive, and then AV R it's negative. And the rate is around 100 because it's regular. I use to calculate 300 by the number of boxes. It's 3. And in lead 1, it is axis is right axis deviation. Rate is 100. And the axis is right axis deviation because in lead 1 it is negative and in AVF it's gone. So the net is 0 to -3.
Who is going to be the representative from Bharati Party?
So, my name is Dr. Felix Andres. I'm representing Bharati Party. So, this is a ECG is showing irregular rhythm. Rate will be around 108 because the rhythm strip it shows 12 R waves. 18 R waves, inter 6 will be 108. And the axis is normal axis. And coming to the, this is not a normal sinus rhythm because P waves are not present in all P waves are present, but not all QRS complexes are preceded by P wave, and There are some PRS without a P wave, and P wave is of different morphology in the rhythm strips, and the heart rate is not 60 to 100. So this is not a normal sense.
Yes, good. So the last ECG to be interpreted by Auroviti.
I'm moving from Auroviti. The ECG strip shows normal sinus rhythm. The PVA morphology in each strip is normal. Each PVA is followed by a QRS complex. Each QRS complex is preceded by a PVA. The rate is 75 beats per minute.
There are approximately 4 large boxes to RA, so yes.
And axis deviation is right axis deviation.
Can you tell why also?
Yeah, lead one, the QRS complex has negative deviation and the AVF is positive.
So it is right axis deviation. Yes, that is. Anyone has had any difference of opinion, any doubts? Please give them a good round of applause.
Thank you, Dr. Anushka. It was an excellent session. We will go to the next session.
Some of the teams had some doubt regarding doubt regarding this ECG error. So if you are having QS complex also, you should take it as a QRS complex. If you are not having any positive result. So in this, many had doubt it is all QS complex, so where will we find R wave? Even if R wave is not there, you should take the QRS complex. Like, if it is QS complex, you take the QS complex and calculate the heart rate. Clear?
Clear, everybody? We'll go to the next session. See, please don't change your teams. You will remain in this team till the end of the day. Understood? Please don't shuffle yourself. We'll have inauguration also. During inauguration also, you can sit as a team. Please don't shuffle. Thank you. Faculties, make sure that they don't shuffle. Please remember your team members. Thank you.
Thank you, Dr. Anushka ma'am. We'll move on to the next session. It will be on chamber enlargement, and I would like to request our speaker, Dr. Praveen Kumar, Senior Resident of Emergency Medicine, Igmc, Karaikal, to kindly come on to the dais.
And relax. I'll make sure that I'm not going to say anything new. I hope that each and every one of you know what I'm going to say in this upcoming slides. What is my role here is, I'm going to make sure that whatever you know has been kept in proper places. so that you will end up in diagnosing RVH. That's it, as simple as that. So, what is RVH? What is RVH? Right ventricular hypertrophy. Okay, fine. So, before this session, what are the waves in ECG which have been discussed here? What are the waves we have in ECG? P, QRS, then P waves. And one segment we have discussed. What is it? ST segment. So, in RVH, we expect to find ECG changes in these 3 waves and ST segment. Okay? Fine. So, if we are suspecting that patient is there in RVH, I can expect abnormalities in QRS complex, abnormalities in P waves, abnormalities in ST segment, and abnormalities in the T waves. Okay, sir, I could not remember all these 3. Please say one thing which is very important. If you ask me that, I can say QRS complex is very much important, because nearly 90% of RVH cases we can diagnose only by looking at QRS complexes. Okay, sir, you said that QRS complex is important. What are the findings which we expect in QRS complex? There are nearly some 10 to 12 findings in QRS complex which suggest RVH. So, not all those are important, only 2 findings are important. With the 2 findings, nearly 100% of RVH ECGs will be having those 2 findings. So, what are those 2 findings? Anyone?
Reversal of RS ratio.
Yes, right, in B1. He is right. There are 2 changes which is most important. One is right axis deviation. Okay, right axis deviation. Second thing is positive QRS complex in V1. Right? So, can you repeat it please? Yes, right axis deviation and positive QRS complex in V1. Nearly in 99% of RVH ECGs we can see these 2 findings in ECG. Okay, so what is right axis deviation? And we have discussed extensively in the last session how to find the axis. I am not going into the detail of that, I am just going to give a glimpse of it. So normally heart lies in the center of the chest, slightly towards left. Okay. So now what happens? Due to some abnormal pathology, right heart enlarges. When right heart enlarges, what happens? It takes more space in the right side of the chest. Right? So normally the current, which segment of heart produces the current? SA node. That everyone of you know, right? SA node, since in normal people, left ventricle plays the major role. Left ventricle is larger than right ventricle. So most of the current from SA node goes towards left ventricle. Okay, whereas in right ventricular enlargement, the current goes towards right ventricle. That is the issue here, because right ventricle is getting enlarged. So how to find the right axis deviation in the ECG? See, this is the cardiac axis picture. So ECG is being taken with 12 leads. We have 6 chest leads and 6 limb leads. In the 6 limb leads, we have 3 augmented leads and lead 1, 2 and 3. So totally we have 6 limb leads. This limb leads monitors the heart in vertical direction, in vertical 360 degree, right? So in this 2, 3 AVF leads monitors inferior wall of heart. Left heart is monitored by 1 and AVF. So if I am saying that most of the current from SA node travels towards right side of heart, in which lead we expect changes? 2, 3 AVF. 2, 3 AVF monitors inferior part of heart, at the same time they monitor right side of heart also. We can see that. See, lead 3 and AVF are towards right side. And lead 2 overlaps between right and left, but mostly towards right side. So if patient is having right ventricular hypertrophy, we can expect changes in 2, 3 AVF. And patient is having left ventricular hypertrophy, we can expect changes in 1 AVF. The current which starts from SA node has to travel in this direction. Okay. If left ventricle is getting hypertrophic, current travels in this direction. So 1 AVF becomes positive. If right ventricle is getting hypertrophic, current travels in this direction. So 2, 3 AVF becomes positive. When a current travels towards a particular lead, that lead will show positive QRS deflection. When current travels away from a lead, that lead will show negative QRS deflection. So, in right axis deviation, if patient is having right ventricle hypertrophy, I said the current from SA node travels towards right side of heart. So, 2-3 AVF will be having positive QRS complex. At the same time, the current travels away from one AVF, right? Current travels like this. It's not going to one AVF. Since current travels like this, in one AVF I will be expecting negative QRS complex. So, this is right axis deviation. 2-3 AVF, I will be having positive QRS complex, and 1 AVF, I will be having negative QRS complex. The reverse happens in left ventricle hypertrophy. Okay, so this is right axis deviation. So this is the first important change which we expect to find in QRS complex in patients with RVH. Fine. Then, second important finding is very simple. Positive QRS complex in V1. I said no, we have 6 chest leads, V1 to V6. V1 is placed in right side of heart. V2, V3, V4, V6, everything is placed in left side of heart. Since V1 is in right side of heart, current travels towards left right. So V1 will be having negative QRS complex in normal persons. If right ventricle is getting hypertrophied, what happens? Current travels towards right side of heart. Since V1 monitors right side of heart, V1 also will show positive QRS complex. Right? That's why we have positive QRS complex in V1. So these are the two important findings which I expect you to know so that we can diagnose RVH in most of their patients if they have. Right? What are those two findings? Repeat. Positive R wave in V1 and right axis deviation. The rest of findings more or less they are same. See QR complex in V1. We have initial negative deflection that we say it as Q, small q. Then we have tall R wave. Okay. If you are not able to remember, just keep in mind positive QRS complex in V1. Okay. In the previous slide, I told the positive QRS complex. In other words, we can say like dominant R wave in V1. They are given some values. I don't want you to remember those values. Just remember positive QRS complex in V1. Then S1, S2, S3 pattern in adult patients. It's also very simple. It's not difficult. So we have seen right axis deviation. So what happens when right ventricle is severely hypertrophied? All of our current goes towards right shoulder, right? Because right ventricle, if it occupies more space in the right chest, current travels towards right shoulder. This results in extreme axis deviation. So when the extreme axis deviation occurs, current travels like this. Okay, so normally current has to travel like this. When right ventricle is hypertrophic, current travels like this. So 2-3 AVF becomes positive. When right ventricle is severely hypertrophic, current travels towards 150 degree, minus 150 degree. This results in positive AVF. Whereas 2, 3 AVF, 1 AVL, everything will be negative. Okay. This we say it as S1, S2, S3 pattern. This is you will be able to see. See in lead 1. In lead 1 we have predominantly negative QRS complex and S wave is bigger here. And in lead 2 also S wave is bigger. Lead 3 is predominantly positive. S1, S2, S3 pattern is nothing but out of these 3 leads, any 2 leads should be predominantly negative. That we say as S1, S2, S3 pattern. And in this patient you see AVR is predominantly positive. Okay, so this is in other words extreme axis deviation. In most of the extreme axis deviation patient, if you see, you will be finding S1, S2, S3 pattern. This is again RS R dash pattern or RBBB only in V1. Not the entire ECG should have RBBB. Only V1 should show RBBB pattern. This is again positive QRS complex in V1. For the positive QRS complex in V1, we have different configurations. QR pattern, tall R wave, RS R dash pattern in V1. So everything says the same. In V1, QRS complex should be positive. So when patient is having right ventricle hypertrophy, this is a bit complicated, but okay, fine. I'll try to explain as simple as possible. When patient is having right ventricle hypertrophy, heart rotates in clockwise direction. When heart rotates in clockwise direction, we will be having negative QRS complex in V1 to V6. But patient will be having right axis deviation. 2, 3 AVF will be positive. Whereas in V1 to V6, patient will be having predominantly negative QRS complex. Okay, when this is there, then it suggests the clockwise rotation of heart. Once again, it suggests RVH. So Regarding QRS complex, we have discussed. So what are the two important findings which I have said to you in QRS complex? Right axis deviation, then positive R wave in V, positive QRS complex in V1. Okay, rest all findings superimpose on these two findings only. Either patient can have right axis deviation or extreme axis deviation and positive QRS complex in V1. Okay, these are the abnormalities which we expect in QRS complex in RBH. What is the abnormality we expect in P waves? It's very simple. It has been discussed by Surinder sir also and by Dr. Anusha also. See, when patient right ventricle is getting bigger, right atrium also gets enlarged, right? Because the pressure is getting transmitted to right atrium also. See, atrial depolarization is monitored by P wave. P wave represents atrial depolarization. When right atrium is enlarged, the height of P wave becomes more than 2.5 small boxes. Small boxes, 2.5 mm or 2.5 small boxes. This we say as P pulmonary. See this P wave crosses maybe some 4 small boxes. Right? So this we say as P pulmonary. When patient is having P pulmonary, again it suggests RVH. What are the other findings we have in this ECG? P pulmonary is there. Other than that, any abnormalities in QRS complex? Anyone can comment about axis? Right axis deviation. See, 2, 3 AVF, it is positive QRS complex. 1 AVF, it is negative. And predominantly patient has positive QRS complex. It is looking like biphasic, so you are getting confused, I feel. It is positive QRS complex in V1, so it suggests RVH. If still you are having doubt whether it is like a positive QRS complex or negative QRS complex, you can take ratio of negative wave and positive wave. If the ratio is more than 1, then it suggests a dominant positive QRS complex. Okay, fine. Now we have discussed the abnormalities in QRS complex and abnormalities in P waves. Now I am going to ST segment and D waves. Okay. If patient is having ischemia, which segment of heart will show the change? Ischemia, ACS, MI, NSTEMI, which segment of heart will show the change? ST segment. So whenever heart is having any ischemia, or in other words any strain, ST segment and T waves will show the change. Similarly, when the right side of heart is getting enlarged, what does it mean? The right side of heart is getting strained much. So which are the leads monitoring right side of heart? We have discussed that already. 2, 3 AVF and lead V1. In all these leads, we can expect ST depression and T wave inversion. This is RV strain pattern. Okay? Fine. So it's easy, right? When patient's heart is having any strain or ischemia, we expect changes in ST segment. When right ventricle is getting hypertrophy, right ventricle is getting strained, we expect changes in the leads which monitors right side of heart, that is 2, 3 AVF and V1. So we expect ST depression and T wave inversion. Sometimes the T wave inversion can extend up to V6, but definitely we will be having changes in 2, 3 AVF and lead V1, which dominantly monitors right side of heart. Right. So what is there in this ECG? It's very simple. Just to look at the QRS complex. Right axis deviation is there. Positive QRS complex in V1. Positive QRS complex is in V1. Okay. So positive QRS complex in V1, right axis deviation, and P pulmonary is also there. P pulmonary is also there, and you can see that I said already 2, 3 AVF monitors right side of heart. In 2, 3 AVF you can appreciate ST depression and T wave inversion in lead 3. The lead AVF has minimal ST depression and lead 2 has ST depression. And you can see in lead V1 it has ST depression and T wave inversion. The T wave inversion extends up to V4. Right? So all this points towards RVH. So what is there in this ECG? Axis. Then what else? Positive R wave in V1. So positive QRS complex in V1. Positive QRS complex and right axis deviation is equal to RVH, as simple as that. This is what I want you to know. That is the motto of our class. Okay, positive x-axis deviation with the positive QRS complex in V1 suggests RVH. Right. And again, in the ECG also, in 2, 3 AVF, we have ST depression and T wave inversion. In V1 also, you have T wave inversion. The T wave inversion extends up to V4. So, this is strain pattern. And the P pulmonary is not seen in this patient. Okay. Thanks.
Request our dignitaries to kindly come forward and light the Buddha Vilaka. Request Dr. Surendra, Organizing Chairman, and Dr. Ashwin, Organizing Secretary, Eimhtyhrra, to kindly come forward and honor our esteemed dignitaries. I request Dr. Surendra sir to honor our Director sir. I request Dr. Ashwin to honor our Dean, Dr. Ramachandra Bhatt. I request Dr. Jafrin sir to kindly come out to the dais and honor our PO sir. Dr. Surendra sir to honor our PRS sir, Dr. Rajesh. I request Tyagarajan sir to kindly come forward to the dais to honor our RMO sir, Dr. Arun sir. I request Dr. Ashwin sir to honor Arun sir. I now request all our esteemed dignitaries to kindly honor our faculty members for the day. I would like to first call upon Dr. Ramesh. Sir has done his post-graduation and senior residency in emergency medicine from Igmc, and his areas of interest are critical care and trauma, and currently he is consultant at ESI Hospitals, Hyderabad. I request Dr. Anusha ma'am to kindly come out to the dais. Ma'am has done her post-graduation from Igmc and she is working as a senior resident in Igmc. Dr. Praveen Kumar, he has done his MD from Igmc and he is now senior resident at Igmc Karaikal. His areas of interest are ultrasound and emergency medicine.
Central.
Rajeshwari Kage, madam has done her MD from Igmc and is now working as senior resident in emergency medicine at SMBMCH.
Madam.
Now I request our Dean sir to kindly felicitate our faculty members. Dr. Amaravati, madam has done sir has done his PG from Igmc and his areas of interest are ECG, airway and cardiovascular emergencies.
Sir.
Dr. Tirumurthy, sir has done his post-graduation from Igmc and is now working as senior resident at SLIMS.
Sir.
Dr. Balaji Shah, he has done his post-graduation from Igmc and his areas of interest are airway, management and resuscitation.
Sir.
Dr. Ajay is consultant in emergency medicine in Holland, America line. Sir will be joining us today via Zoom. Next is Dr. Eril Gugan. Sir is senior resident of emergency medicine in Igmc and his areas of interest are emergency cardiology.
Sir.
Dr. Kumaresh, sir is assistant professor in KIMS. Sir is right now not here with us. He will be joining us in the afternoon session. Dr. Gunaseelan, assistant professor, ABMCH. His areas of interest are emergency cardiology and simulation.
Sir.
Dr. Sasi Kumar, sir has done his post-graduation from Igmc and his area of interest is ultrasound and emergency medicine. Sir has done his PG from BG Medical College, Ahmedabad, and his areas of interest are ECG, trauma, and toxicology.
Sir.
Dr. Raja has done his post-graduation from Aimhtyhrra University, Chidambaram, and his area of interest is critical care and emergency cardiology.
Sir.
Dr. Divya, madam is right now working as senior resident in SLIMS and she has done her post-graduation from Aimhtyhrra University, Chidambaram, and her area of interest is intensive care.
Madam.
Dr. Avinash Anand Raj, sir is associate professor in Igmc. He has done his post-graduation from Igmc and DM in cardiology. Sir will be joining us in the afternoon session. Dr. Surendra, assistant professor of emergency medicine, has done his post-graduation from Igmc and his area of interest is basic resuscitation and skill stimulation.
Sir. Sir. Sir.
Dr. Ashwin, assistant professor of emergency medicine, his area of interest is trauma and critical care. Thank you. Now I request our dignitaries to reveal the first copy of our handbook, EM Arrhythmias. I now request all the faculties to kindly come onto the dais to release the first copy. I request all our expert faculty members to kindly come onto the dais.
Closer. Request our RMO, Dr. Arun sir, to kindly address the audience.
Hello, welcome, good morning everyone. I think the topic for today is very important unless you are a surgeon. So I am a surgeon, so I am not that much into ECG. until I got my MI. Okay, so it's very, very important. You should know what is an ECG and how to read an ECG. Okay, it will be very critical when all of your relatives will be coming with your piece of paper telling you to interpret the ECG, and they'll be having a lot of doubts to be cleared out. That's how it started. So in my time, maybe 15 years back, when we are doing our internship, we used to go in the night by 10 to 12:30 will be the classes for us. We will catch hold of some assistant professor from the Department of Medicine to teach us ECG. That's how it was going around during that time. Now we have made the things simpler with our people here. So I think you will be using the opportunity wisely and learn ECG before it is too late. Okay, thank you. Wish you all success for the easy conduct of the program. Thank you all.
Thank you, sir. I now request our Dean, Dr. Ramachandra Bhatt, sir, to kindly address the audience.
Good morning, everyone. Beloved Director, dignitaries on the dais, faculty members, and all the delegates. It's my pleasure to be part of this, the inaugural function of this particular very important CME or workshop on arrhythmia or electrocardiogram. So this is the month of May, Saturday. So in morning to evening there is today we are having program, and I am very happy to see so many delegates here on Saturday in the month of May. So that indicates how much eager, how much your hunger for the knowledge to improve your skills. And I am very sure today's program, looking at all the resource persons and the book they have released, so everything indicates it will be very fruitful, and definitely you will gain from today's workshop. I wish all the best, and this juncture I would like to appreciate our young team of emergency medicine, Dr. Surendra, Dr. Ashwin, and his entire team for organizing this event. So in the last 7-8 months, this is the third program they are conducting. One, the emergency medicine conference, followed by workshop on disaster management, and today this workshop. So really appreciate them and wish all the success for today's program. Thank you.
Now I request our Director, Dr. Uday Shankar, to kindly come forward and address the gathering.
Good morning, everyone. Respected Dean sir, MS sir, RMO sir, AO sir, and the audience, various faculty members who come from various parts of India. A very good morning to one and all. So, at the outset, I'd like to congratulate the Department of Emergency Medicine to organize this wonderful CME program. Like our Dean sir said, it's a young and dynamic team, and they keep organizing such important programs so that a lot of young budding doctors get to benefit. So a lot of things are mainly hands-on workshop kind of thing. And even if you see their faculty members who they are inviting, they are also very young and dynamic. So you can learn a lot from them. As Arun, our Armo said, ECG may not appear to be very important if you are not in the medicine, cardiology, or emergency medicine field. But it is a very common diagnostic thing, and most of our family members, they will come and show the path solunga, and it will look like Greek and Latin to us. Because only thing probably we will remember from MBBS days will be ST depression, elevation. If you ask to suddenly calculate the heart rate also, we will struggle. Everything we would have learned, but we would have forgotten, because once you do not keep in touch with the subject, you do not keep going through it again and again. Whatever you learn, you will tend to forget. So I wish the workshop, this CME program, a great success, and wish all of you a good learning, and take home message will be keep reading ECGs, keep on reading them so that you will be well versed in them. Thank you.
Thank you, sir. I now request Dr. Surinder to kindly deliver the vote of thanks for the day.
Very good morning to all. I would like to thank our director, Dr. Uday sir, who has been supporting from the day one we have joined this institution. And it is out of the support that we are getting DNB emergency medicine shortly. And we are organizing these events because of this support. Thank you, sir. And next is our Dean, Dr. Ramchandra Bhatt sir. Sir, thank you for being very supportive in conducting all the academic events here. And sir has been also supportive in getting us DNB emergency medicine. Thank you, sir. Next, Dr. Arun sir, our in-charge resident medical officer. Sir has been very supportive from day one for organizing all the events. Thank you, sir, for being with us. Thank you, sir. Next is Dr. Rajesh sir, our deputy medical superintendent, in-charge medical superintendent. Sir has been with us with all the medical legal aspects, and sir has been very supportive over the period of time. Thank you, sir. I would like next thank my faculties who have come all over from different places, who have taken leaves, and then they have helped us in making this wonderful booklet that we are going to release today. I thank all the faculties, and I personally thank Dr. Ajay, who has been working for us from the ships for making this wonderful booklet. I thank you, Dr. Ajay. And I would like to thank the organizing committee, Dr. Soumya, Dr. Ayyappan, Dr. Pushparaj, and other team members, whoever I left, just forgive me because of time. I'm leaving everybody. So thank you all, and above all the participants and the continuous support that you give to us. Thank you. Thank you so much. Thank you.
Thank you, sir. I request everyone to kindly raise up for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
We'll now go for a small break. We'll be back here by 12 o'clock. Refreshments are served outside. I request all the delegates to kindly move out. left ventricular hypertrophy in ECG. So in the previous lecture we learned about right ventricular hypertrophy. So whatever changes you see in right ventricular hypertrophy, opposite to that you will find in left ventricular hypertrophy. Okay. So what is left ventricular hypertrophy? Left ventricular hypertrophy is basically increase in the left ventricular mass. Okay. So it could either be increase in the chamber size or it could be increase in the muscle mass. In simple terms, what happens when the workload of the heart increases? So LVH is not a disease. It is secondary to some underlying pathology. It is a compensatory mechanism. So when the workload of the heart increases, it compensates by increasing its size, and that is termed as left ventricular hypertrophy. So there are n number of conditions which increase the workload of the heart and which result in left ventricular hypertrophy. The most common causes which result in LVH are hypertension and valvular heart disease like aortic stenosis, aortic regurgitation, mitral regurgitation, and dilated cardiomyopathy. So now, in ECG, what does the QRS complex represent? The QRS complex represents the phase of ventricular depolarization, and the T wave represents the phase of ventricular repolarization. Okay, so looking at some principles of ECG. Okay, so when you take a lead, okay, for example, you take lead 2. Okay, Praveen discussed that Aimhtyhrra triangle, no, one circular diagram. Okay, so the lead 2 is located at 60 degrees. Okay, so in ECG, if the vector of depolarization is towards the lead, then you will get a positive wave. If the vector of depolarization is away from the lead, then you get a negative wave. And if it is perpendicular to the lead, then you will get a biphasic wave. Okay. So now you look at Q wave. Okay. Q wave is negative. Q wave represents the depolarization of the septum. So this is the vector. Okay. Lead 2 is, this vector is away from lead 2. So you get a negative wave. So we will get a negative Q wave. Now the depolarization of Purkinje fibers, myocardial and endocardial fibers, the vector is towards lead 2. So you get a positive R wave. Okay. So wherever there is vector of depolarization towards, if it is towards the lead, you get a positive wave. If it is away from the lead, you will get a negative wave. Now see, normally the resultant vector. Okay. This is the resultant vector of depolarization. You take lead V3 and V4. So this lead V3 and V4 are perpendicular to this vector. So in lead V3 and V4 you will find biphasic waves. What happens in left ventricular hypertrophy? In left ventricular hypertrophy, the left ventricular mass is increased and the muscle mass is increased. So because of the increased muscle mass, the vector is shifted more leftwards. So it is moving away from V3 and V4. So in V3 you will find more negative waves because you will find the S waves. So this is the pathophysiology. So normally the QRS complex is hardly 1.5. The amplitude of QRS complexes are hardly 1.5 to 2.5 large boxes. But when the myocardium is hypertrophic, the muscle mass is increased. So the amplitude of R waves and S waves are increased. So in left ventricular hypertrophy, you will find large S waves, large R waves. Now, what will happen? You look at lead 1, lead 3. What is lead 1? Lead AVL, lead V5, lead V6. What are you seeing? You are seeing tall R waves. So these are your left-sided leads. So in your left-sided leads, you will find tall R waves, and in your right-sided leads, like your V1, V2, lead 3, AVR, you will find tall S waves. Okay, so this is seen in LVH. You will find tall R waves in left-sided leads and tall S waves in right-sided leads. pattern. The strain pattern, Praveen has already discussed, no? As the right ventricle gets strained, similarly, your left ventricle also gets strained. So when the left ventricle gets strained, you will find some secondary depolarization changes. You will find downsloping ST segment with inverted T waves. Okay, so this is the second change. Now this secondary depolarization changes or strain pattern are seen in number of conditions. You find it in right ventricular hypertrophy, left ventricular hypertrophy, LVVB, RVVB, which will be discussed in next sessions. Okay, and even in your acute coronary syndrome, your MI, M-STEMI, you will find ST depressions and T wave inversions. So many a times it becomes difficult to differentiate whether this ST depression and T wave inversion is because of strain or it is because of acute coronary syndrome. Now, how to diagnose LVH in ECG? We learned about the changes. So there are numerous criteria to diagnose LVH in ECG. So basically, what they are telling is they are measuring the amplitude of the waves in leads. Okay, so we have voltage criteria and we have non-voltage criteria. Okay, so for example, we look at R wave in AVL. So if the R wave in AVL is more than 11 mm, approximately more than 2 large boxes, then it is LVH. Okay, so out of these two, we will discuss the most important criteria alone. So now, some people have combined these criteria. So these are single lead criteria, no? So these single lead criteria, 2 or 3 criteria are combined together and they are given names. Like Sokolow ion, Cornell, Framingham. Okay, out of which the most important one, which we use in clinical practice is Sokolow ion. So we will be discussing about Sokolow ion and Cornell criteria. So what is Sokolow ion criteria? So what we do is, you take your lead V1 in ECG. In the lead V1, we measure the depth of S wave. So one large box is 5 mm. Okay, so we measure the depth of S wave in lead V1, and we measure the amplitude of R wave in lead V5 or V6, whichever is the tallest. And if the sum of these two waves is more than 35 mm, approximately 7 large boxes, then it is left ventricular hypertrophy. The next criteria is Cornell. So what we do in Cornell, they took the R wave in lead AVN. Okay, so they counted the number of boxes in AVN. So the R wave in AVL is 9 mm, whereas the S wave in V3 is 20 mm. The sum of these two is 29 mm, which is around 6 large boxes. So if it is more than 6 large boxes, then it is satisfying the voltage criteria of left ventricular hypertrophy. So we will go with some examples. So a 40-year-old male walked into ED with complaints of dizziness and profuse sweating. So this is the ECG. So from looking at the ECG, what is your first impression? You are finding big waves. Okay, so you have big R wave, big S waves. Okay, so when you are applying Sokolow line criteria, the first lead we look into is your V1. Okay, so V1 we look at the S wave. So it is covering how many boxes? Approximately 4 boxes. Okay, so the first in V1 the S wave is 4 boxes. Next we look at V6. V6, the R wave is covering how many boxes? 6 boxes. So the total number of boxes are 10. So it is more than 7. Okay. So the S wave in V1 and the R wave in V5 or V6, if it is covering more than 7 boxes, it is crossing more than 7 boxes of 35 mm, then this ECG is fitting the voltage criteria, the Sokolow line criteria. Next is your Cornells. So in Cornell, we look at which leads? We look at lead AVN. Okay, we will measure the R wave in AVN and S wave in V3. So the R wave in AVN is 2 small boxes, it is 2 mm. The S wave in V3 is 6 large boxes. Okay, so the total amplitude is 32 mm, which is more than 28 mm or more than 6 large boxes. So this is again fitting the LVH voltage criteria, which is the coordinates criteria. Now, in this ECG, coordinate criteria is getting filled. Circular line also is satisfied. But when you look at the R wave in AVL, one more criteria is R wave in AVL should be more than 11 mm. Okay, so it is not necessary that all the criteria should fit to tell it is LVH. The more the number of criteria that satisfies, the more probability of LVH. Now we learned about the non-voltage criteria. We learned about the voltage criteria. Now let us look into the non-voltage criteria. So non-voltage criteria are basically your secondary repolarization changes, ST depression and T wave inversion, and the second criteria is your increased R wave peak time. So what is this increased R wave peak time? So this is the time duration to reach the peak of R wave. Okay, so from the start of the Q wave to the peak of the R wave, we measure these times. Okay, so this is called as ventricular acceleration time, or it is called as intensity called deflection, or it is otherwise called as R wave peak time. All the three are the same. So if normally this ventricular acceleration time VAT should be less than 50 milliseconds. If it is more than 50 milliseconds or more than one small box is 40 milliseconds. So if it is more than one small box, that means the R wave peak time is increased. So these are the most common changes in LVH. Some additional changes are, you can find left axis deviation, left atrial enlargement, left bundle branch block, ST elevation in V1 to V3, and sometimes prominent U waves. So again, summarizing. So what is happening? In the left-sided leads, your lead AVL, lead V5 and V6, you are finding tall R waves. In the right-sided leads, like your lead 3, lead AVR, lead V1 and V2, you are finding tall S waves. Okay, so these are the first changes. Second changes is your secondary repolarization change, which is your strain pattern. So again, in your right ventricular hypertrophy, you will find strain pattern in the right-sided leads. In the left ventricular hypertrophy, you will find strain pattern in your left-sided leads. So which are the left-sided leads? 1, AVL, V5 and V6. So you will find ST depression and T wave inversion. ST depression with T wave inversion. ST depression with T wave inversion. So this is the strain pattern. Now we solve one example. 80-year-old male comes with complaints of dizziness for 1 day, intermittent chest pain and breathlessness for 2 hours. So this is your ECG. Now you are going to answer. So what are you seeing in this ECG? What is the first impression when you look at this ECG? Tall R waves and deep S waves. Okay, so there are tall R waves and deep S waves. So let us look at the lateral leads. Which are your lateral leads? 1, AVL, V5 and V6. So they have tall R waves. Your right-sided leads. Which are your right-sided leads? Lead 3, AVR, V1 and V2. You are finding deep S waves. So you have deep S waves in your right-sided leads, tall R waves in your left-sided leads. And then you have strain pattern in your left-sided leads. So your lead 1, AVL, V5 and V6, you are finding ST depression with T wave inversion. Okay, so in this ECG, then you apply your circular and coordinate criteria, and then you tell that this ECG satisfied the voltage and non-voltage criteria for LVH. So now this is a 80-year-old male who has come with breathlessness for 2 hours. So in ECG you are finding LVH, but LVH is not a disease. From LVH you are supposed to find out what is causing that LVH. So what could be the differential diagnosis from this ECG? 80-year-old male, he could be having hypertension. 80-year-old male, again he could be having aortic stenosis. 80-year-old male with chest pain. Most common pathology, what do you consider? ACS. acute coronary syndrome. Okay, so these ST depressions could be because of end-stage. Okay, so this can be ruled out only if you do detailed clinical examination, history, and your echocardiogram. So only from ECG you can tell that this patient is having LVH. But to find out the pathology, you have to do further investigations. So one more clue is like your strain pattern. No, strain pattern is usually present in your left side leads. So like your lead 1, AVL, V5, V6. So here in this lead V3 also you are finding some ST depression. So again there is a high possibility of ACS. So you have to do your biomarkers and echocardiogram. So it is actually clinically very difficult to differentiate, but they tell that the T-wave inversion in every strain is usually asymmetrical, blunt and not very deep, but the ischemic T-wave inversions are symmetrical, pointed and deep. So if you want, you can differentiate it this way. Thank you.
Thank you, ma'am. Now I request Dr. Amravati, Senior Resident of Emergency Medicine, Igmc, to kindly come on to the dais. Sorry, Dr. Tirumurti R, Senior Resident of Emergency Medicine in SLIMS, will be giving the next talk. Okay, we'll go with the simulation session now. I request Dr. Praveen and Dr. Rajeshwari ma'am to come forward.
Faculties, please go to the respective stations. Apply same. Arvind Ashram is 1, White Town is 2, and New Lighthouse is 3. Paradise Beach is 4. Chunamba is 5. Rock Beach is 6. 5 plus 5. Yeah. Okay. C1 வந்து 1 C1 will be Arvind Ashram, C2 will be White Town, C3 will be New Lighthouse, C4 will be Paradise Beach, C5 will be Chunamba. Next you directly jump to C11. C11 is Rock Beach, C12 Serenity Beach, C13 Pondy Marina, C14 Bharati Park, C15 Orwell. Clear? Yeah, 5 minutes time for you.
From rate is an access. Rate here it is 100, complete large boxes. Then rhythm is regular because P followed by QR and all those the same. So rhythm is regular. Then coming to axis, one it is showing negative and in AVF it is positive. Since they are reaching each other, it is right axis deviation. And other things sir told me that there is prominent RV, so that also points towards right ventricular hypertrophy. And we can also see this that strain pattern in V1, V2, V3, that is ST depression and TDF inversion and in V1, V2, V3, that is also present. And the leads 2, 3 and APF we see positive, and in 1 and AVL we see negative. So all points towards right ventricular hypertrophy.
Good. Nice.
White Town. Next sheet. Who wants to volunteer?
So it's right into the hypertrophy because tall always is seen in V1 and deep is seen in V5, V6 leads. It's extreme axis deviation and S1, S2, S3 pattern is also seen. Its rhythm is normal, regular intervals. So nearly it's covering 4 to 3.5 boxes, that is 100 to 70 beats per minute. Then axis deviation is extreme axis deviation is seen because 1 and AVF are both in negative, so extreme axis deviation. P bundle is also
Some other person from the team already shares that for last time. Some other person. Sir, regular rhythm, heart rate around 73-80. PA is positive in leg 2 and a bypassing P permanent V1 and a negative AVR. And right axis deviation. V1 is negative and the AVF is positive reflection. And prominent R wave in V1. So right hand is correct.
Lead 1 shows negative R wave and AVF shows positive. Other station is more than V1. E wave inversion and S infiltration in inferior leads and anterior leads are seen, showing right ventricular hypertrophy.
As he said, this ECG has right ventricular hypertrophy because right axis deviation is there and RF ratio in V1 is more than 1. And there is a strain pattern also in V1, V2, V3, 2, 3, VF. So number which who wants to volunteer?
Please introduce yourself.
Myself, Bhuvaneshwari from Igmc. Right axis deviation is presented in lead 1. V1 QRS complex positive, right ventricular hypertrophy.
Lead 1 and AVF shows negative QRS complex, and comparing lead 1 and AVF, 1 is negative and AVF is positive, so it shows right axis deviation. And as you said, QRS is positive in V1, so it goes in favor of RDH. Good.
Next finger. 11, C11. Rock pitch. Rock pitch is C11. Yes.
It is sinus rhythm. The axis is normal and
and the heart rate is 16 beats per minute. In V1 the S wave is deep, and in V6 the R wave is tall. Together, counting the large boxes, there are around 10 boxes, so it's larger than, more than 7 large boxes. According to Sokolow life criteria, it is less ventricular ventilation. Along with that, you have your secondary LV strain pattern in your lead 1 and V6 is LV strain.
Okay, give a round of applause. C12.
C12, the ECG interpretation. Then in the first ECG, the rate was 100 beats per minute, regular rhythm. Then it shows ventricular hypertrophy as it fulfills Sokolow criteria, where the S wave in V1 and R wave in V5 exceeds more than 35 mm. Next, it doesn't fulfill Sokolow criteria, but in the next ECG, the heart rate is 65 beats per minute, regular rhythm, and it meets Sokolow criteria and Karman's criteria. And secondly, LV strains.
What is the axis?
Normal axis.
So you have normal axis with left ventricular hypertrophy. Next, ECG 3.
Morning, Verena.
G. Hemalatta from Pandi Verena. Heart rate will be 60. Then P wave is followed by QRX. QRX will be narrower, normal axis rhythm. Then ST elevation from V2, V3 and V4. Hyperacute under level of myocardial infarction.
Other changes.
V1 and V5 is the LDH.
So you have. So what is there in the ECG? How much is the heart rate?
Heart rate 60.
Heart rate is 60. Is it sinus rhythm or not?
Yes.
Normal sinus rhythm. What is the axis?
Normal axis.
Normal axis. So whenever you read an ECG, you should not directly tell the diagnosis. You should start with rate, rhythm and axis. So rate, rhythm and axis. Additionally to this, what you are finding? You are finding tall waves, right? Tall R waves in V5, V6, 1, lead 1, and deep S waves in V3, V4. Is it fitting the criteria, Sokolow criteria? How? So in your V1, how many boxes it is covering? Count the number of large boxes. S wave.
11.
Huh?
11.
Small boxes, 11 boxes. Large box?
6.
How many large boxes?
2 boxes.
2 boxes. Your V1. V6, how many boxes? V5 you take. How many boxes?
5 boxes.
5. So 5 plus 2. So 7. It is more than 7 large boxes. So this is fitting
Left ventricular.
your left LDH Sokolow criteria. So you need not remember all criteria. One criteria, if you remember, which is routinely in clinical practice, is your Sokolow. So you can apply this Sokolow criteria. Next team.
Give a round of applause. Bharati Bharti.
I'm Dr. Shaiza from Bharati Lab. In first ECG, the heart rate is 75 beats per minute. Deep sinus rhythm, left axis deviation present. According to Karman's criteria, LVH is present. In second ECG, heart rate is 13 into 6, it's 78. irregularly irregular, not in sinus rhythm. Axis is normal axis, no LVH and no RVH.
Last team, Auroville.
Please, you told axis is left axis. Which one? Which one?
Hello, I'm Dorvisa from team Auroville. The ECG given, it's a normal sinus rhythm with rate of around 100 beats per minute and regular rhythm. There is left axis deviation and according to Corner's criteria, Sokolow's, it does not fit the Sokolow's criteria. According to Corner's voltage criteria, they are more than around 30 millimeters, so that fits the Corner's criteria. And modified Corner's R in AVL is more than, it's around 15, it is more than 11. So that is also.
Give a round of applause. Thank you. We go to the next session.
Essentially supplied by, proximally supplied by the RCA, distally supplied by the lady. So this is normal ventricular depolarization. So normal ventricular depolarization reflects as the QRS complex in the ECG. So QRS will have three waves: Q wave, R wave, and S wave. Same as the three vectors which is going to generate the ventricular depolarization. The first vector is a intraventricular septum. So here it marked as a 3. Intraventricular septum, it will receive the Purkinje fibers from the left bundle branch. So once the left bundle branch will give the signal, intraventricular septum will activate. So it will lead to the direction of the conduction towards the left to right. So we are getting the positive wave in the lead V1 and the negative wave in the lead V6. This is the first vector, the activation of intraventricular septum. So second vector is going to be the ventricular free wall. This is the major thing. So ventricular free wall, both ventricle, it will depolarize simultaneously. So right ventricle and left ventricle both will depolarize simultaneously. In the right ventricular depolarization, the vector that resulted from the activation of the right ventricle will not come to the expression. It is getting drowned by the major large vector which is generated by the left ventricle. So ventricular free wall vector, mainly what we are seeing is the activation of the left ventricle. So left ventricular depolarization only, mainly we are going to see right ventricle not come to the expression. The third one is going to be the basal depolarization. Basal depolarization, the direction is showing it is going upward. So there we are getting the, it is away from the lead V1, so we are getting the negative, and it is towards the lead V6, so we are getting the positive. This is how we are getting the QRS. Next we are going to see the physiology of bundle branch. So bundle branch law occurs if bundle branch is dysfunctional and it is unable to transmit the impulse. So ventricle whose bundle is blocked will have to wait for the electric impulse spread from the other ventricle. So if the left ventricle is blocked, the impulse, right ventricle has to give the impulse to the left ventricle. Next one, the spread of impulse after entirely or partly outside from the conduction system, the QRS complex will be prolonged. The conduction system is low, the QRS duration is prolonged. So this is left bundle branch. So left bundle branch is blocked. So intraventricular septum, it won't receive the electrical impulse from the left bundle because already left bundle is blocked. So we are so the initial positive R will be either size will be decreased or it will be absent. So major thing is ventricular free wall depolarization. Ventricular free wall depolarization, the direction is right ventricle has to first activate and generate the impulse, then it will go to the left ventricle. So it will be prolonged. So we are getting the, it is away from the V1. So this is the main thing. In V1 we are getting the negative wave. V1 we are getting the negative wave, that is the S wave. And the V6 we are getting the positive wave. So the QRS duration will be prolonged. And next one, the conduction from right to left is going. So we are getting the negative S wave in the V1 and broad positive R wave in the V6. So this is the ECG. The first I told the conduction is slow and prolonged, the QRS will be wide. So in this ECG, if you see here in lead AVL, this is the wide QRS. The QRS is more than 3 small dots or more than 120 milliseconds. The QRS is wider. Second, you see, as I told in the previous slide, the V1 we are getting the deep S wave, and the lateral is 1 AVL, V5, V6 we are getting the orbit. The dominant S wave is the V1, and you see lead 1 AVL, lateral is V5, V6 we are seeing the broad monophasic positive orbits. So these are the criteria to take the patient traffic LVS in ECG. So first thing is QRS should be wider, more than 120 milliseconds, and dominant S wave should be there in the V1. Broad monophasic orbit in the lateral leads, and absence of QRS in the lateral leads. This prolonged orbit peak time more than 60 milliseconds, which is varying. Some studies are telling it is 50 seconds, more than 50 seconds, like whatever you want. Then this is a specific thing. This is called rule of appropriate discordance. So as soon as we are seeing ECG, we mainly will look for the ST segment. So if ST segment depression or elevation is there, we think it as a patient is having biopsy infection like that. So in LVVP, this discordant is normal. So in normal LVVP, ST segment should be isoelectric or to be in the opposite direction of the dominant part of the QRS. So what I told as in the V1, the QRS will be negative. So in the V1, you are getting the ST segment is elevated. So opposite to the QRS complex, you are getting the ST segment. This is normal for LVP, and the lead V6 also QRS mainly positive, so ST segment depressed. So in this, if you see this ECG, in V1 you see V1 QRS is negative. You see there ST segment is elevated. In the V6, QRS is positive, ST segment depressed. This is normal. This is normal for the left bundle branch. And since left bundle branch block is having anterior vesicle and posterior vesicle, I am going to cover that. What is the left anterior hemivesicular block and what is left posterior hemivesicular block? First we are discussing the left anterior hemivesicular block. So if you see here, this is the anterior hemivesicle. So anterior hemivesical block. Once the anterior hemivesical block, this is the first direction. Your initial vector is going to be the direct towards inferior. This is the lead 2 and area, 2, 3 area. So direction of the initial vector towards inferiorly, it is coming through this. So in the inferior leads, you are getting initial positive deflection. 2 you are getting positive deflection, A you also are getting positive deflection. And it's away from the lead 1 and area. So there you are getting negative. If you see here you are getting the positive, and here you are getting the negative. The major vector which is second, here it's not a second, this is going towards the leftward, upward and backward. You see here, it is going left, up and backward. So it is going towards the one area. There you will get this is the major vector. So the QRS will be the same direction. So there you are getting the positive. So in one area you are getting the positive deflection, 2, 3, next one you are getting the negative deflection. So initial vector will be directed inferiorly. So small positive deflection in 2 area and the negative deflection in the 1 area. The second major vector is considered stronger and is directed towards the left and back and upward. It will produce a strong negative deflection in the 2, 3 area and the positive deflection in the 1 area. So inferior leads will show RS complex. This is R way, this is S way. And the lateral leads will show QR complex. So this is diagnostic of left anterior hemivesicular. This only you remember these 2 directions. Initially it is inferior, next is going left and upward. Next one is left posterior hemivesicular block. This is least common. So same 2 vectors only. Initial vector here is directed towards the leftward and upward. It is exactly opposite. So there you are getting the positive deflection. In the inferior you are getting the negative deflection. Direction of this, it is going through this. So here you are getting the positive. It is coming here. So here you are getting the negative deflection. The same second vector, it is the downward and right. So direction of this, you are getting the positive deflection in the 2 and area, negative deflection in the lateral leads. So these are the this is the criteria. RS complex in the 1 and area and the QR complex. This is the most important thing in LVVP. Being the emergency physician or like whatever if you are seeing the ECG with LVP, some patients coming with chest pain, you have to diagnose whether the patient is having myocardial infarction or not. Because I told in the LVP that elevation is normal. Then how are we going to diagnose the ischemia in bundle branch block? So to diagnose that, we are having one criteria which is called Gargosa criteria. So Gargosa, this will have the three things. The first one, as I told, discordance. So wherever the QRS opposite the ST segment will be there. Here, this is concordance. Concordant ST elevation more than 1 mm in the with the positive QRS marker. So here, if you see the QRS is positive, elevation also in the same thing. So this is called concordant. So it should be more than 1 mm. If it is there. Second one, concordant ST depression. The QRS is negative and the same day patient will have the depression. So that is more than 1 mm. Third one, this is normal. In LPUB, this discordance is normal, but the discordance is excessive. Excessive discordance means like if it is more than 5 mm. If it is there, then we can easily tell it as a ischemia in left bundle branch block. So in this Gargosa, it is having high sensitivity but least specificity. Only 39% of specificity is there. So that they have introduced another criteria which is called modified Gargosa. Nothing the same only. In modified Gargosa, same concordant ST elevation will be there and concordant ST segment depression also is there in the V1. So this is the third thing. Excessive discordant they change. Excessive discordant they change into ST by S ratio. So how are you going to calculate that? If you see here, third one, you have to calculate the S wave length. If you see 5, 10, almost 13 small blocks is coming. So S wave ratio is 13 and ST segment elevation is around 4 mm. So 4 divided by 13, if you put it will come with 29.6. If it is more than 23%. So ST by S ratio is more than 25%, which is suggestive of myocardial infarction. So in modified Gargosa, the specificity is coming around 93%. So this will be like now recently followed up for everyone to diagnose the myocardial infarction in LVP. There are other signs also which is having low sensitivity and specificity. One is Cabrera sign. Cabrera sign means so notching at 40 millisecond in the absolute PS wave in the lead B3 and B2. Another one is Stampford sign. This is the like upsloping notch in the upsloping arch. I show some ECGs. If you see lead B4, there arrow mark is there. If you see there is a notch in the upsloping of the S wave. So that is the Cabrera sign. These are the signs you can tell this patient is having in LVP patients having myocardial ischemia, but it has very low sensitivity. The second one, this is Chapman sign. If you see here, I told 1 and ABL upslope in the orbit. So if you see in 1 and ABL, there is a notch in the orbit. This is Chapman sign. These both signs will have very sensitivity. Thank you.
Thank you, sir. Our next speaker for the day is Dr. Amravati, Senior Resident of Emergency Medicine, Igmc.
Good afternoon, everyone. Since Earth has discussed extensively about the particular block, he has made my job easy. Now we'll discuss about the right bundle branch block. Here I am not going to discuss much about the electrophysiology. That part is already taken care of. I'll just make it simple. So,
if patient, how do you diagnose a right bundle branch block? So there are three main criteria. First, whenever there is a bundle branch block, the QRS should widen. That is the first criteria. Whether it is a left or right, your QRS should be more than 130 milliseconds. That criteria should be there. Second, we need to have two patterns. For the RBB, I want to remember only two leads. Lead B1, lead B6. In lead B1, we need to have an RSR pattern. In lead B6 or lateral leads, one ADL, we need to have a widely slurred RBB. So I'll show what it is. Even if you don't remember this RSR or this slurred way, just remember two alphabets. One is M, one is W. Okay. So first let's look at B1. Now I told you, first criteria is widening of the QRS. Is it fitting? QRS is definitely more than 3 small boxes, that is more than 130 milliseconds. Now we know that it is widened, we need to know whether it is a right bundle branch block or a left bundle branch block. For that, first I told there is an RSR pattern or M pattern. Just remember the letter M. For example, you see this start like this, goes like this, goes like this, goes like this. So B1, you need to remember the alphabet M. Now I will tell you why this M pattern develops here. Normally, in electrical conduction, impulse starts from the AC node, goes to the AV node, bundle of is transferred equally via both the left and right bundles, Purkinje fibers and contraction happens. But in bundle branch block, one of the bundles get affected. So normally this QRS represents the ventricular depolarization. So what will happen is, initially, first septal depolarization will happen. So I remember these two leads, B1 and B6. Let us assume that B1 is facing the RB, B6 is facing the LB. Just remember these two leads. Assume that they are diagonally opposite to each other. So if current is going towards B1, it will be positive deflection B1, it will be negative deflection B6. Just the opposite. Remember these two things. Now, first septal depolarization happens. Septal depolarization is predominantly left to right. So current is going towards right side. So right side only have lead B1, right? So first it produces a small positive deflection. That is the R wave. Okay. Now, ideally both bundles should activate normally, but here there is a right bundle branch block. So left bundle will conduct, and that will produce. So current will go towards the left side now. Are you able to understand? So that will produce a small negative deflection, that is AS wave. Now LV conduction has happened, but RV has to get some impulse. That will come only from LV. So now the impulse has to come from LV to RV. So that will produce an again positive deflection towards B1 because it is towards the RV. That is why you get this RSR dash pattern, or simply just remember the pattern M in B1. This is the criteria for lead B1. Let us see B6. The same criteria will apply. What I told, initially septal depolarization will happen from left to right. Now V6 is on the left side, so current is going towards the right side. So that produces a small negative deflection, that is the Q wave, the small Q wave, that is the septal Q wave. Then LV will get activated normally. So V6 is facing towards LV, current is coming towards LV. That will produce a tall positive deflection, that is your RV, right? Now, once again, RV has to get impulse from the LV, so current is going from left to right, that is opposite of your V6. So that produces a wide slurred S wave. Are you able to understand the electrophysiology? That's it. Just remember these two leads, V1, V6, M and W, RSR dash pattern, and wide slurred S wave in V6, 180. Is it clear? This is the main criteria. There is something called an associated criteria. Ideally, there should be discordance in the pre-coordinates, leads V1 to V3. So for example, in RBP, the QRS should be predominantly positive in V1 to V3. So discordance means the ST segment and T segment should be opposite. So there should be ST segment depression with or without T wave inversion in the leads V1 to V3. This is called as a discordance. If both are satisfying, definitely the patient has a right bundle branch block. Is that clear? Now let's see this ECG. Is it fitting into RBP? Why? What is the first criteria? V1. Why QRS is there? That is satisfied. What about the second criteria? RSR F pattern. F pattern. Is it fitting? Actually, it's not typical here. So usually RSR pattern will be there. Sometimes something called as a QR can be there. A small Q, a large wide R can be there. That is called as a QRBP. Okay, so this also can be there. Or a tall monophasic R also can be there. These are other morphologies which can present as right branch block. Okay, so remember this also. So it's a Q, small Q, large R, and V1. Now see this ECG. Whether it is fitting into bundle branch block or not. What is the first criteria? QRS widening. Is it there? QRS is less than 3 small boxes. For example, if you see, it is almost coming in 2 to 3 small boxes only. You see this part, this QRS complex are. Okay, so not having the pointers and not even exactly controlled. The QRS is definitely not more than 3 milliseconds. But what about the other criteria? Whether RSR pattern is there or not in given? There is an R wave, a small S wave, it is too small, actually not able to. There is an R wave, there is an S wave, again an R dash wave, it is there. And slurring is not there in the laterals, that part is not satisfying. But this discordance is there. We want the V3 ST depression T inversion is there. This we call it as an incomplete RBP. You call it as a button branch block, first criteria should be widening of QRS. Here there is no widening. But other criteria for RBP are fitting. The RSR pattern is there, discordance is there. But the slurring in the S5 and P5 and P6, one area is not there. So this is called as an incomplete RBP. So what is the significance of an incomplete RBP? In children it is usually at normal variant. In adults, in the presence of, it can happen pulmonary embolism or acute RV strain. So that is what we need to think of. Acute RV strain, pulmonary embolism. You see an incomplete RBP in an adult. So what about this CCT? Is it fitting the criteria? Is the QRS wider? You see this? The QRS starts here. It is almost 3 small boxes. So that is widening of QRS. Whether there is any RSR pattern in D1, there is a small R wave, there is an S wave, then there is an R dash wave. So can be called as an RBP. And this V6, there is some slurring in the V6 also. So can be called as an RBP. Though it looks like an RBP, it is actually not a true RBP. It is called as a Brugada pattern. Basically, this is a differential diagnosis for an RBP. It is not a very classic RBP pattern. But one point that is against is, here you see ST segment elevation. Usually your discordance should be ST segment depression or T inversion. But in V1 to V3, if you see, there is an R dash pattern, but there is some ST segment elevation there. So this pattern, you just remember, it's called as a Brugada pattern. Basically, it's a channelopathy. These people are prone for ventricular arrhythmias. Okay, this is a differential diagnosis for right bundle branch block. Okay, now let's see CC. So, is the QRS wide enough? Approximately, it starts here, almost 3 to 4 small boxes is coming. So, first component is fitting. What about the second component? RSR is fitting. There is actually small RV and the small negative deflection R dash. So, RSR is there, and there is some slurring in the S wave also. So, right bundle branch morphology is fitting. What about the axis? Will the RBP cause a change in the axis deviation? Usually, RBP should not cause axis deviation because your LV is properly working. There is no left bundle branch block. Whenever the LV is getting affected, axis will significantly change. But in the RBP, usually axis will not change. So, usually it should be normal axis. But what is the axis here? Left axis. So, what is the difference for left axis deviation? There are some few causes for left axis deviation. Left ventricular hypertrophy, very good. Left bundle branch block. Both are not there. There is no voltage criteria satisfying LVH. Definitely it is not fitting into LVP morphology. Now, third possibility, when the left axis deviation is there, we need to think of a heavy block. Left anterior heavy block. This was discussed, left anterior vesicular block, left posterior vesicular block. When left axis deviation is present, rule out the common causes. LVH, left bundle branch block. Both are not satisfying. Then you take it as a left anterior heavy block. Is it clear? So here patient is having a right bundle branch block associated, there is a left anterior heavy block. This is called as a bifascicular block. His bundle has 3 fascicles, left anterior fascicle, left posterior fascicle, right bundle. Now 2 out of 3 fascicles blocked. So you call it as a bifascicular block. What is the importance? 2 out of 3 is getting out. So these patients are more to develop heart blocks. Ultimately they can end up in a complete heart block. That is why we need to monitor these patients. If they come with syncope, we need to observe them and think about pacing. So let's see this CC. Is the QRS wide enough? Definitely it's wide, right? Everyone is agreeing. Is it fitting the RBP criteria? Is there an RSR pattern? There is not a classic RSR pattern, but there is a Q, but large R is there. That is also one more pattern which can happen in RBP. There is some slurring which is happening in the V5 cases. Okay. What I have told, the RBP should not cause any axis deviation, right? What is the axis here? One is negative, AVF is positive. What is the axis? Right axis deviation. So, from our learning, we know that RBP should not cause an axis deviation, but there is right axis deviation here. So what are the causes of right axis deviation? Common causes? Right ventricular hypertrophy. So right ventricular hypertrophy is the most common cause. What is the second cause? Acute RV strain because of pulmonary embolism. Also is an important cause. Any other causes? These are the two usual causes, RVH and acute RV strain. But in this patient, whether the patient is having a voltage criteria satisfied for RVH. What is the criteria for RVH? RVH should be more than S. As per Berkeley's class, R should be more than S. So, can this patient have an RVH? It's difficult to tell. In the presence of a right bundle branch block, it is very difficult to find out whether the patient is having an RVH or not. So, you need to satisfy all the criteria, voltage criteria, associated criteria, everything should be satisfied. Otherwise, it's very difficult to tell. Or you need to confirm with an echo. So, if you have an echo, just put a probe and see whether the RV is hypertrophied or not. At the same time, there is RV hypertrophy. Usually, it will be associated with RA hypertrophy also. Because most of the time, pulmonary hypertension will cause RA enlargement. So, if there is a look for evidence of RA enlargement, definitely there is no P pulmonary. So, unlikely to be RVH. That's what you can tell. But there is right axis deviation. So, let us see RVH is not there. There is no P pulmonary. We have ruled out RVH. But right axis deviation is there. Let us see pulmonary embolism also is ruled out. Now, when right axis deviation is there, what is the next possible cause? In these two are ruled out. You think about left posterior heavy block. Left axis deviation, when the common cause of ruled out, it is left anterior heavy block. Right axis deviation, when the other common cause of ruled out, it is left posterior heavy block. So here, right bundle is blocked, left posterior fascicle is blocked. This is also a type of bifascicular block. These patients are also at risk of developing a complete outblock. Is it clear? So before putting that as left anterior or posterior heavy block, you need to rule out the common causes of left and right axis deviation. Is it clear? So this is what I put there. There is something called as a trifascicular block. I don't want to confuse much. There is something called as a trifascicular block. Ideally, all the fascicles are blocked. So, what is the criteria is, basically there should be right bundle branch block, plus a left anterior or posterior heavy block, plus a third degree heavy block should be there. If all these things are there, then the patient is a complete not block. It really needs space. It is called as a trifascicular block. But there is something called as a incomplete trifascicular block. If the patient has first or second degree heavy block, you call it as incomplete trifascicular block. If the patient has a third degree heavy block, you call it as a complete third degree heavy block. So, to just refresh, to call RVP, you need to have three criteria. One is QRS widening more than 120 milliseconds, two alphabets, M pattern in V1, RSR pattern V1, W in V6, wide is learning in V6, 1 area should be there. If it is less than 120 milliseconds, you think of incomplete RVP. RVP should not cause any axis deviation. If RVP has axis deviation, left or right axis, rule out the common causes. If ruled out, then you consider a heavy block, left anterior or posterior heavy block. So if RVP plus either left or anterior or posterior block, you call it as a bifascicular block, plus an AV block, you call it as a trifascicular block. Is that clear? Any doubts so far? Thank you.
We have the simulation sessions now. I request our faculty members to kindly go near your groups.
Samples and DVB5 will be Chunamba Beach. DVB11 will be Rock Beach, DVB12 will be Paradise. Huh? What is the beach paradise? Serenity Beach. DVB13 will be Ponte Marina, DVB14 will be Barbie Park, DVB15 will be Oregon.
அது ரொம்ப பீச்சாக இருக்கும். சில நேரம் வாங்கிட்டு வருவேன், 6 வச்சுருக்கான். ரொம்ப
Ready? We'll go to Aimhtyhrra, DB1. Ready?
I will know Ashram who's going to. No wallet is from the team.
Others, please listen. Please watch this ECG. Please watch this ECG.
So here, so that is
others, please see the ECG.
And that is third, let's say between B5 and B6. So it will be left quadrant. First wide and KYC. Second, so the B1 what you dominant SL is the B1. Yes? And B5 and B6 are you first analyze the rate, what the rate is.
Always go with rate rhythm axis and then interpret the ECG.
So it's around 150. Around 150. So it's regular. So it's right axis deviation. So one is left axis deviation. It's left axis deviation. And then in AVL, Biden curve complex. Then in BFN cases, that's a
Hold my thing. So everybody is listening to you.
okay, then BFN cases, there is slurred escapes.
So what you see in the B5 is mainly in B1 what are you going to see? B1 what should do?
Different estates.
In one, in lateral is 1 and area B5 B6 what are you going to see? Yeah, broad monofascial. It's there because what is there is area. Area is a broad monofascial. QR is prolonged. So it is
Any doubts? Yeah, give applause.
White out.
Sir, irregular rhythm, sir. The heart rate is around 66. Left axis deviation, sir. Axis deviation, left axis deviation. Absence of P-wave in lead one, sir. Atrial fibrillation. White QRS complex. Deep SA presence, so LBP, left bundle branch block.
Deep SA present.
V1.
V1 and
V4.
V1 and V2. V3, V6, what is this?
Tall or
What is it?
rod. Appropriate disc.
So,
LBP, left bundle branch. Irregular.
No period. So, atrial left bundle branch block.
Clear? Others are clear? Be louder, just introduce yourself and be louder. Everybody is listening to you.
I'm Dr. Ignatius from CLC. So I would like to first comment on the rate. So the rhythm is regular. So 2 large blocks will come up to 150 per minute, and the period is followed by QRS in lead 2, and in AVR it is negative, so it is sinus rhythm, and the axis it is normal in lead 1 and AVR, so normal axis. And P-wave is having a normal morphology in lead 2 and AVR. And now I will comment on the QRS. It is up to 3 small box, and I could see a deep S wave in D1 and tall R wave in leads V5 and V6. So I will comment on a left bundle branch block. Also, I could have a ST depression with P-wave inversion in lead 1. So there is some feature of strain also there.
This QRS you told no? QRS is so the patient sitting with the LCB all the patients with QRS only in the LCB QRS is prolonged more than 120. Here QRS is normal. So what is it? Incomplete less 25. Okay.
Clear? Others, please listen to the ECGs.
Clear, no? Everybody?
Yes, next is. Clap for.
I'm Siddharth Shankar. Our ECG shows a rate of 75 beats per minute, resonance regular. Axis is left-sided deviation, with positive in lead 1 and negative in AVF. The findings are lead 1 and AVL, QRS complex, QR complex is present, lead 2, 3 and AVF, RS complex is present.
Okay.
QRS voltage is increased in left leads. Which is suggestive of left anterior vesicular curve.
So, what are the findings? Tell once again.
QR complex is present in lead 1 and AVL.
Okay.
RS complex is present in lead 2, 3 and AVL.
The inferior is RS
Inferior and superior.
lateral is QR complex. So, what is the
Left anterior vesicular curve.
Good.
ABMC. In this ECG, we are able to see heart rate as 1 or 2, and there is a left axis deviation, and probably there is an incomplete RBP, so it is a bypass.
Okay. How any other specific?
Left anterior fascicular block is there.
How?
In V1 and AVL there is QR, and in 2-3 AVL there is RS.
V1 and AVL?
QR.
QR.
And in 2-3 AVL there is RS.
Okay.
So it is left anterior fascicular block.
Left anterior. Okay.
Here, we go to the next. BB11, Rock Beach.
Regular rhythm, rate is 100 beats per second, and there is left axis deviation, there is right bundle branch block. Since the QRS is more than 3 small boxes, and there is RSR pattern in V1, and there is slurring in V6, it could be wide fascicular block.
Okay. Give a round of applause for him. BB12.
This is Vaishali. In this, it is regular and rate is around 100 beats per minute. Normal sinus rhythm, a normal axis. In V1, QRS complex is less than 3 boxes, but we can see M-shaped pattern. In V6, slugged S wave is not seen. In V1, V2, V3, we can see discordant. So it is incomplete right branch.
Okay.
Yeah. Introduce yourself.
Myself R. Shakti Padan. And the heart rate is 60. Normal sinus rhythm. Right axis deviation. QRS is wider because of the more than 3 small bugs. Bundle of branch block is present. Right RBP. V1 is M shape, is possessed positive. V6 is the W shape wave, is possessed negative. So it is right bundle branch block.
Anything else is there?
Right axis deviation.
There, any other thing? If you see the
posterior.
So, how about the fascicular block?
Postgraduates, any postgraduates there in the group?
Can you tell me how the left posterior is?
Postgraduates should be there in the group.
Usually in RBMP there is normal axis deviation, but here it is right axis deviation. So we can rule out right ventricular hypertrophy, and then in bifascicular block.
Which facility or posterior?
Posterior. Okay. Great. Give a round of applause. Next. 14.
Myself Suvir. Here the rate could not be determined as there is not specific. The TVM morphology is not seems to be normal, but the TVM is not all the QRS complex, and all QRS complex is not presented by TVS. As I said, and QRS is positive in V1 and negative in AVR, so it's left axis deviation, and then AVR in V1, M pattern is seen, RSR, and then B6, there is swelling of the S wave and white QRS complex, rest of RDPP. But since left axis deviation is present, it would, and also non-perfected periods are present, it would be a right ventricular or right ventricular.
Okay, great. So very difficult ECG, very difficult ECG, great. Right ventricular. Any other postgraduates has any doubt in this ECG? Postgraduates, colleagues. Last ECG, BB15.
I'm Robin Island from Oral Group. This ECG shows regular rhythm with rate 75 beats per minute, and there is a left axis deviation in this. We can see QRS complex is more than 3 small block boxes, so there is widened QRS complex, and in V1 we have M pattern, that is RSR pattern, and in V6 we have swelling of the S wing. So there is both right bundle branch block and left axis deviation, which would be which indicates there is left anterior left. There is left anterior hemi block, so it's a bifurcating block.
Yeah, clear? Clear, everybody? Any doubts?
Bifurcating block is correct, but there is. Are you able to find anything else?
Any postgraduates will answer this.
Along with the bifurcating block, there is a prolongation of PR interval. So it is suggestive of second degree AV block. So this could be a expanding trifurcating.
Okay, great.
All the years followed by QRS, but the PR interval is more than 200 milliseconds, more than 5. We will be discussing all these things in the prior area, but bifurcating block plus first degree AV block. So it will be a trifurcating block, incomplete trifurcating block.
Clear? Other people, postgraduates? Okay. Thank you. We'll go to the next session. Tachyarrhythmias by Dr. Balaji Shah, Senior Resident Assistant Professor from Sri Electrocardiogram Medical College, Department of Emergency Medicine. Break this for lunch after this session. Just 15-minute session, after that we'll break for lunch.
As you can see from this picture, how will you broadly classify it? Can anyone please? Yes. How will you broadly classify tachyarrhythmias?
Regular tachyarrhythmia is narrow QRS, regular tachyarrhythmia is wide QRS, and the irregular tachyarrhythmia is narrow or irregular tachyarrhythmia is wide QRS.
Okay, that's also. We classify them into 4 groups: narrow, wide, and regular, irregular. So thus it is falling into 4 categories. That's it. So we'll be discussing, mostly on these topics. So broadly you classify them on based on the QRS complexes, whether it's a narrow QRS or wide QRS. So narrow QRS means it is for only 3 small boxes. So less than 3 small boxes are narrow QRS complex. If it is more than 3 boxes, that is broad QRS complex. So again, which is further divided into the regular and irregular. So among these regular, we have all this list. So we'll be discussing briefly on all these topics. So among this, what you need to understand is, so very critical for us to recognize, being an emergency physician or whatever, suppose if you work in any other critical care settings, it is very much mandatory for us to recognize this tachyarrhythmias, so that accordingly we can manage, right? So the most common is sinus tachycardia, and among this, we need to familiarize with the SVT, and among the effects, we need to familiarize ourselves with recognizing atrial fibrillation with a rapid ventricular rate. Among the broad QRS complex regular, we need to first with recognizing the monomorphic VT. Among irregular, at least we need to recognize the ventricular fibrillation, which is a anyone? Ventricular fibrillation is what kind of rhythm? Anyone? It is a shock rhythm, right? So pulse plus VT as well as VF is a shock rhythm. So what do you see here? So So what is this? So sinus tachycardia, which is the very most common cause of regular narrow complex tachycardia. So everyone knows it. So it applies everything which is corresponds to all the criteria which corresponds to the normal sinus rhythm except the heart rate. So which is more than 100 beats per minute in this. And when there is an extreme tachycardia, you will be able to observe something called here one mechanism. What is that? It is a camel hump appearance that will be seen in an extreme tachycardia, right? So that's all about the sinus tachycardia. There's nothing much. So I hope you were able to recognize sinus tachycardia. Right? The next phase. And SVT. We are going to be discussing more deeper into this, but broadly, I'll tell them, like, simplify. I want to simplify the SVT by saying this. So it is a narrow regular QRS complex, and this heart rate will always be more than 150. And usually, you will never find the P-waves. Usually, the primary will be absent. So that is SVT. Okay. So again, this SVT, we have two categories, that is AV NRT and AV RT. So that is AV nodal reentrant tachycardia and AV nodal atrioventricular reentrant tachycardia. Right. So okay. So what is AV NRT? AV nodal reentrant tachycardia. So in this, you need to understand a simple mechanism. So normally, we have AV node and it has a proximal connection as well as distal connection, as you can see here. So as you can see in this pathway, so there is two pathways that we have in the AV node, that is slow pathway as well as fast pathway. So normally what happens in the normal sinus system, as you can see here, as you can see here, there is a two kind of pathways, that is slow pathway as well as fast pathway, right? So normal conduction mechanism, what happens is like this, these slow pathways, it conducts slowly, but it has a very short refractive period. But that is fast pathway, it conducts fastly, but it has very long refractive period. That means it takes some time to recover itself. So what happens when there is a rapid atrial heart rate? So what happens here is like when the heart rate when the rapid atrial tachycardia happens, normally it gets conducted through the slow pathway, but that is, it does not conduct through the AV node. That is what happens in the usual tachycardia. That's what happens in the normal sinus rhythm. But what happens in AV and RT is like it goes back through the fast pathway. It goes back and then it gets re-entered. It gets circulated among this AV node. And then rapidly it fires to both the sides. It gets circulates to the supraventricular area also and ventricular area also it fires. And thus it produces certain ECG findings that we are going to be discussing here. So as we can see here in V1 and V2, okay, this is a very peculiar finding for this AV and RT. So those are pseudo or dash wave. It's not an R wave, it appears like a R wave. It is due to the P wave that falls over that area. Right? As you can see here, the P wave falls over at the end of the QRS complex. So that appears as pseudo or dash wave that can be seen in V1 and V2. And there is a pseudo S wave pattern that can also be seen in inferiorities that we'll see in the next slides. Right? So yeah, here you can see. So let's just focus on the typical AV and RT alone. Let's not confuse so much. So most of the 90% of the cases you will be able to see AV and RT. In this case, either P waves not visible at all. Either if P waves falls right at the QRS complex, you will not be able to see any P waves. So if that is the case, you are actually dealing with the AV and RT. Otherwise, if you're able to see some pseudo S-wave pattern, that means what? That is the inverted P waves. Okay, as you can see, right at the end of the QRS complex in inferior leads. For example, here in lead 2. Okay, that is called pseudo S-wave pattern and pseudo R-dash pattern that we have seen in the earlier slide. So if all these things are seen, that you are dealing with the alien random, right? And also we have something called Jaggi algorithm. Based on this algorithm, you can able to find out whether we are simply we can determine whether we are dealing with the alien random or AVR. Okay. So we'll be applying this in the subsequent slide. So now we got a ECG. So can anyone practice? Anyone any images? So can anyone? Okay, so let's start from the basics, man. This thing is what? What is this tachycardia? Start from basics. When we started the classifying, we started from basics. It is narrow QRS complex, narrow regular QRS complex tachycardia. Okay. Now, what I have specifically mentioned to recognize the alien random, what are the criteria that I know? So, that is a pseudo odd wave or pseudo S wave. Here you can see there is a pseudo S wave as well as pseudo odd wave. Okay, if that is there, then obviously you are dealing with the alien random. Another slide. Okay. In this case, you just look at the rhythm strip of this V2. You just try to see if there is any, if you are able to elicit any P waves. You look at the V1 as well as V3, you are not able to find out any P waves, then look at the rhythm strip to see if there is any hidden P waves. You are not able to find out anything. Right, so the P waves is absent. That means you are probably dealing with alien random. That's it. Okay? P is not visible and history impression is also not visible. Right? So then we have come to AVRT. AVRT again it is divided into two. So AVRT is basically seen when there is an accessory pathway. Okay, usually seen in when there is an accessory pathway, right? So for example, WPW can have this AVRT. It's a very important and critical ECG. Why we want to know is you will recognize its importance at the end of this class. So any orthodromic, that means what? The impulses gets conducted through the AV node and then through accessory pathway it reverts back into the atrium. So that is orthodromic. Ortho means going straight, taking a normal route, right? So ortho, anti, against. So that means what? It goes against the normal anatomy. That means what? It takes the accessory pathway and it reaches the ventricles and again it reverts back through the AV node. So that is called antidromic, right? So most of these tachycardias will be rate will be more than around 200, and they will have usually orthodromic will be narrow QRS complex, whereas antidromic will be wide QRS complex because it takes more amount of energy to stimulate the ventricle, right? So that is why it's wide. And most of the antidromic is very difficult to distinguish from the VT, but we have a second VT criteria that we will be discussing also. Okay. And now let's practice this. Anyone? Start from basics. So what is it? How do you classify that? Narrow QRS complex tachycardia, right? So what do you see here? You take the rhythm strip. You try to see if there is any P waves. You are not able to find out any P waves. You call this as what? AVRT or AVMRT? Yeah, but there is a certain criteria that you need to remember. ST depression, diffuse ST depression can be seen if ST depression more than 2 mm. In that case, you are probably dealing with the AVRT. As you can see here, there is a lot of ST depression on that, and that is causing more than 2 mm. That means you are probably dealing with the AVRT. As per this algorithm, I just applied this algorithm, nothing. As you can see here. Okay. So here, what happens? It is not seen. Then you check the RP duration. No visible P waves. If there is no visible P waves, then I went to this algorithm. ST depression is there. Got it? If ST depression is there, we are probably in the AVRT. Okay? So this is an AVRT. So now we are now to very similar part, that is focal atrial tachycardia, which is already been discussed. Okay, I just want to highlight really, whatever is important. So what do you see here? First you classify basically, what is it? What was categories? What kind of tachycardia is? Okay, so narrow regular tachycardia. And what do you see here? Inverted periods. So inverted periods, especially seen in the inferior leads. Okay, and with the PR interval, normal PR interval, not short PR interval. Short PR interval is what? Short PR interval. No, in the case of tachycardia, within the narrow purus complex, if you are seeing this is inverted periods with the short PR interval, it is junctional tachycardia. So that is normal PR interval. You call that as focal atrial tachycardia, and you can see there is a same morphology throughout. Same morphology of periods. Okay, so you are dealing with the focal atrial tachycardia. So now you can see in this slide, okay, as you can see in this inferior leads, you are able to elicit this inverted periods, and there is a narrow purus complex tachycardia, and PR interval is normal and constant. Right? Next. So now we have junctional ectopic tachycardia. I just explained here. So what do you see here? What do you see here? You are able to elicit any TVS here? So there is an inverted TVS right before the beginning of the QRS complex. Okay? So that is the ectopic focal. And it is of same morphology. And so therefore it is junctional tachycardia. So usually inverted TVS will be seen in inferior leads, just like we have seen in the focal atrial tachycardia, and sometimes you can see upright TVS in area and TVS. So as you can see in this ECG, so what is it? Anyone? Anybody? So what is this? It is a narrow purus complex tachycardia. Once again, you can able to find out any TVS here. You are not able to see any TVS, which is also a junctional tachycardia. Okay? Either you see as inverted POC, TVS can be fall anywhere, just before the QRS complex, or under QRS complex, or right after the QRS complex. All these are junctional tachycardia. Right? So answer POS in this case. So here you can see there is an inverted POS. Retrograde POS, right? See it, if you invert, it is inverted in inferior leads. Now we have come to atrial flutter. So T waves obviously gets a replaced with the fluttering waves here. Okay, and you consider it as a sawtooth pattern. So atrial flutter can present as two things. One is either variable or fixed. Okay. So let's look at the fixed AV block. Okay, fixed AV conduction block. In this case, it can be either 2:1 block or 3:1 block. So we'll explain what is it. Most of the atrial flutter, if there is a fixed block, they continue to maintain the same heart rate. Right? Most of the 2:1 block, as you can see here, it looks like sinus tachycardia. It looks like sinus tachycardia, but it doesn't. Okay. Most of how do you differentiate from sinus tachycardia? It is a narrow pure. Flutter waves numbers also get to vary accordingly. So it basically varies from 2:1 to 4:1. Okay, so this is a variable conduction. And then when we have come to atrial fibrillation. So in atrial fibrillation, so V waves is being replaced with the filtering waves. As we have just discussed, fluttering waves is being there. So it can be any pages? Please look at this. Look at this ECG diagram. Already I have written. So there is a narrow irregular complex tachycardia, and EVs are absent. It is being replaced with the fibrillary waves. That's it. So what you see here? What is this? So there, we have already discussed this in the morning regarding this PVA morphology, right? So what is it? So you can see there is a different P-wave morphology here. There is more than or equal to 3 P-wave morphologies, basically suggesting and it is irregular. It is narrow, irregular complex with the more than 3 P-wave morphologies, suggesting that patient is having multifocal atrial tachycardia. Right? So what is this? It's the same, right? So look at the rhythm strip. Look at the rhythm strip here. As you can see, different P-wave morphology over here and there, and it is irregular. Right? So it is suggesting that the patient is also having some additional finding here. As you can see, dominant orbit in V1 with a deep strip, which is suggesting of RVH. So now, ventricular tachycardia, okay, which is the most important and critical part now. So broadly, the ventricular tachycardia is being classified as stable and unstable. So based on the hemodynamic instability, and again based on the duration also, whether it is sustained or not sustained, and based on the morphology as well, monomorphic, polymorphic. So what is this here? Anyone? What is this rhythm? Narrow or wide? It is wide. And regular or irregular? So narrow, wide, regular complex tachycardia, probably varying with the monomorphic VD. Okay. So there are so many criteria, so many things which can suggest you of this ventricular tachycardia. So let's see one by one. So this is a very important table in this of this entire session. So one of the signs which is favoring VD. Okay. First, extreme axis deviation. You can see extreme axis deviation. Otherwise, negative concordance or positive concordance. That means what? All the precordial are showing entirely negative or entirely positive. So, which is mostly suggestive of VD. Otherwise, what you can see here, there is a Brugada sign as well as Josephson sign. Brugada sign is, what is Brugada sign here? Distance from the onset of the QRS complex to the nadir replacement. So, it should be more than 0.1 second. 0.1 second. Other one is Josephson sign. There is a notching during the negative reflection. There is a notching during the nadir replacement. There is a notching that means there is a Josephson sign. And you have fusion beat as well as capture beat. So, what is fusion beat? What causes a fusion beat? Anyone? Okay. So, fusion beat is basically due to the sinus beat. It is just nothing but a sinus beat. That time, both the atrium and ventricle is being contracted and produces a hybrid complex. That is called fusion beat. And capture beat is normal sinus rhythm. Intermittently, patient can have normal sinus rhythm. That is the capture beat. And patient should not have any RBP morphology or LPP morphology. Okay? And you can see something called tolerant left rapid ear sign. We have seen this in V1. V1 leads in RBP pattern. What we see is RS R dash pattern. That means R will be smaller, S will be deeper, and then there will be R dash. Okay, so that is called tolerant right here. If it falls, then if the positive, more positive over the left side, that is called tolerant orbit. If that is there, probably you are dealing with the VT. And the single most important criteria to diagnose VT is R wave peak time. So as you can see here, this is the beginning of the QRS complex to the top of the R wave. So if it crosses more than 50 milliseconds, probably you are dealing with the VT. And then polymorphic VT. So it is a irregular complex tachycardia, and you can see there is a multiple morphology of QRS complex. Simply it is polymorphic beating. So what is this rhythm? Anyone? Can it be shockable rhythm or not shockable? So it is a shockable rhythm. Okay. And whether the patient can be alive during this time. Whether the patient can be alive during this time. So it is one of the dangerous arrhythmias. The patient can peri-ARRES condition. This is one of the peri-ARRES condition. Patient may anyway deteriorate and lose pulse. So this is one of the ECGs that looks like this. Most common cause that is causing this polymorphic beating will be either due to underlying decelerative radiation. Okay. And we have VF. So VF is nothing but it is also a shockable rhythm, and there is a chaotic. It is like the QRS is, it is being very much chaotic, and there are some variable deflections that are happening of varying amplitude. You can't able to appreciate any T waves here, or any proper QRS complex or any T waves. Right? So based on the amplitude, it divides into the coarse wave as well as fine wave. Okay? So fine wave is something which is less than 3 mm. Coarse wave is more than 3 mm. Whenever the patient goes into VF, they start with the coarse VF and they end up having fine VF at the later stage within a matter of minutes. Right? So this is the ECG of what is it? So this is a ventricular fibrillation. This is a coarse VF. Okay? And there's something called ventricular flutter. What is ventricular flutter? Anyone? What do you see here? Please comment. What is the difference between ET and ventricular flutter? Anybody? So this is also a narrow regular complex tachycardia. Okay? Here you can see that QRS is being compressed like this. That means heart rate is more. Ventricular flutter usually the heart rate will be somewhere latest between 300, 250 to 300. So when it is at the lower rate, it will manifest as VT. When it is at the higher rate, it manifests as ventricular flutter. Eventually that will deteriorate into the, it is very unstable arrhythmia. So it will be very transient. For a few seconds only it will stay. But eventually it will deteriorate into the VF. That is the importance of knowing this flutter waves. As you can see in this both is ECG. Okay? And what you see here, VT and VF. Anyone? Okay, so where is the VT or ventricular flutter? So it is a flutter waves. Okay? So these are the 4 dangerous arrhythmia. Can anyone name these? Please, from this group. Anyone? What is A? What is B? What is C? What is D? Can anyone stand up and answer? Please, anyone? Come on, it's easy. Easy one. Any pieces? So what is A? Monomorphic BT. Very good. What is B? B is ventricular flutter. Okay, very good. What is C? Polymorphic BT. So what is D? Ventricular fibrillation. So that's it. If you know these rhythms, it is better to. So then you have to go ahead and consider shocking this patient. If the patient is having signs of hemodynamic instability, consider shocking this patient immediately. You cannot just simply stand there and see what is happening to the patient. Okay? Right. So let's have a brief discussion on WPW. Okay, we know what is WPW, what is the classical findings in ECG. Let's just emphasize on that. Okay? So basically we have accessory pathways which can be either, it can go in both directions or it can have some retrograde action. Accessory pathway, that means what I just explained, right? So it gets carried through the normal anatomy, that is AV node, and it gets reverted to the accessory pathway. Right? So when the patient is in normal condition, whether he doesn't have anything, if you are taking that patient baseline ECG, his baseline ECG will be completely normal. He will not have any the characteristic pattern. What are the characteristic patterns in WPW? Short period interval. Delta waves. Broad QRS complex. So in Lamia they get broad QRS complex. Right? So all these things will be seen. Right? So but these conditions will not be seen if there is a concept path. And apparently that will be seen only in 50% of the patients. Okay. Most commonly, majority they will have both the directions. So therefore they tend to have the underlying changes. So these are so this is the condition with the pre-excitation. Right? So as you can see here, short PR interval, wide QRS complex, and there is a secondary STT changes. So based on the direction, whether it is a type A or type B, so how can you say whether it is a left side? So you want to know whether the accessory pathway stays at the left side or right side. If it is the left side, what will you see? There is a RS view. This RS ratio more than 1 in V1 suggestive of left side of accessory pathway. If there is a negative delta wave in V1 and V2 suggesting that patient is having right sided pathway, that is type B WPW. Okay? So as you can see here, the process behind the pre-excitation here and classical ECG findings, and there is something called pseudo-infarction pattern. Okay? So it is due to the negative deflection that can be seen in the inferior leads or either anterior leads that will appear like a pseudo-cuveus. Okay? So here, let's start this ECG. So what is it? What are the findings that you see here? You can see there is a short PR interval, and you can see the delta waves very prominent at the inferior leads, especially E2. And what you see in AVL, that is a negative delta waves. You will appreciate the negative delta wave, and that will appear like a cube. Okay, so that is why it is called a pseudo-infarction pattern. And what you see here in V1, V2, V3, all this dominant R wave followed by discordant STT sequence changes. So dominant R wave is there means what kind of WPW is? Left sided. Very good. So it is type A. Okay. They may have associated RBH also. Okay. So what is this finding? What is the classical finding here? So let's come to the inferior leads. So what you see here? Same short PR interval, and there is a delta wave. It will be wider QRS complex. And what do you see in V1, V2? V1, V2, you can see deep phase wave, which is suggestive of, and you can see in V6 positive R wave along with the discordant ST segment changes. So probably patient is having underlying AVH, right? And in the inferior leads, you can see some ischemic changes. Okay, so which is suggesting that probably the patient is having type B WPW. Okay, so there are two arrhythmias which is possibly WPW. There are one is atrial fibrillation of flutter or AVR. Okay, so let's have a look at this. Can someone track this ECG? So what's happening here? So a patient has been given some drug here, and after that the patient is developing this and going into this. Can you tell what is this? So what drug is already written there? Okay, what is that? Patient is given verapamil. Okay, so what is verapamil? Calcium channel blockers. Where does it act? AV nodal. So it is a AV nodal blocking agent. So you are giving it to the patient, and then what the patient is developing? What is the arrhythmia that is developing? It looks like toxitis, but it's actually a ventricular flutter. Okay? So it is very much amplified. Not appear like that. So it is a ventricular flutter. And eventually what is patient is deterring into? Why it is happening? So patient is eventually deterring into the ventricular fibrillation. So why it is happening? Anyone? What do you think the patient is having underlying condition? Can anyone tell? So what do you think it is? So AV nodal blocking agent you are giving it to the patient, and eventually patient is deteriorating into the VF. What do you think the patient is having underlying? Any please? Any clue? Any clue? No clue. So I just discussed regarding that condition. So that is called WPW. The patient is having underlying WPW. Right? So what's happened is he used to have a normal pathway. That is through A2. Now you have blocked that pathway. And he already having a higher rate. Higher atrial rate is there. Now you have blocked that pathway. What is happening? Through accessory pathway, it is being conducted very, very fast. So all the VRS complex, all the A1:1 connection, if it is conducting, it goes into the ventricles and it stimulates. It increases the rate up to 300. So that's what produces the ventricular flutter. And we know ventricular flutter is a transient rhythm. Eventually it will deteriorate with the EF. Okay, the whole point of knowing the arrhythmias behind this class is to do not do this. Okay, being a medical professional or medical care profession, we should anticipate these kind of findings in such patients. We should suspect, back of the mind we should suspect before giving any drug. Okay, so therefore you should be very careful in treating this condition. Okay, so that's it. These are my references. Thank you everyone.
Thank you, sir. We'll now break for lunch. I request all our delegates to kindly carry your food coupons. We leave in groups. There are 2 volunteers sitting outside. So while you leave, please let us know whether you will be joining us for dinner. So we'll start with group 1. Food is served in downstairs. Straight down. You can use the stairs.
Tachycardia, I can appreciate there is no P wave and narrow QRS complex and ST depression seen in certain leads, but it's not appreciable as it's less than 2 mm. So I suggest AVNRB.
Everybody is clear? Everybody has listened to it? Can you repeat it again? I think so few of them have not listened. Just repeat it again.
TAC 3, I can appreciate there is no P waves and narrow QRS. There is absent P waves, narrow QRS complex and ST depression I can appreciate, but it's not it's not more than 2 mm. So I conclude it is AVNRB.
Clear? Okay. Give a round of applause for it. TAC force. Who is having the hand mic? Other hand mic? Please, your mic.
Heart rate is around 165 is tachycardia. Absent periods. White QRS complex.
Some scenario has been put, Modest. You can read the scenario then.
A 60-year-old man complained of severe central chest pain and a few minutes later becomes extremely breathless and collapsed. He was brought to the emergency department where his heart rate was found to be 165 beats per minute. His blood pressure was unrecordable and he had signs of left ventricular failure. This is his ECG. There is white QRS complex. It is regular. Some
axis that is suggesting of VT, ventricular tachycardia, which I have mentioned in the class. As you can see in the precordial leads, so how does this look? The RBA progression of that V1 to V6. So there is something called positive concordance, right? So all the chest leads appears positive. So throughout the chest leads it is positive. That is called positive concordance. As well as broad QRS complex, which is approximately around 200 milliseconds. Okay. So both of these features suggesting of VT, and as well as and no other features. Right? So these two features suggesting of VT. Right, very good.
Others are okay with ECG? Okay, thank you. Give a round of applause.
TSC 16, new lighthouse.
16? 16?
The heart rate is 300.
Please read the case scenario.
A 50-year-old man who had complained of attacks of dizziness and palpitations for several years, collapsed at work and was brought to the EM department. He was cold and clammy. His heart rate was rapid and his blood pressure was unrecordable. There were signs of LPF. His ECG recorded above. What is the issue? The heart rate is 300 per minute. The QRS complex is narrow. The regular was narrow regular complex tachycardia. There are no E waves. Therefore, it's a non-sinus rhythm. And checking for either AVRT or AMRT, the pseudo R waves in V1 are even in third period or so. Pseudo S wave is also not present. And the atrial flutter is ratio 1:1 before. I think it's 1:1 atrial flutter.
Balaji?
So, what do you think that is? Atrial flutter 1:1 connection. Very good. So, what can you do to appreciate flutter waves? Is there any drug that can be given? Or any other manuals that you can do? So you can either give carotid massage to find out if there is any underlying flutter waves. Transiently it may appear, again it may not. Very good.
Or you can slow down the ECG paper. You can slow down the timing of the ECG paper. And you can see whether. Okay, thank you. Give me a round of applause.
TSC 5, Santium's paradox.
TSC 5?
Yeah.
A 45-year-old man in the coronary care unit with a suspected myocardial infarction suddenly becomes breathless and hypotensive. And this is his ECG. What does it show and what is it? The heart rate is around 180 beats per minute. That is regular white complex tachycardia. There is left axis deviation. There is absence of V wave. And there is widened QRS complex, duration 0.2 seconds. So it's a suggestive of monomorphic exploration.
Yeah, very good. So in this case, you cannot find any negative concordance or positive concordance. But there is monomorphic QRS complex as well as broad QRS complex, which is more than 200 milliseconds. So these two features are listing of monomorphic.
All are convinced with that answer? Thank you. Next, give a round of applause, please.
Next, number leads T, TAC 10.
Was weaned during an attack and his ECG was recorded. He was breathless and his blood pressure was unrecordable. What does the ECG shows and how should he be treated? So white QRS complex, regular tachycardia, with a heart rate of 200 to 220, and it shows left axis deviation, sorry, right axis deviation, and monomorphic.
Yes, you're right. So there is one entity called, so usually we tend to see extreme axis in VT. So in this case, we are able to see right axis deviation. So there is an entity called RVO. So in this patient, there is a LVP2 morphology. So in these two features suggesting of there is a RVO2. Right? Very good.
Okay, any confusions in the ECG? It's clear? Yeah, we'll go to the next. Give a round of applause. ECG number, Balaji?
TAC 13.
13?
From which?
This ECG was recorded from a 60-year-old man seen in EMD because of severe breathlessness which had developed over several years. His W venous pressure is raised. What do you think is the problem? It is regular and the rate is around 150 beats. It shows right axis deviation. We see sinus rhythm and there's tachycardia, and there's right atrial enlargement because there's heightened V wave, and there's right ventricular enlargement because there's large QRS complex. So there's sinus tachycardia.
Yeah, very good. So there's a lot of findings in this ECG. It is quite a complicated one. You can see there is a tall peak to PVOs in inferior leads, so which is suggestive of right atrial enlargement. As well as you can see some dominant R wave here. So it is having RVH, dominant R wave suggesting of RVH is also there. And patient is in sinus tachycardia. Okay, so there is a regular rhythm. So it is suggesting of there is a patient is having underlying chronic lung disease. Okay, very good.
Okay. Any doubts in the ECG? Fine? Yeah. Give a round of applause. Go to the next team.
TAC 14. The security needs to.
My name is Krishna, a 30-year-old man who had complained of palpitations for many years without anything being abnormal. Came to the EM department during an attack and this ECG was recorded. Apart from signs of marked anxiety, there were no unusual findings except a heart rate of 140 beats per minute. What does the ECG show? ECG shows tachycardia, regular tachycardia, narrow regular tachycardia. So, PR interval is less than 100 and inverted P waves are seen in inferior leads like 2, 3 and ABF. So, it's characteristic of junctional ectopia.
Very good. Give a round of applause, please.
What is the next ECG one?
TAC 17. TAC 17, sir. TAC 17.
TAC 17.
I'm sure.
Any other person from the team, because it's being repetition? Any other person who want to volunteer?
sinus tachycardia. Camel cough.
Yeah, very good. Give a round of applause.
Next.
ECG number 18. Felix, you already know somebody else.
Good afternoon, sir. I am Akash Kumar from Electrocardiogram. The ECG rate is around 150 beats per minute. Two large boxes between two consecutive R waves, and the rhythm is regular. The axis is normal axis, and it shows inverted P waves in leads 2, 3 and AVL, and it is a narrow, regular tachycardia with inverted P waves with prolonged PR intervals as of junctional electrodes. Short PR intervals.
Sorry, what is your latest? Junction tachycardia. So it is a form of atrial tachycardia. Junction tachycardia will be short PR interval. So in this case, what do you see? It's normal. Short. All right. Thank you.
Sir, 21. Surena sir. 21.
Sorry.
It's a regular narrow QRS complex, heart rate about 150, and probably supraventricular tachycardia, and there is a pseudo R wave in the V1 and pseudo S wave in V2, probably AV enlargement.
Very good. Yeah, good. Any doubts in the DCG? Clear? Yes, give her a round of applause.
Face करेंगे அங்கே வச்சு போடுங்க சொல்லலாமா மறைக்கிறேன் அது இருக்குதான் அது சுத்தமாக இல்லை டார்க் ஆகிடும் எவ்வளோ நேரம்
Sinus tachycardia. Okay. So what is the most common? What is the most common narrow irregular tachycardia? Atrial fibrillation. Atrial fibrillation. When it comes to wide, regular, what is it? Ventricular tachycardia. So we'll have actually a few discussions on monomorphic VT. So so what are the points which favors VT? Anybody?
Like there are some signs, extreme axis deviation, extreme axis deviation, the presence of some signs like fusion beats, capture beats. Like in fusion beats, what happens is that the sinus and ventricular will mix together and will produce a hybrid complex. Then capture beat, some brigade sign will be present.
Very good. Anyone wants to add up on the signs? All the signs, anything else? Any other signs that you want to add up? One sign which is having a very high sensitivity is suggestive of VT. What is that sign? So you check for R wave peak time. So you check in lead 2. So that single feature suggests you of VT. You don't have to look at anything else. If R wave peak time is more than 15 milliseconds in lead 2. Right? So that is one thing. Any other morphology criteria you have? Anyone? All right, thank you.
Thank you, sir. Our next speaker is Dr. Ajay, consultant of emergency medicine, Holland, America, Netherlands. And a very big and special thanks to him for joining us today in spite of being so far. Right now he is joining us from Casablanca, Morocco in his cruise ship. So I welcome Dr. Ajay, sir. He'll be delivering a session of bradyarrhythmia. A big round of applause for him.
Okay, let me start.
You are ready.
Okay. Okay, morning guys. It's very difficult for me to take class like this because I'm not able to see you guys. I have no clue what is going on there. So if there are any issues, I think the moderators can just let me know through the cam or something through the mic, right? So yeah, we will rush it a bit fast, right? Am I audible now?
Yes, sir.
Okay, yeah. So this topic is on, of course, bradyarrhythmias, okay? So yes, so our main concern is with the heart rate. So that is how we usually start. So whenever the heart rate is less than 60 per minute, we are going to follow this algorithm. Yes, this algorithm has some flaws in it, but still we are going to stick with it, right? I will tell you where the flaws are and then you can modify it accordingly, right? So we have an ECG with the heart rate of less than 60 beats per minute. I hope you know how to calculate the heart rate and so because we have been listening to the classes since morning, right? So the next step will be, you are going to look at the number of P waves and the QRS waves. I am not going to tell you about atria and ventricles, we are going to talk about P and QRS, right? So first of this, look at the heart rates. Yes? Any issues? Zoom in. What happened? No. Okay. No, because now. Okay. No, because the next slides I cannot zoom in much, no? Okay. Sorry, okay. Okay, so the step one will be looking at the heart rate, right? If it is less than 60 per minute, then look at the number of P waves and QRS waves. So with this, we have three possibilities, right? So with this, we have three possibilities. First possibility is both the P and QRS are the same number. That is, the number of P waves are equal to the number of QRS complexes. The second possibility is more number of P waves less QRS. That is, P waves are more, QRS are less. Third possibility is QRS are more at less number of P waves, right? So these are the three possibilities. Either both number of P waves and the number of QRS are equal, or more P less QRS, or more QRS and less P, right? So we will look at the first possibility, right? So since I need to zoom in, put in this entire slide, I can zoom in so that it will be easier, I guess. Yes. So the first possibility we are looking at the number of PAs are equal to the number of QRS. Both P and QR are in the same numbers. So then, next step will be looking at the PR interval. I hope you know what is PR interval. That is from the beginning of the P wave to the beginning of the QRS complexes. And now it should be between 3 to 5 small boxes, right? So both P and QRS are equal. Next step, you look at the PR interval. If the PR interval is normal, that is within 3 to 5 small boxes, you call it as sinus bradycardia. Okay? If the PR interval is prolonged, that is, then you call and 60 first step. Second step is you have to calculate how many P waves are there, how many QRS waves are there. Third step, if the P and QRS are the same, then look at the PR interval. If the PR interval is normal, that is within 5 small boxes, then you call it as sinus bradycardia. If the PR interval is prolonged, that is more than 5 small boxes, you call it as first degree AV block. Since at the start of the slide, I told you there are some flaws in this, right? This first degree AV block need not have always a heart rate of less than 60. It can have a normal heart rate as well, right? So always keep that in mind, and then you can analyze the ECG, okay? Yes. Is it visible enough? Yes? Okay. Now we are going to differentiate how we differentiate between sinus bradycardia and first degree AV block, right? We will be going a bit fast because there are so many logistical issues going on, right? The rate less than 60, yes, to call it as sinus bradycardia, heart rate should be less than 60 per minute, right? Whereas first degree heart block, it can have a lower heart rate or it can have a normal heart rate as well. Both will have P waves, both will have QRS, and this is mandatory. P waves should be equal to the number of QRS complexes. Okay, so that is the number of P waves should be equal to the QRS complex. All P should have a QRS followed by, and all QRS should have a P wave in front. Next one is the PR interval. The PR interval is normal in case of sinus bradycardia. That is between 3 to 5 small boxes. Whereas in first degree heart block, the PR interval should be more than 5 small boxes. That is more than 200 milliseconds. The problem with sinus bradycardia is you have a problem not within the SI node, but maybe because of increased vagal tone, where the vagal nerve activity is more, so that the sinus node gets suppressed, so that there is a delay in sending the impulses. Whereas in first degree AV block, sinus node has no issues at all. The problem is the connection between SI node and the AV node. Fibers between the SI node and AV node that transmits the connection impulses. That is where the problem is. Whereas in sinus bradycardia, there is an external suppression on the sinus node, or it can be a sinus node dysfunction where there is a problem within the sinus node itself, right? So, yes. So we will have a look at this. What is sinus rhythm? What is sinus bradycardia? Yes. Just concentrate here. Okay. So this is how the sinus rhythm acts. This is the SA node, the fibers, then which connects to the AV node, his bundle branch, right, left bundle branch, then you have the Purkinje fibers, right? So look at the conduction time. Look at the sinus bradycardia. The problem is the start of the impulses which is delayed, right? Whereas in sinus rhythm, there is no delay of any such sort. It beats almost like 1.2 seconds like that. Whereas here, in sinus bradycardia, there is a delay generating the impulses from the SA node. But when you keenly look into this, the conduction into the rest of the fibers, there is a duration taken for the rest of the impulses to reach, it's almost the same when compared to the sinus rhythm, right? So problem is here in sinus bradycardia, whereas there is a SA node, okay, but the rest of the conduction time is normal, okay? So it is P QRS, P QRS, P QRS, P QRS, P QRS, P QRS. Right? So as of the sinus rhythm works. Okay. Now looking at sinus bradycardia, it's still P QRS, P QRS, P QRS, P QRS. You don't have any problems with the duration of the PR interval or the QRS complexes. Okay. So only problem is the delay in generating impulses from the sinus node. Just now coming to the actual topic, the sinus bradycardia, first we are going to differentiate it. Yes, you have already seen what is sinus bradycardia, right? Now we are looking at first degree AV block. Okay, so here just see what is the duration of time taken for the impulse to reach from the SA node to the AV node and compare it with this. Yes, so there is a delay in transmission of impulses from the SA node to AV node, which is happening in case of the first degree but the rest of the pulse conduction time that is absolutely normal and which is almost similar to your sinus bradycardia or the sinus rhythm, right? So in first degree AV block, the problem is here in the conduction time is between the SA node and the AV node, so that is why you have a prolonged PR interval. Whereas in sinus bradycardia, there is a problem, either there is an external suppression of the sinus node or there is a problem within the sinus node itself, so there is a delay in generation of impulses. Whereas in first degree AV block, there is a problem with conduction of impulses. Okay? Okay, we have a ECG here, yes. The first is being at the heart rate, as I said, we are going to count the number of large boxes divided by, 300 divided by the number of large boxes. You have 1, 2, 3, 4, 5, and 6. So it is 300 divided by 6, which is around 50, right? So you have bradycardia, understood? The second step will be looking at number of PVs and the number of QRS. You have the first P, and you have the second QRS complex. For this P, you have the QRS. P, QRS. P, you have this QRS. Again, you have this P, QRS, P, QRS, P, QRS, P, QRS, P, QRS. So all the P waves are followed by a QRS complex and all the QRS complexes preceded by a P wave. So that satisfies our second criteria as well. Then the number of P waves must be equal to the number of Q waves. Yes, that is true. Next, look at the PR interval. I can zoom in and you can see. Yes, right? So should be between 3 to 5 small boxes, which is that in this case, right? So the PR interval is the same and it is less than 5 small boxes. 1, 2, 3, 4, 5, and 6. Yes? So the rate is less than 60. Yes? The number of P waves are equal to the number of QRS complexes. Yes? The P wave PR interval, it is normal. It is less than 5 small boxes. So we are dealing with the case of sinus bradycardia. Okay? Understood? I'm not sure. I'm not able to see you guys. Right, so I hope you guys are understanding or not. If there are any issues, I think you can address it to the operators. Please. This ECG, P, yes. Before the P, we can take a rhythm, right? 1, 2, 3, 4, 5, 6, approximately 6.5. We can keep it as 6. Again, it is around 50, right? So for this P, you have this QRS. This P, you have this QRS. For this P, you have this QRS. This P has this QRS. P, QRS, P, QRS, P, and QRS. So all P waves are followed by QRS and all QRS has a preceding P wave. Again, looking at the PR interval, yes, it's less than 5 small boxes, right? And all the PR intervals are the same. Yes, the heart rate is less than 60, which satisfies the first criteria. Second criteria is number of P waves equal to the number of QRS complexes, which satisfies the second criteria as well. And the third criteria, the PR interval should be normal, which satisfies the third criteria as well. So we are dealing with the case of sinus bradycardia, right? That is just a heart rate. Okay, now look at this ECG, right? So let's look at the heart rate. 1, 2, 3, 4. So 300 divided by 4, which is around approximately around 70. So heart rate seems to be normal. Yes, but do not discard it just like that because the heart rate is normal. Next, for this P wave, you have a QRS. For this P, you have a QRS here. This is the P wave. Do not get confused with this. So P, QRS, T, 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 and P, QRS, next this P has this QRS, this P has this QRS, and this P has this QRS. So all P waves have a QRS complexes, right? So P, QRS, T, QRS, P, QRS, T, right? But what seems to be the problem here is the PR interval, that is from the beginning of the P wave to the beginning of the QRS complexes. Can we measure it? Yes. 1. There seems to be more than 5 small boxes, approximately around 2.5 to 2.5 large boxes. Yes. Yes. So we have prolonged PR interval, but the rate seems to be normal. So yes, that is why I already told you there are some problems with that algorithm. Yes, even though the rate is normal, doesn't just go by the rate alone, right? The problem here is the number of periods are equal to the number of QRS, but the PR interval is prolonged. Okay, so this is the case of a single heart block. Okay, so the PR interval is prolonged, but there is a number of people with QRS complexes. As per the general example, there are many features in this example, but we will stick to what we are supposed to discuss. You have a P, this is your QRS, and this is your P. Again, P, QRS, T, P, QRS, T, P, QRS, and T, P, QRS, and T, P, QRS, and T. Again, you have a P here, QRS, you have a T here. P wave, QRS complex. P, QRS, P, QRS, P, QRS, P, QRS, P, QRS, P, QRS. Again, look at the PR interval. Yes, I think I can zoom it a bit for you guys. Look at the PR interval. So it is from the beginning of the PA, yes, to the beginning of the QRS complex, which is more than 5 small boxes. So rate doesn't satisfy it because the rate is just around approximately around 70 bucks. Your P waves are equal to the number of QRS complexes, and the problem is here within the PR interval. There is a prolonged PR interval. Okay. So that concludes our sinus bradycardia. With first we have to recap. Look at the heart rate, then calculate the number of P waves and the number of QRS complexes. If both P and QRS are equal, then look at the PR interval. If it is normal, sinus brady. If the PR interval is prolonged, then you call it as positive block. Okay. Now moving to the second part of the equation, where we have more number of P waves but less number of QRS complexes. P waves are more, QRS are less. Again, we are going to look at the PR interval. Right? Here we are going to talk about constant and varying. It is not normal or prolonged. Here it is whether the PR interval is constant. It can be prolonged, but it should be the same interval in all the leads. Right? So that is the difference between normal and constant. Normal in the sense it should be less than 5 small boxes. Whereas constant, you say it as, even though it is 6 small boxes, 7 small boxes, it should be the same 7 small boxes in all the complexes. If it is 3 small boxes, it should be same in all complexes, right? So if the PR interval is constant, you are dealing with second degree type 2 AV block, right? So we dealt with first degree. Now we are coming to the second degree AV block, which has 2 categories. One is type 1 and another one is type 2. So if the PR interval is constant, you call it as second degree type 2 AV block. Okay? If the PR interval is varying, suppose one complex has 5 small boxes PR interval, the next complex has 7 small boxes, the next complex has 2 small boxes, you call it as a varying PR interval. If there is a varying PR interval, look at the RR interval, that is the difference RR complexes. Again, constant if or varying. If the RR interval is constant, look at the third degree AV block. If the RR interval is varying, then it is second degree type 1 AV block, right? So heart rate, then look at the number of P waves and QRS. If P waves are more than the QRS, look at the PR interval. PR interval constant or varying. Constant, it is second degree type 2. If the PR interval is varying, then you are going to look at the interval. Again, we are going to classify it as a constant or vary. If it is constant, we call it as third degree. If it is varying, we call it as second degree type 1 AV block. All these notes are there in the books, right? You can refer it as well. I'm not going to talk about theory, right? We'll go directly into the ECGs, right? So I'm not sure whether you're able to see clearly, I hope, right? So again, we will look at it. Right. Yes, you have a P here, you have a QRS complex here. Because there are many motion artifact sort of thing here which we are looking at. Again, you have a P bump here, this is a QRS. Here you have a P, right? If you have a doubt, just trace the lead above. You can see a small positive deflection, right? So that is the P wave, right? If you still are in doubt whether it is P or T, trace it upwards. You have a big positive deflection because this is the morphology of P wave and this is the morphology of T wave, right? If you have any doubt whether it is a P or T, or if you have a doubt whether there is a P, always trace the corresponding lead above to see whether you are able to trace any leads there. Because if it is not showing anyone, clearly there is a possibility it might show clearly on the other leads, right? So you have a P here, right? But you don't have a QRS here, right? You have a P, you have a P here, you have a QRS which is following, but this P has a non-conducted QRS, there is no QRS. This P waves, the impulses which start in the P wave didn't reach the QRS, so you don't have a ventricular contraction. Again, P, QRS, P, QRS, P, QRS. This is your P wave. Again, you have a P and you don't have any QRS complexes. Again, the next P is static. Okay, so I have the QRS complex. P, QRS, P, QRS, complex. You have a P wave and a QRS complex. Okay, so you have P waves, you have QRS, but there are some P waves which are not having a QRS complex following. Okay, now look at the PR interval. Yes, not sure whether you're able to see it. It's almost the same PR interval. Okay. Yes. So the PR interval is constant. I'm not talking about normal or a prolonged. I'm talking about constant or varying. Yes, the PR interval is constant in all the complexes. Okay. Now have a close look at this. Right. So this is a P wave. You have a QRS complex followed by T, P, QRS T, P, QRS T. You have a P and you don't have a QRS complex. Right. Look at the PR interval here. It is the same PR interval. The PR interval is constant in all the complexes. Right. So this is a case of second degree type 2 where the PR interval is constant and you have a missed QRS 8, right? So constant PR interval with missed beats is a case of second degree type 2 AV block, right? If you still need confirmation, there is another method, right? You can measure the RR interval distance between beats 1, 2 and 3, right? So between the connected complexes. Yes?
Yeah. Everybody please stand up. Please raise, please raise. Please raise. Clap your hands, clap your hands. Clap your hands. Yes, Abdullah.
If some other moderator want to continue the class, they can continue it as well. I think it will be better. Okay. Okay. So, okay, maybe I can speak in Tamil a bit. I hope everybody is okay with it. So that we're interacting in English, I'm not sure. Yes. So yeah. So, another step, you just calculate RR interval distance. Rather the contact RR you're going to calculate, right? So we have a P, QRS and T. Complex 1, 2 and 3. இதுக்குள்ள R and distance you are going to calculate and you are going to reciprocate it with the next non-conducted impulses. Conduct ஆகாத impulse உடைய R and distance calculate பண்ணும்போது it should be the exact same R and interval distance. So that is another clue which can help you to identify whether it is a second degree type Ev block. திரும்ப சொல்றேன். The RR interval between the conducted or the transmitted QRS complex should be the same with the non-conducted complexes. இங்க நடுவுல ஒரு non-conducted complexes இருக்கு. அதுக்கு அடுத்து வர PQRS-யும் அதுக்கு முன்னாடி வர PQRS-யோட RR interval calculate பண்ணி you have to measure it with the previous ones. So it should be the exact same. Okay. This one, you have a PA here, அடுத்து QRS இருக்கு, corresponding QRS, இங்க ஒரு P, இங்க ஒரு அடுத்த corresponding QRS, you have a P, QRS, இங்க ஒரு P இருக்கு, whereas here you don't have a corresponding QRS complex. Okay, next, அடுத்த P is transmitting conducted QRS, இந்த P க்கு you have QRS, P, QRS, இங்க P இருக்கு, but இங்க இருக்கிற QRS complex connect parallel, right? Again, திருப்பி P, you have a QRS in the beach and skipping it out, it will be confusing for you guys. 3P, QRS, in your P, you have a QRS, okay? So the number of P's are 11 P's, you have 9 QRS, right? So the P waves are more than the QRS complexes. Again, PR interval partner, right? In the PR interval is this, in the PR interval is much more prolonged. It is much more than prolonged, followed by a drop weight. So there is a progressive prolongation. That is the PR interval prolongation. It is getting bigger. All of a sudden, followed by a drop weight. It is getting dropped. Conduct parallel. Again, you start out. It is just bigger. Again, the PR interval is getting much bigger. It is getting dropped. So there is a progressive prolongation of PR interval followed by a dropped beat. At this step, you have to look at the RR interval. Okay? RR interval varying a constant or not. If the RR interval is constant, when it may constant then it is a third degree Ev block. I think this will be a common confusion between second degree type 1 and third degree. Gross of percentage will be like all the TP intervals are the same, and gross of RR intervals might look the same, but when you calculate it, the RR intervals are not the same, right? Zoom. Yes, look at the RR interval between this and this and this. So there is a varying RR interval between the complexes. The RR interval is not constant; it is not the same. Okay, so you have a first criteria P waves are more than QRS complexes. You have a varying PR interval and you have a varying RR interval. So you have a progressive prolongation of PR interval followed by a dropped complex with varying RR interval. So this comes under second degree type 1. Okay, second degree type 1 Ev block. Okay. Okay, so there is a P wave here. You have a QRS. This small bump is a P, right? Don't get confused with it. So you have P, QRS, P, QRS, P, and okay. Again P, QRS. You have a small bump in this P, QRS, P, QRS, P, and you have a drop beat, right? So there is a progressive prolongation followed by a non-conducted beat. Again, P, our interval is getting progressively prolonged. Again, you don't have a connected QRS complex. Right? Next, you are going to measure the distance between the conducted complexes, right? So, which is varying. Okay? I don't speak about this because I think most of you are sleeping. This is what I know. So, just another clue to look into it, right? You have a pause here, right? So, you have a P here. You have a pause. There is a non-conducted QRS complex here. So, to reconfirm it, the PR interval, the PQRS complex which is coming after the pause. And the pause is the PQRS complex, the PR interval should be short. The pause is the PR interval will be long. Okay? So that is another clue to identify this Vinci back phenomenon. Okay? So again I tell you, you have a P, or a QRS drop item. So this P and QRS has been dropped, right? So the next, which is following the P and QRS, look at the PR interval between this complex and the one which is before. Okay, so this P and QRS has a short PR interval, and this, the one which comes before the pause, has a longer PR interval. This is another clue to identify your Igmc sequence. Okay, PR interval is longest before the pause and it is shortest after the pause. So all these red lines denote your P waves. All this QRS, all these blue lines denote the QRS. Conducted, conducted, conducted. You have a dropped beat. There is no conducted QRS complex. Again, you have a conducted beat, conducted beat, conducted beat. Again, you have a non-conducted QRS complex. Right? So, and you have a progressive polarization. This one, you have a P here, you have a QRS. This P, there is a buried P inside, you don't have a QRS. P, QRS, P, QRS. Here you have P, you don't have a QRS there. P, QRS, P, QRS, P, QRS, I think I will skip this. Okay. So you have a P, QRS, P, and you have a dropped QRS complex here. Again, you have a P, QRS, P, QRS, P, QRS, P, and you have a dropped complex. So you have P's with dropping QRS complexes. Okay? When you look at the PR interval, it is varying, right? PR interval is varying. I'm not talking about normal or reduced, I'm talking about varying. Yes, you have more P's and less QRS, and the PR interval is varying. Okay? When you look at the RR interval, the RR interval is also varying. And another clue, right? So here you have a dropped beat. So the PQRS complex, that is the PR interval, after the dropped beat is the shortest, and the PR interval, which is coming before the beat, is the longest. So this is again a case of second degree tech-mode AV block. Right? So whenever you look at an ECG, just ask this question: yes, P more than QRS? Yes. Are there non-conducted P waves? Yes. There is QRS which is not following a P wave? Yes. Are there PR interval variation? Yes. Are there varying RR interval? Yes. Then you call it as a second degree tech-mode. Okay. I will see this. Okay. You have a okay. Now look at this ECG. The obvious ones, right? I will start from here. You have a P. Okay. You have another P here. This is the P wave, right? You have another P here. You have another P here. You have a P, 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 P. When you look gross up, you look like the PR interval is much more. You will drop QRS therapy. It is very short. Your PR interval is short. In your long, much more long, then it gets stopped. But when you look closely, you have a small positive deflection here. I'm not sure whether you're able to see it. You have a small positive deflection here. So that is an hidden P wave. Okay? Again, here you have a small positive deflection. Okay? So that is another hidden P wave in that. Again, here you have a small positive deflection, which is an hidden P wave. Okay? Again, you have a small positive deflection here, so you have a hidden P wave. So always look at the ECGs very closely for hidden P waves, or when you have a look at a ECG. So there is a hidden P wave here, you have a small hidden P wave here, right? So now you look at the PP intervals. The PP intervals looks the same. Okay, so you have the constant PP interval. Next, look at the QRS complex. So this is one QRS, this is the next QRS. Okay, third, 4, 5, 6, and 7. Okay, now look at the RR intervals. The RR intervals are also the same. Okay, so always look at the ECGs closely, where it might look like a progressive prolongation with dropped beat, but when you look closely, it looks like there are some hidden P waves inside those complexes. So the PP intervals are the same, the RR intervals are the same, but you cannot assure that this QRS complex is the transmitted impulses from this P wave. That is, there is no relationship between the P waves and the QRS complex. Okay? Yes, so the PP intervals are the same, RR intervals are also the same, but you don't have any relationship between the P waves and the QRS complex. So this is a case of complete hot blocker, third degree AV block. Complete hot blocker, third degree AV block, right? So always look at the ECGs very carefully for hidden P waves. Okay, look at this ECG. You have a P here. You don't have any QRS P. You have a QRS here. You have a hidden P buried in this. Again, you have another P. Here there is another P. Here you have a P wave. P wave. Here you have a hidden P. You have a P here. P. Here you have a hidden P wave. Again you have a P there. P. And okay. So when you cross here, you have many P waves, right, with equal intervals. Right? So this is a PP interval, which is the same in all the complexes. Next, look at the QRS complex, right? So you have one QRS here. Second, this is the third, this is the fourth, and this is the fifth. When you cross the RR intervals are also the same. But this QRS is not the impulses which are switched from the hidden P wave. Okay, so there is no relationship between your P wave or the QRS complexes. Okay. So the PP intervals are the same, intervals are also the same, but you don't have any relationship between the P wave and the QRS complex. So this is just a rough thing, right? So in particularly a block, the problem is only with the PR interval. Okay, so PR interval is prolonged, but the rest of the waves are all normal. All the P waves will have a QRS prolongation. Whereas in secondary type 1, there is a progressive prolongation. Both the PR interval pericyclic program. QRS drop, right? In secondary type 2, PR interval constant. I'm not telling you about normal, constant PR interval. The PR interval is the same with the drop degree. That is secondary type 2. And the third degree. Third degree, like you have many P's and intervals, but PP interval will be the same, RR interval will be the same, but this P cannot be accounted for this QRS. In the P, in the QRS, there is no relationship between the P and QRS complex. Okay? Okay. Next, look at this ECG. You have a P there. There is one QRS complex. In here, when the P, you have one QRS. 2P, one QRS. P, QRS. 2 P's as QRS. 2 P's as QRS, right? So, when the time P wave generate the whole time QRS complex is getting conducted, right? So 2 P's and 1 QRS complex, right? Again, this is a case of advanced second degree AV block. So this is called as 2:1 AV block. Okay, so it should be regular format. Okay, so look at the PR interval, right? For this connected QRS complex, the PR interval is normal, but provided 2 P's are followed by 1 QRS. Okay. So that is called as 2:1 advanced second degree AV block. Look at this ECG. You have a P there, you have a P. Okay, you have a QRS there. Fine. So this is good. Okay. QRS complex. Okay, so 3 P's are followed by 1 QRS complex. For every 3 P, there is 1 QRS complex. So this is called as an advanced secondary 3:1 block. Okay. So we have a P, 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 and this QRS is getting on P, P, third P QRS is getting connected. Okay, P, 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 and QRS. P, 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 and QRS. P, 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 and QRS. So for every third P, 1 QRS is getting connected. Okay. Now we are going to come to the last part, right? When the QRS complex is more than the P waves. Again, there are many flaws in this algorithm as well. Okay. So QRS just the P waves coming out. Just look at the P waves. Okay, again P waves, even though it is called as sinus node dysfunction, again you can categorize into 2. Either say exit block is there and sinus pause or arrest is there. P waves are absent P waves, then you look at the QRS width. Okay, when you have an ECG with no P waves at all, look at the QRS width. If the QRS width is narrow, you call it as junctional bradycardia junctional rhythm. Okay, if the QRS is wide, you call it as idioventricular rhythm. Okay. So when you have a P wave, but P waves are less than the QRS complex. Okay, so again the rate is going to be less than 60, yes, or it can be a normal heart rate as well. Okay, important features to differentiate is between an SA exit block and sinus pause arrest. Both sinus pause and sinus arrest are used interchangeably, right? Do not think these two are a different one. Pause duration rather less than 3 seconds. That is less than 50 flash pauses. Okay, or it should be next. It should be followed by a sinus beat. Okay, when you call it as a sinus SA exit block, you will have a pause. I'll show it in the ECG. Yes. Zoom on. Okay.
Okay.
When you have an SA exit block, if the exit block is all you call it as an exit block, that will be a pause. I'll show you in the next ECG. The pause should be within 3 seconds or less than 15 flash boxes. To call it as a sinus arrest, the pause will be more than 3 seconds or more, or sorry, this should be more than 15 flash boxes. After a pause, it should always be followed by a sinus beating SA exit block. For a pause mode, அடுத்த beat should be a sinus beat. That is, it should have a P wave followed by a QRS complex. Whereas in sinus pause or arrest, it must be followed by a junctional rhythm. Okay, where the P wave will not be there, so the other pacemakers of the heart take over and they start an impulse. Okay, so the problem with SA exit block is, okay, the problem is the conduction of impulses from the SA node. Okay, the generation of impulses is normal, but the problem is conduction of the impulses from the SA node to the left of the atrial ventricles. Whereas in sinus pause or arrest, there is a problem with the impulse generation. Okay, this is another feature, but I think I showed it on the ECGs. Okay, now look at this one. You have a P, QRS, T. You have a big pause here, then again you have a small bump P, QRS, T. Again you have a big pause, then again you have a P, and you have a QRS. Okay, when you count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So it's around 13 large boxes. So it is less than 3 seconds or less than 15 large boxes. Okay, and the beat which comes after this pause is a sinus beat. Okay, so this is a case of SA exit block. Okay, so again there are 3 types of SA exit block, type 1, type 2, type 3, but I'm not going to the depth of it, right? So this is how exit block goes. So you have a normal conduction followed by a pause. Again, you have a normal PQRS, PQRS, PQRS. You have a pause. PQRS, PQRS. Okay. The only problem is the duration of the pause, whether it is less than 3 seconds or more than 3 seconds, and what is the beat which is following after the pause. Here, you have a P wave, QRS, T, then you have a big pause here. And you have a rhythm, but it doesn't have a P wave in front. It doesn't look like a sinus rhythm. Okay, so calculating the number of blocks 1, 2, 3, 4, 5, 6, 7, 8. Right? So you don't have a P wave there. So this is not a sinus impulse, right? So even though it is less than 3 seconds, but it is not followed by a sinus rhythm, you call it as a sinus arrest. Right? Next, look at the PP interval. The third clue to differentiate whether it is SA exit block or a sinus arrest is look at the PP interval. If I extrapolate it here, so if there is supposed to be a sinus P here, this should be the interval. If there is a sinus P, this should be. And if there is a P here, it should have been here, but unfortunately we are not having it, right? So the PP interval, when it is extrapolated, it is not the same for the generating P wave, right? So this is another difference where the PP interval is not the exact multiples of the one which has a QRS complex. Okay, so I'll tell it again. You have a P, QRS, and T, and you have a pause here, right? So next, it is not getting conducted, right? So the next impulse which is not getting conducted is not a sinus rhythm. Okay, so when you calculate the number of large boxes, it is less than 15. Even though it is less than 15, the next impulse is not getting conducted, so this is a case of sinus arrest. Look at this one, right? You have a P, QRS T, you have a big pause. The next impulse is a sinus impulse, right? So even though it appears to be more than 15 pulses, right? The next impulse appears to be a sinus 1, right? Whereas here, you have a P, QRS T, you have a big gap. There is no generation of a sinus P wave. This is a junction error. Okay, so this is a case of sinus pause or sinus errors. This is a case of AZ block. When I extrapolate the number of PP intervals, right? 2, 3, 4, 5, 6, 7, 8, 9. So this is an exact multiple of this PP interval. Okay, so this is another clue differentiating your AZ block from your sinus pause or sinus errors. The PP intervals should be the exact multiples of the one which is preceding the pause. Right. So the last part, look at this rhythm. We are looking whether we are having a junction rhythm or a idioventricular rhythm, right? Both can have bradycardia. Heart rates can be less than 40. Usually junction rhythm have a heart rate between 40 to 60 per minute, right? But important to is look at the QRS complex. That is the first thing. If the QRS is narrow and you have a bradycardia with no P wave, bradycardia is the absence of P waves, narrow QRS. We call it as a junctional rhythm. Again, absent P waves, whereas wide QRS. The QRS is wide. We call it as an idioventricular rhythm. And another clue whether to look for whether it is a junction is we can have an inverted P wave or retrograde P waves. That is the P waves which comes after a QRS complex. Okay, so this is junctional and this is idioventricular. This is another example, right? So you have a no P waves, you have a QRS complex, right? You have a T. And again you have a QRS complex, there is a small P which is coming after the QRS complex. Again you have a T wave and here. If it's correlate, you can have a small bump here. So the P waves are coming after the QRS complex. These are called as retrograde P waves. So retrograde P waves, narrow QRS, bradycardia, you call it as junctional rhythm. So I think I'm done with my slides. I'm not sure how much you have understood. I think most of you would have been sleeping, right? So I think Gunnar might do a better job than me, I guess. So I'm sorry for the inconveniences caused, right? So yeah, and thank you all.
More P wave and less QRS and less QRS and more P wave. In case of P wave is equal to QRS complex, based upon the PR interval. In case of narrow PR interval, it is sinus bradycardia. Whether it is in case of it is prolonged first degree AV block.
Okay, thank you. We are giving you a chocolate because you have attended.
Then P equal to QRX complex, look at the PR interval, normal, sinus bradycardia, prolonged, first degree AV block.
Okay, thank you.
When PR is greater than QRS complex, it is
based on PR interval, constant and varying, second degree AB block. Then PR is again the PR interval varying, it is two types, constant and varying. In that it is second degree AB block and third degree AB block.
Great. Next.
Look for P-waves and QRS complex. If P-wave is present, it is QRS. If P-wave is absent, we should look for QRS complex. If QRS complex is present, I mean narrow, QRS complex is present, it is junctional tachycardia, bradycardia. If QRS complex is wide, it is idioventricular bradycardia.
Thank you.
Number of P-waves is less than 200, we should look at the number of P-waves. If it is present, it is sinus node dysfunction, and it is absent, we should look at the QRS. If it is narrow, then junctional bradycardia. If it is wide, we should it is idioventricular.
Thank you.
Unipolar. Okay, so wherever you see the letter B, that it is unipolar means. Okay.
Okay, we go ahead with the simulation of the bradyarrhythmia. We're all awake now, we're all on the road now. We will go back. Yes. BC1 we have to go. BC1 open the simulation ECGs.
Arvita Ashram ECG BC1. White Town BC2. New Lighthouse BC3. Sand Dunes BC4. Sunapar BC8. Rock Beach BC9. Pondy Marina BC12. Bharati Park BC14. Oracle BC19.
1 minute. Yes. Aimhtyhrra students ready? BC1. Guess who is going to interpret? Did you remember that?
Numbers.
Who is volunteering?
There are 9 large boxes that is each percentage, and there is P wave preceding QRS complex, and after P wave there is QRS complex, so that it is in sinus rhythm, and bradycardia, so that sinus bradycardia. The PR interval is constant, not less than 5 small boxes. PR.
So the answer is sinus bradycardia. Okay.
Sinus bradycardia. Is it okay for everybody? Others, please see the ECG when it is put up. Please see the interpretation. If you have any doubts, just ask us. Yeah.
Any doubts? BC2. Why?
Under beats per minute, a regular rhythm, axis, right axis deviation, in lead flow there is prolonged PR interval, so it is first degree long.
Okay, BC2. Answer is first degree. Any doubts?
Yeah, that is constant.
PS, QRS complex are equal. Oh, any doubts?
Any doubts? Yeah, please clap. At least the team members can clap.
Good afternoon. I am Shaikina from Eimhtyhrra. The heart rate is 40 to 45 per minute. It is of non-sinus rhythm. The axis is left axis deviation. The periods are present and it is of normal morphology. There is a narrow QRS complex. The PR interval is fixed, but there is also some QRS drop in between. So it denotes movements tied to
Any doubts? Think so, she is clear. Okay.
BC2.
myself Shivkumar. Heart rate is approximately 50 beats per minute. It's a non-sinus rhythm. Axis is normal. It's a progressive prolongation of PR interval with sudden drop in QRS complex. It's a type 2 Mobitz. It's a type 2 heart block. In that Mobitz type 1. RR interval is varying.
Any other interpretation as a PG level interpretation?
Inferior wall MI we can see in the 2-3 AVF. And ST segment.
This is Mobitz 1 or Venkibar. Along with that, you also see ST deviations in 2-3 AVF.
Thank you. Give him a round of applause.
BC 8.
8.
Satish Kumar, rate is about 44, absence P wave, and the narrow QRS complex suggestive of junction rhythm.
Okay.
There are no PVS and QRS is narrow, suggestive of junction.
Suggestive of junction.
Next is BC 9.
300. That is the number of large marks.
Igmc. Heart rate is less than 45. Left axis deviation, not a sinus rhythm. Number of P waves is greater than QRS. Every two P waves has followed one QRS complex. So it is a advanced second degree AV block. 2:1.
Number of PVs are more than number of QRS complexes. For every 2 PVs, you are seeing 1 QRS complex.
Yes.
2:1. AV, 2:1.
2:1 AV block. Everybody is clear? Yes? Okay. Please give a round of applause for
Next week, BC 21.
21.
This is Prashant from Igmc. My ECG, the heart rate is 40 and it's a regular rhythm, and there is a right axis deviation and it's a non-sinus rhythm. It's non-sinus rhythm because every PR is not followed by QRS, and in my ECG the PR interval is varying, and but the RR is constant, so it's a 30-degree heart block and it's a complete AV dissociation.
So, AV dissociation is there, PV interval is constant, R interval is constant. And this is CH, so you can also see the hidden P waves within the QRS complex. Okay, you can map the PP interval and connect it across the leaf. You can see hidden P waves. This is CH. Any dots? Next team.
BC
12, BC 12. So this CCG has 2 segments. First we'll interpret the first segment.
Sir, first segment B7, sir, QRX 6, then constant RR interval, second degree AV block, sir. Then segment 2, PR interval, then type 2 AV block, then 2:1 conduction block.
In the first segment, second degree AV block of which type?
Type 2.
Okay. So in the first segment, we are having Mobitz 2 or second degree AV block type 2. And in the next segment, we are having IDV 2:1 AV block. Any doubts? Next team. BC 30.
BC 40. Sir, next one.
BC 40.
Heart rate is around 50 and rhythm is not in, it's not a sinus rhythm. can see more P waves than QRS, and the PR interval is varying while R interval is constant. So it's purely
So this is complete output.
Complete output. Yeah. ECG number?
90.
Others, please see the ECG. If you have any doubts, just ask us.
I'm Arvind from Igmc. The heart rate is 40 beats per minute. There's a non-sinus rhythm. Axis is normal axis. There are more P waves than QRS complexes. Also, the PR interval is constant. So it is second degree type of heart rate.
Yes, thank you.
So now will be this coronary artery anatomy. So here you see root of the aorta, from which two coronary arteries are arranged, right coronary artery and your left coronary artery. Your left coronary artery again divides into left circumflex and left anterior descending. Okay, so these are your three main coronary arteries: right coronary, left anterior descending, and left circumflex. Okay, so this is the basic pathophysiology for ACS. So due to atherosclerotic plaque, your blood flow is getting reduced. So at this stage, patients will have chronic stable angina. That is, only when they exercise, they will have increased demand and the coronary arteries will not be able to meet the supply. So there will be demand supply mismatch and patients will have chronic stable angina. Once the plaque ruptures, can lead into two things. Either it can completely occlude the vessel or it can occlude the vessel incompletely and still there is some flow. So when it is completely occluding the vessel, it will result in ST elevation in ECG and it will lead into transmural ischemia. Okay. Whereas when the atherosclerotic plaque rupture results in incomplete obstruction, then it results in either extended or unstable angina. Okay. So basically your coronary arteries are separated from the epicardium. Okay. So here you have your endocardium, then subendocardium, myocardium and epicardium. If all these layers are involved, then it is called as transmural ischemia, which occurs in STEMI or your complete blockage of the coronary arteries. Only when the subendocardium is getting ischemic infarction, then it is your subendocardial ischemia, which occurs in end-stage. Okay. So this is what I told you. So if the full muscle layer is getting affected, endocardium to epicardium, then it is transmural. Only the subendocardium is involved, then it is subendocardial ischemia. So only when the vessel is completely occluded, it results in transmural ischemia and it results in ST elevation on the ECG. Okay. In all other conditions, you will not see ST elevation. ST elevation only when there is complete occlusion. In other conditions, you will see ST depressions or T wave inversions, under or T wave inversions. Okay. So basically, you can divide ACS based on ECG into two main categories. If you see ST elevation in ECG, then it is STEMI. If there is no ST elevation, then you do cardiac biomarkers, and if cardiac biomarkers are positive, then it is end-STEMI. If it is negative, then it is unstable angina. Okay. So there is no difference based on the ECG between end-STEMI and unstable angina. Okay. Both these end-STEMI and unstable angina can have STT plus T wave changes. Clear? So now coming to some these basics have been covered already. The end of your QRS complex is called the J point. Okay. So this is where we measure ST elevation. Okay. Reference point for measuring ST elevation. Next is, so this is your ST segment. The period between your ventricular depolarization and ventricular depolarization. That is between your QRS and the onset of T wave. This is your ST segment. Normally ST segment will be flat. Okay. So this is your cardiac action potential. Basically, the ST segment represents the phase 2 of your cardiac action potential. Okay. In phase 2, there is no net electrical action because potassium goes out and calcium comes in. Okay. So the net charge is 0. That is why in ECG the ST segment is flat. Whereas what happens in MI is this net potential gets altered and you see ST elevation or depression. Okay. So coming to the baseline. So this is ST segment. So to compare whether ST segment is elevated or depressed, you need a baseline, right? So what is the baseline? So this is TP segment, this is PR segment. Okay. So actually there is no clear-cut answer for this because some authors say that TP segment should be considered as a baseline, whereas some authors say TP segment should not be considered as baseline. PR segment only should be considered as baseline. Okay. Because sometimes in pericarditis TP segment will be downsloping and that time you won't have a baseline. Okay. So So you can remember either one of this, TP or PR at your level. Okay, don't be confused. TP or PR, both you can use. Okay. Only in graph scenarios you will have confusion. Next, as I told you earlier, so once there is transmural ischemia, the leads which are facing that part of the myocardium, suppose if inferior part of the myocardium is getting infarcted, that leads will be showing ST elevation. The opposite leads, the root, suppose pains are inflow-alarming, the inflow leads will be showing ST elevation. The leads which are opposite to the inferior walls, are other leads, anterior leads will be showing. The change is opposite to this because those are looking at the arch from a different angle, exact opposite angle. So those leads will show ST depression. These are called as reciprocal changes. Okay. So in STEMI also you see both ST elevation and ST depression. Okay. In the walls which are getting involved, in the walls which is having STEMI, you will be seeing ST elevation, and in the opposite walls you will be seeing ST depressions. Okay. Whereas in subentennial ischemia you will not see any ST elevations. You see only ST depressions and TA inversions. Okay. So now here just identify if the ST segment is flat or is there any elevation or depression. What is the ECG? ST segment is flat or flat. Okay, so it is the same baseline as your TP or your PR. Okay, it is not elevated, neither elevated nor depressed. What happens in this ECG? There is ST segment elevation. So here you can see this is your PR segment. Here clearly at the J point, if you take the reference, clearly you can see ST segment elevation. This ECG, you clearly see that ST segment is depressed. Okay. So there are many morphologies of ST segment elevation which Ramesh has already covered. Can be convex upsloping, straight horizontal, downsloping. Okay, all these are not important. You just have to identify whether there is ST segment elevation or not. Okay, all these can be seen as state. Okay. Now, coming to one another important morphology of ST segment elevation. So here, is there ST elevation or not? ST elevation present or not? Okay, so some beginners do not pick this one. Okay, because they think that this is your ST segment. Okay, so just try to play and just showing how it actually progresses. So basically, initially it starts like this. Okay, so here you can see ST segment elevation. Okay, so this is your PR section, this is the baseline. Here you can see ST segment. Once it starts progressing, this will rise so high. Okay, and it will become like this. Okay, so sometimes we will misinterpret this as no ST elevation. So just to compare and tell you. So initially it will start like this. Once it goes till this level, you will be seeing this one. So this is basically called as tombstone elevation. Okay, you should never miss this on a ECG. Tombstone ST elevation. Okay, like the tombstone which you are seeing here. Okay. Okay. Now coming to the STEMI diagnostic criteria. So how much ST elevation and how many all these things. Okay. So basically this is a ECG paper. So this is your small box. Okay. This is your small box. So we are just going to talk about the height. Okay. Because for ST elevation we are just going to look at the amplitude. Okay. So each small box is 1 mm. Okay. Just remove that which is mm. Okay. So each small box is 1 mm. So now, as I told you earlier, J point is the reference at which you will measure how much ST segment elevation is there. So this is your PR segment, the baseline. So at the J point you measure how much ST elevation is there. So here you can see 1, 2, 3, 4. So 4 small boxes. So here there are 4 mm ST elevation. Clear? Okay. So in this ECG, can you count how much ST elevation is there? So this is the baseline. Around 2.5 mm. Okay. Here again. So this is the basic PR segment. Here you are seeing around 6 to 7 mm ST elevation. Okay. So as I told you earlier, the morphology of ST elevation is not important. Just see whether there is ST elevation or not and calculate the amplitude. Okay. So can people from this side tell how much ST elevation is there in this? This is the PR segment. How much ST elevation is? Around 5 mm. Okay. People from this side, can you count and tell me how much ST elevation is there in lead 3? This is the baseline. How much mm? 3 mm. Okay. 3 to 4 mm. Okay. Okay, clear? So now coming to the diagnostic criteria. So for diagnostic STEMI on ECG, you should have new ST elevation. Okay, ST elevation should be new and it should be at the J point in at least 2 contiguous states. Okay, so we'll see what are 2 contiguous states later in the slide. So there are cutoffs for each state. Okay, so new escalation at the J point in at least 2 contiguous states. So how much mm should be there is in all leads there should be at least 1 mm of escalation. Okay, in all leads there should be at least 1 mm of escalation except in few leads. So in V2 and V3 they have different criteria. Okay, 1 mm escalation is not significant to call it as state. Okay, in V2 and V3 for females we have cutoff of 1.5. For males less than 40 we have cutoff of 2, and for males more than 40 we have cutoff of 2.5. Okay, clear? In V2 and V3 1.5, 2 and 2.5. Females, males less than 40 and males more than 40. Clear? And your right-sided leads, as we have covered today morning. So if, when you suspect Aimhtyhrra, you will also take right-sided and posterior leads. Okay, so when you take right-sided leads, 0.3 mm estimation is significant in right-sided leads except in males less than 30, which you don't see commonly. Okay, so just remember for right-sided leads and also for your posterior leads, V7 to V8, V7, V8 and V9, 0.5 mm elevation is significant. Okay, clear? So this is the same thing. So this slide I want to show because for diagnosing STEMI, do you need proponents or not? You need cardiac biomarkers to diagnose STEMI. Suppose you are suspecting STEMI, you want to thrombolize the patient or activate the cath lab. Okay, so you can do all these things just by looking at the ECG and asking history. Okay, you don't need cardiac biomarkers. Okay, so ECG in STEMI is that much important. Okay. So coming to this ECG, so now it is the contiguous leads. So this is the ECG lead placement. Okay, so normally we do this V1 to V6 plus your lead limb leads 1 area, 2, 3 in areas. Okay, so as you can see here, V1 looks at the right side. Okay, V2, V3, V4, V6 looks at the anterior portion of the myocardium, LV. So your V1 and V2 looks at the septum. Okay, V3, V4 anterior, and your V5, V6 are lateral. V5, V6 along with that 1 and AVL are also lateral. So 1 and AVL are specifically called as bilateral leads. Okay, so V1 to V6 are totally anterior. Separately, if you want to tell V1, V2 septal, anteroseptal, V3, V4 anterior, and V5, V6 lateral. Okay, and 1 and AVL high lateral. And here you have leads 2, 3 and AVL. They look at the art from the inferior aspect. So these are the 2, 3 and AVL for inferior leads. And on top of that, we have additional leads like V7, V8 and V9, which look at the art from the posterior aspect. Okay, so those are posterior leads, and your right-sided leads are here. Look at the right side of the art. Okay, clear? So this is how just placed. V1, V2 septal, V3, V4 anterior, V5 and V6 lateral, 1 and AVL high lateral. These are your right side leads, V4R, and V7, V8 and V9 are your posterior leads. So this is how you actually see in a 12-lead ECG. So if you have, so these are your contiguous leads. Okay, so 2 contiguous leads means you should have estimation. So 2, 3 in AVL, all these are considered as inferior leads. So in these 3 you should have at least 2 leads. Okay, 2 contiguous leads. So if you have, should have estimation in 2 and 3. Okay, at least in 2 and 3 to call it as 2 contiguous leads. Suppose you have estimation in lead 3 and estimation in AVL and it is fitting 1 mm. Can you call it as STEMI? Because they are not contiguous. Okay, now we can't call it as STEMI. Okay, so 2, 3 AVL inferior. These are contiguous leads, and 1 AVL high lateral, V5, V6 lateral, and totally V1 to V4 anterior and septal. Okay. So same thing which I mentioned, 1 and AVL high lateral, V5, V6 lateral, V1 and V2 septal, V3 and V4 anterior, and 2, 3 AVL for the inferior leads. Okay. So maybe if you are taking additional ECG leads like your right-sided leads or posterior leads, then you suspect Aimhtyhrra. Okay. So whenever you have estimations in 2, 3 in area, you have to take additional leads to diagnose right-sided MI or posterior MI. So this has been covered already by Surendra today early morning. So can someone look at this ECG and tell me what all you see in this ECG? Whether it is fitting STEMI diagnostic criteria or not? Fitting? Okay. 2, 3 areas estimations are there, and it is clearly more than 1 mm, and there are also estimations in contiguous leads. Okay. So as I told you earlier, the leads which are looking at it from a different direction will have reciprocal changes or ST depressions. Here you can see 1 and AVL. Okay. In 1 and AVL you are seeing reciprocal ST depressions. Clear? Okay. This one, is this fitting semi-diagnostic criteria or not? Yes or no? Yes. Here you are seeing estimations in lead 1 and AVL. Okay. So lead 1 and AVL are both looking at the eye lateral leads, so they are continuous. Okay, again this one. You are seeing estimations in which all leads? V1, V2, V3. Okay. Okay, so are they continuous? Yes. So this is anteroceptal end. Okay. As we told you earlier, you can also see ST depressions in other leads. Okay, this is also a very important thing. If you are just seeing ST depressions without reciprocal ST depressions, you should consider other diagnosis like pericarditis. Okay, that kind of something considered. This is almost the same ECG. Here you will also see V1, V2, V3, V4 and V5. So this is extensive anteroceptal with reciprocal changes. Again, confirming that this state. What are this? ST are present or not? This is what I showed you, right? Tombstone ST. Okay, this much ST are there. Okay, so here you are seeing ST in V1 through V6 and also in 1 and 8. So extensive anterolateral limit. Okay, with reciprocal changes. Always look at the other leads to confirm whether there are reciprocal changes or not. If there are no reciprocal changes, again you have to think about the diagnosis. If this is really stable. Okay. This one. Estimations are present in which leads? Inferior. So this is inferior line. Confirm that other leads are showing ST depressions. Okay. So one more thing which I wanted to tell you is, as I told you earlier, in inferior limb you will be taking right-sided leads and posterior leads. So right side. So sometimes we usually take only V4, V5 and V6 we place. Sometimes we can also place all the leads. All these V1 and V6 you can interchangeably. The most sensitive is V4R. Okay. If you see 0.5 mm distillation in V4R, then it is inferior limb with the right ventricular limb. Okay. And these are your posterior leads. These are V8 and V9. Again, these are V8 and V9. What is the cutoff? 0.5. Okay. So whenever you have a patient with inferior limb, take right-sided leads and posterior leads also, and see if there is any estimation. Okay. So one more thing which I wanted to tell you is, just by looking at the 12 lead ECG also, you can have an idea whether this patient is having posterior or MI or not. So here you are seeing V1, V2 and V3 are looking at that from the anterior aspect. Okay. V7, V8, V9 are looking at that from the posterior aspect. So V1, V2, V3 are exactly opposite to V7, V8, V9. So whatever changes happening in V7, V8, V9, those changes will be reciprocal or exactly opposite in your V1, V2, V3. So when you are seeing in V1, V2, V3, if you are seeing ST depressions, then it can be a reciprocal change of a ST elevation which you actually see in posterior leads. So that is what I am showing here. So here you can see tall RVM in V2, ST depression in V2 and a positive EVA in V2. So all these things, if you take a posterior leads, you will see like this. Okay, actually if you take a posterior lead, you will be seeing the Q wave, ST elevation and T inversion which you normally see in stent. Okay, so when you are suspecting posterior and just by looking at the 12 lead ECG, what I can do is you can take the ECG and flip it across. Okay, invert it and see whether it is mimicking a stent, Q waves, ST elevation and T inversion. So whenever you have inferior limb with ST depressions in V1 to V3, also suspect posterior limb and take posterior leads. Okay, here which leads are showing ST elevations? V2, V3, V4, V5, V6 and 1 and 8. So this is again anterolateral. Okay. Okay, here which leads are showing ST elevations? 1 AVL and V2 to V5, V6 also, and reciprocal changes are there or not? Which streaks are showing reciprocal changes? These 3 and AVL. Okay, inferior leads are showing reciprocal ST depressions. Okay, clear? Any doubts? One more thing which you wanted to cover is, in the very early phase of your staining, what happens is, so this is how it usually progresses. Okay, here there is no occlusion. Once occlusion is happening, first thing which you will see is hyperacute TAs. Okay, so after that only ST elevation starts. Okay, this is what we have discussed in ST elevation. So what happens after that is, as time progresses, you will have Q waves, which is associated with constant, okay, and here ST elevation. So as time progresses, you will also see Q waves with T inversions and ST segment elevation. Slowly, over days to weeks, your ST segment returns to baseline, and you still have T inversions and Q waves, and over years you will just have Q waves, which are a sign of holding function. Okay, so this is how it usually progresses. So the thing which I want to concentrate here is about your hyperacute TVs. Okay, so we'll see this ECG. So see this ECG and tell me if you see any abnormality. Okay, see this ECG. Are there ST elevations? ST elevations are there? Which leads? Lead 3? V2, V3. Okay, maybe 1 mm or 1.5 mm. Okay, not so significant. Anything else? You are seeing reciprocal ST depressions in any leads? Only T inversion is there in lead 3. There are no reciprocal ST depressions. Okay. In this, do you see ST elevations? This is the baseline. AVR, okay, mild ST elevation in AVR, any other lead? But in AVR you are seeing ST depressions. Okay, so these ECGs I am comparing to the normal ECG. See this normal ECG and the ECG which I have shown you. So here you can see, compare the lead V2 in the top ECG. Top ECG is a normal sinus rhythm, normal ECG without any abnormality. See the ECG on the lower end. Okay, any difference? V2 and V3. What is the difference between V2 and V3 in first and second ECG? T waves. Okay, T waves. So these are your hyperacute T waves. Again, this ECG which I showed you. So here you can see in inferior leads how the T wave looks in this one and how the T wave looks in this one. The 3 to 3 and area. Okay. Here estimation is still not started. Okay, but you are seeing a broad and a tall T wave. Okay, so these are nothing but your hyperacute T waves. So this is how your normal. So this is how your hyperacute T waves. So this will be broad and it will be tall. Okay, so there one more definition for a tall T wave which you see commonly in hyperkalemia. Okay, so in hyperkalemia what happens is it will be narrow based. Okay, it will not be broad like this. It will be very narrow and it will be peaked. Okay, so here you can see broad based, tall and blunted. Here it is narrow based, peaked and tall. Okay, so this is your normal sinus rhythm, which is a normal T wave. Okay, this is how your normal T wave looks asymmetrical. Normal T waves are usually asymmetrical. The earlier part will be very much delayed and the later part will be so fast. Okay, delayed upstroke followed by a rapid downstroke. Okay, in both your process of tall T waves, your T waves will become symmetrical. Okay, T waves will be symmetrical in both hyperacute T waves seen in STEMI and in your hyperkalemia. Here it is broad and blunted, whereas here it is narrow based and peaked. Okay. So basically this is how, if you just see this, you will not forget this. Okay. So just look at these two monomers, the secret level, which they are comparing with the hyperkalemia tall T wave. So what happens in hyperkalemia is, this is your normal T wave, hyperkalemia T wave, where the area doesn't increase. Okay, only the it appears peak and okay. So there is narrow base and it is peak. They get peak interval. Whereas in hyperacute phase of your STEMI, what happens is it becomes widened and broad. So there is increased area under the T wave. Okay. So this I have told you earlier. So this is how it progresses. Hyperacute phase, you see only hyperacute T waves. So if patient present to you with chest pain, significant chest pain, and based on history you are actually suspecting STEMI, but in ECG you are not seeing ST elevations. What you will do, even if you do not pick up hyperacute T waves, what you will do clinically, you should not send the patient back home. Okay, whenever you are suspecting some STEMI or ACS, always make the patient wait and repeat ECG. If you repeat ECG, you will get the diagnosis. Okay, even if you do not have any senior with you, you don't have anyone to consult, you have those, make the patient wait and repeat ECG. Okay. Clear? Okay, next, rest of the ECGs we will see in the simulation. Basically, these ECGs I just wanted to show to see the evolving phase. So here you can also see, along with ST elevations, you are also seeing Q waves and T inversions. Okay, so these are a little bit later. Okay. Also in this ECG, you are not you are seeing a D QA followed by ST elevation and T inversions. Okay. So in this ECG, again you are seeing D QAs in leads 2, 3 and AVF, ST elevations, and some T inversions are starting to appear. This is ECG. So is this STEMI or not? So what are I taught you? Applying. ST elevation of at least 1 mm in 2 contiguous leads, is it present? So which all leads are showing ST elevations? 1 and AVL. Okay. Any other leads? V5, V4, V5, V6. Okay. And lead 2 is also showing ST elevation. AVL is also showing ST elevations. Okay. According to criteria, actually it is following more than 2 contiguous leads and it is more than 1 mm. Are you seeing any reciprocal changes? Any lead is showing reciprocal changes apart from area? Apart from area and E1. So this is actually a pericarditis. Okay. So this ECG, here you are seeing ST elevations in multiple leads. You are seeing ST elevations from right from V3 to V6 and also in 1 AVL, 3 and 8, 2 and 8, 3, 2 and 8. Okay. But apart from your area and E1, you are not seeing ST depressions in other leads. Okay. As we are seeing in neurology, you are seeing ST depressions from 1 and AVL, and in microbiology, you are seeing ST depressions in inferior leads. So whenever you see ST elevations in multiple leads without reciprocal ST depressions, always think about other causes of ST elevation. Okay. There are many causes of ST elevation. So this ECG is actually pericarditis. Okay. Here you can see. So area actually is the extreme lead which is placed in the extreme-most axis. So whatever changes are there in the other lead, it will be exactly opposite with the area. So ST depressions in area are not considered as reciprocal. Okay. So this is actually a case of pericarditis. Thank you.
STEMI. The difference will be the need of management. STEMI occurs because of the complete occlusion of the coronary blood vessels. Whereas in case of Eimhtyhrra happens when there is an ischemia is there and infarction of the cardiac tissue is there. Unstable angina when there is no infarction, just a ischemia is there. So this is the basic difference. But clinical picture, diagnostic part and the management, irrespectively, it is going to be the same. Even the ECG is going to be the same in unstable angina and Eimhtyhrra. Okay. So the definition, this is the definition given, it's an internationally accepted definition. When you will call it as an Eimhtyhrra or unstable angina for that matter. Now hereafter we will going to discuss, Eimhtyhrra includes both Eimhtyhrra in ECG and unstable angina. Okay. It exhibits, there is a transient ST elevation. So they given a cutoff of 20 minutes. Even though ST elevation is there, that should be a persistent ST elevation, more than 20 minutes, then only it will come under STEMI. If it doesn't come, if it is like ST elevation is there, then it is spontaneously reverted, then you have to manage this patient as Eimhtyhrra. This is criteria number 1. That is transient ST elevation, the time cutoff is less than 20 minutes. Second criteria, ST depression or STT changes are there. Next T wave, in T wave it can be T wave inversion or flat T waves will be there. This is the international task force definition for acute coronary syndrome, particularly Eimhtyhrra. Okay. So one thing about this STT changes might have been like old changes or maybe secondary to other QRS. In relation to QRS, STT changes will happen. So how we will identify is, if you have a doubt, so you have to take a serial ECG. When there is a dynamic STT changes, it is most commonly, and the patient presenting with ischemia complaint like chest pain is there, and it is most probably of MI. This dynamic STT changes will give the more probability that it is because of myocardial ischemia. So coming to the morphological criteria of ST depression, the cutoff is, as per the international task force, what they have given the criteria is ST depression of minimum more than 0.5 mm. So it is given us at the voltage. In voltage it will be of 0.05 millivolt they have given. If in ECG if you see, it will be of at least 0.5 mm in 2 continuous leads. When it comes to STEMI or Eimhtyhrra, they are given the cutoff of 2 continuous leads, it should have this same changes. If it is 0.5 mm, that means less than 1 small box, half of small box. So remember, less than half, that is half of small box. If it is there, it means it is, you can take it as this ST depression is significant and it is an evidence of STEMI. Okay. So whereas what are the other points means, if it is more than 1 mm, it is most probability, the probability is increasing for it to be STEMI. And if it is more than 2 mm and it is present in more than 3 continuous leads, this patient is having very high mortality is there. So better earlier intervention will be required. There are 3 patterns of ST depression will be there. It can be downsloping, horizontal or upsloping. So downsloping and horizontal are more towards the myocardial ischemia. So coming to before going to the next slide, I need your attention a little bit more. Those who are sleeping, just wake up and then listen to this. This you have to understand STEMI, why ECG changes are happening. When first ischemia started happening, the first thing to go change in ECG is T wave. Repolarization will be the first affected in ECG, so the first changes will happening in T wave because T wave represents what phase of cardiac potential, action potential? T wave represents louder. What phase of action potential? Phase 3. So that is relative refractory period. This is a depolarization phase. Phase 1 to phase 3 represents repolarization. In that, phase 3 represents relative refractory period, and that will be equivalent in the T wave. Okay. So that will be the first thing to get affected. When it doesn't needs to develop infarction, ischemia is more than enough to change cause a T wave changes. So T wave will be the first affected. Even in STEMI, what is the first thing you will see? In STEMI, what is the first thing? Hyperacute T waves. So the T waves will be the first thing go under problematic. In ECG, it will be manifested. First will be T waves. If T waves are like a hyperacute, means it is like complete STEMI. It will go for T inversion in case of subendocardial or transmural ischemia. Okay. Second thing will be undergoing this. ST segment also represents phase 2 of action potential, and it is also a repolarization. So first is T wave will be affected in MI. Even there is ischemia, followed by ST segment, followed by QRS complex. Okay, so it's going to be the same. If it is STEMI, complete occlusion is there, it is going to manifest as ST elevation. If there is incomplete occlusion is there, it is going to, and subendocardial myocardial ischemia is there, it is going to manifest as ST depression. So understand this, so it will be very easier. So if as like STEMI, where you can localize according to the ST elevation pattern, in STEMI there is no specific like ST depression to particular leads. It will means like there is an ischemia. So mostly it will be diffuse ST depressions will be there. And the morphology, but one differentiate is, as Dr. Elita has mentioned before, reciprocal changes. Okay, so reciprocal changes will be seen in the reciprocal leads. For anterior, which is the reciprocal leads? For anterior leads, MI, which is the reciprocal leads? Posterior. So posterior is represented by what are the leads? V7, V8 and V9. Okay. In case of posterior MI, which will be where you will see the ST depression reciprocal changes? Anterior. So except for this condition, where here V1 to V4, if you are seeing a patient is having ST depression, you should think about posterior MI. You isolated posterior MI. Rare, but usually posterior MI will not present isolated, it will present either with the inferior MI. Very rare scenario, V1 to V4 you will find only ST depression will be there. You should not treat it as STEMI. You have to take the posterior leads and to confirm the posterior MI is there or not. This is one scenario where reciprocal changes will be there, only as a ST depression will be there. Rest of the scenarios you will see the diffuse ST depression will be there. So among it, there are few AVR and all, you will see as a normal phenomenon. Lead 3, AVR and V1, V2, you can see it as a normal phenomenon. So if someone from the third row, can you just tell what are the findings? You guys have been continuously like interpreting ECG for a very long time. Is someone? Okay. Black shirt, right? So can you just interpret what are the findings related to my session? So which are the leads you can see the ST depressions? So we are just different. What is the criteria for ST depression?
Can you be a little louder? Someone please, your mic open. Mic.
So whichever leads you think there is a ST depression. The criteria for, as discussed, the criteria for ST depression is one small box is enough, or half small box is enough. So based on that, whichever leads you think there are ST depressions are there. Let's start from the first corner. Lead one? No. So always, I think that part also Dr. Elin has covered, which you will take it as isoelectric. Both you can take TP as isoelectric and PR also as isoelectric. If you compare that, if this is the TP segment, do you think this is depressed or not? Yeah? When compare this, this is depressed. What about this? Is there or not? Lead 3? VAVF? What about lead AVF? No. What about AVR? What is the difference here? AVR is presence of ST elevation is there. Okay? We will go back there. Why there is there? What about V1? ST elevation is there. What about V2? As per that criteria, V2 it is not having. V3, ST depression is there. So all the lateral is having. So this you can treat it as end-STEMI. Usually, clinically speaking, we will treat this as end-STEMI. But one thing you have to remember is diffuse ST depression with AVR ST elevation as a special case. There are a few conditions which critical conditions will cause AVR ST elevation along with diffuse ST. Please sit down. Thank you. These are the conditions you want to remember. First, LMC occlusion, left main coronary artery occlusion. It doesn't have to be acute, complete occlusion, whereas a critical stenosis what possibly is LMC occlusion. Second thing, triple vessel disease. Third important thing is the patient is to be having proximal LAD stenosis. Fourth condition is type 2 MI. It's a type of type 2 MI where there is a supply demand mismatch is there. Those conditions, this patient will have ischemia and there will be diffuse ST depression with AVR ST elevation will be there. Particularly, while proximal LAD, there will be AVR ST elevation. It is anterior. Proximal LAD will be supplying left side. AVR supply mainly indicates the right side. Why there is an ST elevation is there? What are the other points? See, AVR represents the basum of the heart. It also represents the basal area of the heart. The septal branches arises from the LAD. The first branch, the very proximal, it arises from the very proximal LAD. If there is an occlusion proximal to this, from the LAD, the first branch will be either septum S1 or diagonal branch. If there is an occlusion before giving off this branch to S1, because septal branch, first septal branch supplies the basum of the heart. If occlusion is very proximal to it, then it will manifest as ST elevation in AVR and V1, V2, V1, V2. Okay. These are cases you will see AVR expression, that is for proximal LAD. Other cases you will be ST depression. Whereas in case of LMC occlusion or triple vessel disease, you will see multiple leads showing ST depression will be there. Okay. So coming to this next lead. So green shirt. So can you just tell me which are the leads you are seeing ST depressions here? And what are the findings you see?
ST depression is seen in lead 1, 2, and AVL.
Very good.
AVF.
Yes.
AVL and AVF.
Yes.
And there is ST elevation in V4, V5 and V6.
V4, V5, V6. Can I just want to revise the statement? Do you think it's ST depression or ST elevation?
ST depression.
Yeah, it is ST depression. ST elevation you can see only in AVL. Okay. So this leads, it's again going to the same. So this is what I said, it's about proximal LAD. Please sit down, thank you. So this is the proximal LAD where there will be ST elevation will be there here in V1, V2 is there and hyperactive TVS in V3 and AVR ST elevation there, whereas you can see other places having diffuse ST depression. Okay, this is a case of proximal LAD occlusion. I think it will be very okay. So this I think we have discussed. Reciprocal changes because of STEMI in the posterior, particularly more important in STEMI. And one more point I forgot to mention is, see, when ischemia started developing, first thing what changes will be there is going to be same in T waves. Okay, so for the STEMI to develop, rather than the direct STEMI has developed, the first changes will be seen in the reciprocal leads. You will see the T inversion and ST depression in the reciprocal leads first, when in some scenarios, then ST elevation will start developing. If you are seeing in the reciprocal leads, okay, there is ST depression. For example, if the patient is having high lateral wall MI, it will be seen in lead 1 and AVM. Okay, when sometimes what happens, only ST depression you will see in the inferior leads. You should not assume that there's a NSTEMI of inferior leads. You have to assume there's a possibility of high lateral MI. You have to give what is the importance of it. The treatment will vary. In case of STEMI, you need to take on immediate reperfusion. Whereas in case of NSTEMI, it will be usually medical management. Again, depends on the clinical scenario, the treatment is going to say. So have a high index of suspicion for STEMI. So, yeah, at this point, just we'll go to the ECG first, then we'll come back. So there is one atypical ECG we can call it as. Usually, if there is a complete occlusion, what will be the manifestation? It will manifest as STEMI. In LAD stenosis or in LAD occlusion, there is one different pattern. Anterior MI, there is one different pattern. At least 2% of patients is having LAD or LAD or proximal occlusion and STEMI. They will show this ECG pattern. The last one, yeah, you. Give it to him. So can you please tell me interpret this ECG? Huh? It's a wall test. Okay, fine. They are not attending the class then. Okay, that row, whoever you prefer, you give it to them. Okay, stop. Give. Yeah. Just interpret what are the findings. Yeah, give it to her, give it to her. Okay. You can sit down and then it test. I have been given only 10 minutes, so finish fast. So what are the findings you are seeing in this ECG? You have seen a lot of normal ECGs, right? So related to that, what are the findings you think there are changes in this ECG?
Hyperacute T.
Hyperacute T waves. Very good. Then let's go with the approach what you have taught you from morning. PQRST. What about P wave? Anything is there? Anything wrong about P wave? Is it sinus? Is it sinus? To say the sinus, what should be there? In which lead it should be positive or negative? One or something else? One and two. More in the one. Sorry, two. Two is more. Why two you have to take? Because it is along the long side of the heart. So you have to take lead 2 and AVR predominantly. Lead 2 it should be upright. So it's still not over. Be with you only. So AVR, lead 2 it should be upright and AVR it should be negative. But this case is a ulta. Okay? You see, lead 2 it is negative. Lead AVR it is positive. So it is not a sinus P wave now. Okay? This way, next QRS. Sorry, PR interval it is looking like narrow. Apart from that, what about QRS? What are the findings in QRS? The one with mic. This is yours. Sorry, with QRS, is it narrow complex or not? Is it appearing narrow complex or not? What is the criteria to call this white QRS? How many small boxes? Minimum. Say more than 3 small boxes, you have to take it as white QRS complex. This looks prolonged or not? Okay, fine. See here, in this, where it ends, this is the J point over here. Okay, acute waves you are told. What about ST interval? ST segment? It's not able to see. This is the J point. From the J point, there is an upsloping of T waves there, followed by hyperacute T waves. Upsloping of ST depression with upsloping pattern with hyperacute T waves. And which are the leads you are seeing this pattern? Entire anterior leads you are seeing. Okay. When a patient is coming with chest pain, and this is what ECG is showing. This indicates there is a complete occlusion. It is called a STEMI equivalent. So the guy who was discovered or found this pattern, it has been named after him. That is why it is called as D ventus T wave. Thank you. Please give the mic to them. So the criteria is first is upsloping ST segment depression more than 1 mm at the J point in the precordial leads. Second criteria, tall prominent symmetrical T waves again in the precordial leads. Third, absence of ST elevation. Fourth, ST elevation may be in the AVR more than 1 mm. Then typical STEMI morphology may or may not proceed before this. What is the importance of this? Usually hyperacute T waves will wait for it to for thrombolization or not. Whereas in case of DV test, you have to take it as like a STEMI, you have to manage this patient. So T inversion, I think we have already discussed. Similar to ST depression, again here the cutoff is 1 mm. If it is like 1 mm in 2 continuous leads, and one more important point is this you have to take only in the leads where R wave is significant or R wave is more than the S wave. Only those leads we have to take it as leads. If there is inversion in that will be taken as significant T wave inversion. It will be only significant if seen in the leads with upright QRS complex. It may be a normal, T inversion may be a normal when it is present in the lead 3, AVR and V1. Okay. Based on this, I think. Okay, this side, green shirt. Yeah, you. Can I just interpret this? No. Okay. Mike. Can I just interpret this ECG for me? So tell me about your findings. What are the findings you noticed? That's only your training. Abnormalities.
Deep S wave in V1.
Deep S wave in V1. Is it normal or abnormal? Is it normal or abnormal? Usually RS ratio will be like S will be predominant in V1. Okay, then. Okay, we'll stick it on to our topic. But what about ST segment and T wave in this? What are the findings you know it as abnormal?
The ST segment elevation.
When you are seeing ST segment elevation?
V1.
V1. It's a little doubtful. Okay, maybe, but I don't see that much actually. It may be insignificant, less than 1 mm. Next. So ST segment is looking grossly abnormal. Sorry, normal. What about T wave? If you ask me, relatively V5 and V6 there is ST depression with the T wave inversions are there in V4, V5, V6, is, and 1 and AVA. So can I take it as MI? Can we take it as MI? So there comes a differential diagnosis. So what is the problem? What is the probable diagnosis of this ECG? You guys have discussed about chamber hypertrophies, right? What is the criteria it is fitting? What is the chamber hypertrophies? Sorry? LVH. So what criteria you guys applied? So what is it? So various criteria are there. You can take a total of 35, you can take. Isolately you take V1 more than around 20, AVL more than 10 mm. So any criteria apply. These are all called as secondary STT wave changes. Because of QRS, because of ventricular depolarization, issue with the ventricular depolarization, it will be reflected in repolarization also. These are called as secondary STT changes. Secondary to what? Pathology is the QRS complex. Okay, if it is directly affecting, whereas in case of ischemia, the pathology is primarily repolarization will be the first one will be affected. This is mostly, this is the case of a left ventricular strain ECG only. This is not a STEMI ECG, STEMI ECG I have shown. So there on comes another concept called as pseudo-normalization. So basically, this will have, patient will come into you with active chest pain. Okay, if the patient comes to active chest pain, you are taking an ECG. ECG may be looking normal to you, but patient will give you the typical history of, and outside ECG may be, there will be T inversions there. Basically what happens is, patient would have developed first ischemia, patient in the phase of revascularization. So once ischemia develops, there will be a T inversions will be there. But again there will be a re-occlusion will develop on the revascularized vessel, then there develops a second ischemic attack. So when that happens, rather than ST elevation, the amplitude will get what you call as compromised. Okay, because it is T inversion. Now it has to develop an STEMI. In the process of transformation, when we take the ECG at that point, it may look normal. So always you have to compare the previous ECG. Okay, so this is more like a, this will manifest again if you leave adequate time, this will become a STEMI again. Okay, and if at all Then one more pattern we want to tell about is Wellen syndrome. So it's a very remembered words for me because my senior, who is very interested in ECG, always call this ECG Wellen syndrome and Brugada. It is his favorite. His name is called as Dr. Brugada. So he will talk. He will give his talk next talk. You will understand who is there. Okay. So coming to it, Wellen syndrome. This is not an actual STEMI. Okay. This is not an acute infarction. It's not an ongoing infarction. Why this is important means, whatever the pathology has happened, it will reach a critical lesion. Particularly, this is again noted in the left anterior descending vessel lesion. Okay, then will reach the critical stenosis. So when you call this critical stenosis in the coronary artery means, if the vessel has been occluded more than 70% in a normal state, when there is a secondary over demand supply demand mismatch is there, then it can develop ischemic symptoms. To produce a chest pain clinically, the vessel should be occluded minimum of 95%. Okay, but in certain cases when the patient is a smoker, when he smokes, he will go for coronary spasm. Even a 50 to 70% also will develop similar manifestation, because normally the flow will be there, but because of the additional coronary spasm, he would have gone for additional ischemia. Patient will have transient ischemia. Okay, when that happens, this patient will be presenting this pattern. Okay, so what happens is, if left anterior descending stenosis is there, there is one typical pattern. It will present as biphasic T waves. First changes will be happening in only the biphasic T waves. This is the one ECG showing that. Here you will see the biphasic T wave pattern in V1 and V2 and V3. So on T inversion you will be seeing in V4. This is Wellen's type 1 pattern. The type 2 pattern is, you will see deep inverted T wave inversion. Okay, so this at that point of time you can just treat it as STEMI, but this patient may develop full-fledged extensive anterior MI in a period of days to weeks. So recognition of the pattern is equally important as like treating a STEMI. Okay, so the differential diagnosis for STEMI will be like yes, it's a very less. It starts with very critical pulmonary embolism to simple right bundle branch block. So I'm not going to this. This you can read everywhere. But the history of chest pain will be there with the patient risk factors with elevated enzyme proponents. Will give you, and dynamic STT changes is one thing which can help you narrowing the diagnosis to NSTEM. Okay, thank you.
V1, V2, V3, and the reciprocation I can see in lead 2 and lead 3 where there is ST depression. Apart from that, I can see peak T waves in V4, V5 and V6. So it is lateral anterior wall MI.
Here is also showing ST.
Rate 75, regular rhythm. There is ST elevation in E1, APL, V2, V3, V4, V5 and V6. There is reverse changes in V3 and APL. Anterolateral is constant.
Any doubts? This is anterolateral state.
So this ECG represents the heart rate of 75 per minute. So P wave is positive in V2 and it's negative in AVR. So it's normal morphology and normal axis deviation. In lead 2, 3 AVR, V4, V5, V6 there is a ST elevation with the reciprocal ST depression and AVL V1 and V2. So represent the inferior-lateral MI. To rule out a posterior or right wall MI, we need to take either V7, V8, V9 or 4R, right 4R.
Anything about the PR interval?
It's prolonged. So it's a type 1 class.
Interval is steady with first degree atrial. T4.
Heart rate is 100 beats per minute. It is regular in rhythm. ST elevation is seen in lead 1 and V2 to V6 and AVL. Downstream appearance is seen. Then reciprocal changes are seen in lead 2, 3, VF and AVR. ST depression is present. Diagnosis is acute glomerular syndrome and through lateral
Good. Downstream elevation you are seeing. Extensive anterior plus lateral. T5.
Myself, Dr. Electrocardiogram from Delhi Medical College. ECG shows the heart rate of around 75 per minute. ST elevation in 2-3 AVF. ST depression in anterior.
Group 6. Group 6.
Fast.
Group 6.
In this ECG, ST elevation is seen in all lateral leads, 1 AVL and V5 AVL, and reciprocal is seen in 2 second lead, third lead, and AVF shows ST segment depression. So lateral wall MI.
Elevation only is 1 and AVL. Okay, this was these are showing ST depression. So this is bilateral state. Team 7.
These are Google measurement from Eimhtyhrra, right? Heart rate is around 88. Rhythm is regular. PR is prolonged, but FDP is followed by QRS. Axis is normal. ST is elevated in 2, 3 and AVF. Inferior means. But reciprocal changes are seen in 1 AVF, V1, V2 change in anterior leads. So maybe posterior, but not maybe. Inferior was posterior inferior. With the first degree heart.
This is internal and with first degree heart block. You will additionally take right side and posterior. TP.
I am Aimhtyhrra. Septal wall 2, negative wave, negative depression with a positive T wave, patient posterior wall MI, reciprocal of V1 AVL with a ST depression with a T wave in V2, posterior MI is V4 0.5 deviation and then right wall extension.
These leads represent V3R, V4R, V3R and V6R. So those are right sided leads. Can you, do you want to change the names?
In this V4R, is there anything you're seeing here? Right side leads only you're able to see here. Yeah, that's what. V4R, is there any ST deviation there? V4R, you see that? There is the ECG. V4R, deviation is there? No, sir. You can check up. So what is the criteria for right side leads? ST deviation? 0.5. Is this 0.5? Is there or no?
Yes. Is that? So, another any other ST elevation changes are there? No, any other leads?
Yes, sir. That is true.
Yeah, what are the changes you see? ST elevation changes. You can see there. So, what are the other areas you can see? ST elevation. ST elevation. Yeah. What are the?
So, this is inferior wall MI with the right side progression.
There is another ECG insert which is shown in the picture.
Yes, post right inferior wall MI, posterior. Since V7, V8 are separated, there is also posterior progression.
Anything else?
Except the RCA approach.
Okay. Any other finding in this ECG? What about the PR interval? So, PR is from so
first degree.
So infrared MRI with RE posterior extension with first degree ECG time.
Rate is around 100 and the is normal sinus rhythm and estimation is seen in V1, V2, V3, V4 and V5. And some estimation is seen in V8. Most probably stimuli. Androceptive. AVL.
I now request Dr. Surendra sir and Ashwin sir to kindly come out to the dais. I request them to felicitate Dr. Avinash Anand, Associate Professor from Tripura. Sir has done his MD in Pediatrics and DM in Cardiology, and Sir's area of interest is Pediatric Cardiology.
Sir?
I'd like to welcome Dr. Kumaresh PT, Assistant Professor in Emergency Medicine from Kalpaka Vinayaka Institute of Medical Sciences. Thank you, sir. Now I request Dr. Avinash Anand sir to kindly come on to the desk.
பேக் வந்துருங்களா?
Good evening, Morena. It's really heartening to see that when I was coming, I was thinking one of you will be tired and most sleepy after a hectic day, but one of you are so fresh and interpreting ECGs with so much vigor. So it's the hard work of Surendra and Ashwin, I think. So congratulations to them before we begin with the talk. So after a tiresome day with adult ECGs, let us just spend some little bit time on basic concepts of pediatric ECG interpretation. So I bring greetings from Igmc. So in this next few minutes, we'll stay together in this quest for pediatric ECGs. So can one of you interpret this ECG for me? whether it's normal or abnormal. So that Dr. Kumasulin has helped us now. So because none of you have volunteered, let us interpret this ECG. So if we interpret this ECG, it's an abnormal ECG because there is sinus tachycardia. The heart rate was a little less than 150 beats per minute. There was right axis deviation, and the QRS axis was around plus 150 degrees. So I think through the day you would have discussed a lot of QRS axis determination. So let us touch upon that in the next few slides. And there was a tau R in V1 fulfilling criteria for right ventricular hypertrophy. And there was reverse progression of R from V1 to V6. And there were inverted T waves in V1 to V3. So it's very, very abnormal, right? So we were telling that the axis was around plus 150. So how did we derive that? So did you discuss about QRS axis today? So you know how to localize the axis, right? So this particular ECG was showing that the lead one was predominantly negative and lead EAV to that be a right axis deviation, right? So we will lead to lead one. AVL. So what is the perpendicular lead to lead to? Okay. AVL. And to lead 3, so lead 3 and AVL are perpendicular. So now when we find that lead 2 is having equiphasic complexes, so you will have to look at lead AVL. Right? So lead AVL, what is the axis of lead AVL? So we'll go to this figure. So this is lead AVL. So this is 1 is 0, so AVL will be minus 30. So if we extend, so we already know that it belongs to this quadrant. And we also find that AVL is predominantly negative. So it cannot be in the positive arm of AVL, which is minus 30. So it has to go to the negative arm of AVL, which is almost plus 150 degree. So if we extend this, it is plus 150 degree, which is in this quadrant. So roughly around plus 150 degree. So that is right axis deviation. Now, can you compare the previous ECG with this ECG? Like, can we try to interpret this ECG? Is it normal or abnormal? It appears to be normal. So, if we interpret this ECG, it appears to be in sinus rhythm. The heart rate is a little less than 100 beats per minute, so volume is for sinus, not tachycardia. Axis is normal. How are we saying it's normal? We go back to the same figure. Lead 1 is positive. Lead AVF is also positive. So which is the equiphasic lead here? Lead 3. So if it is lead 3, then what is the perpendicular lead to lead 3? AVR. So we'll go to AVR. AVR is predominantly negative. So what is the negative equivalent of AVR? So we'll go to this one. So AVR is here. We know that normal axis is in this quadrant. So we'll extend AVR. AVR is minus 150. So if we extend that here, somewhere around plus 30. So plus 30, somewhere around plus 30 should be the axis, which is in the normal range. So this is normal. And there is a normal progression of the R wave from V1 to V6 with a transition happening at V4. So the S waves, there is no big R wave in V1, and gradually we are seeing that R wave is increasing in amplitude from V1 to V5. So this is normal progression. So this is normal. Now, if I say you interpret this first ECG, like all of us interpret ECGs with the assumption that it is an adult ECG, right? So if you interpret this ECG knowing that it's a day 2 newborn, a newborn child who is just 2 days old. So this is the same ECG that we interpreted first. So if you know that it's a 2-day-old newborn, then same findings, the heart rate is a little less than 150, but that is a normal rate for newborn. Okay? And that is right axis deviation, which is also normal for newborn. And the QRS axis is around plus 150 degree, which is a normal rate for newborn. There is a tau R in V1, which fulfills the criteria for right ventricular hypertrophy in adults, but it is normal picture of newborn ECG. And the reverse progression of R from V1 to V6 is also a normal picture of newborns. How it changes over age and how it reaches adulthood we will be seeing in the course of the lecture. And inverted T in V1 to V3 is also a normal picture of newborn ECG. So that brings us to the contents of this talk. Let us always know the importance of knowing the child's age. So when somebody asks you to interpret ECG, the first question that you ask is what is the age of this patient. So if they say it is clearly adult ECG, then you need not worry about the age. But if it's a pediatric ECG, whether it's a newborn, whether it's an infant, whether it's a toddler, all that matters. So why right dominance is there in pediatric ECG and how it evolves to the normal left dominance seen in adulthood, and what is the checklist that you apply to ECGs before interpreting pediatric ECGs. We'll go through a checklist which was published recently, which is very useful. And then we go through certain case-based illustrative examples so that we touch upon most of the important diagnoses which are not to be listed in pediatrics. So we already know that knowing the child's age is important prior to starting to interpret a pediatric ECG. What are the changes that happen from newborn to childhood through adulthood? So RV dominance is a normal feature of childhood because at birth the PA pressure is very high. Because the lungs are not air-filled, they are fluid-filled while in utero. And the systemic vascular resistance is not high, whereas the pulmonary resistance is very high because the lungs are fluid-filled. And the right ventricle is very thick walled in order to push blood against this high pressure zone, which is the PA. And the RV pressure is very high. During infancy, gradually the PA pressure falls, and the RV pulse stress and thickness decrease, and the right ventricular systolic pressure falls to adult levels by approximately 6 months of age. So before 6 months of age, whenever you interpret an ECG, definitely you will find right ventricular predominance. So the RV will be tall as V1, and gradually it will go through a reverse progression instead of the adult pattern that you see. The heart rate, we saw that like usually we expect a heart rate of less than 100 in adults, and whenever more than 100 is present, we call it as tachycardia. But different heart rates are there for pediatric ECG based on the ages, and we call it as tachycardia based upon the normal limits. So once a child is born, the heart rate increases from day 1 of life, and the peak heart rate is reached somewhere between first and second months of life. And then it returns back to newborn values by 6 months, and in the next 6 months it remains stable. That is 6 months of age to 1 year of age, it remains stable. And thereafter, gradually there is a decline in heart rate till after 1 year of life because of the maturation of vagal innervation of the sinoatrial bone. And the normal adult resting heart rate of roughly around 80 beats per minute is typically achieved by mid-adolescence. So such a long time it takes. So till the time, if you interpret a ECG, you will always call it as sinus tachycardia. So knowing the age is very important to call it as a normal ECG before interpreting a pediatric ECG. So let us go to the pediatric ECG checklist. What are the steps that we follow? So first, when you interpret the rate, always see whether it is age appropriate. And all the atrial and ventricular rates same. So you see the P, you see the QRS, whether the P rate and the QRS rate are the same. And then when you want to interpret the rhythm, see that a P wave always precedes the QRS, and a QRS ask a cardiologist's opinion prior to saying that this child is normal. So are the periods negative in area and positive in all other chest leads? So if it is so, it is normal. If the answer is no, then you will have to reevaluate the child. So RQRS complex is positive in lead 1 and AVA. Now the caveat is in a newborn, it is normal to be negative in lead 1. And then we go to the P wave. So what is the P wave amplitude? So normally the P wave amplitude that you say as a cutoff in adults is 2.5 millimeters, right? So here, because newborns are also involved, you take it as 3 millimeters. So less than 3 millimeters is normal. More than that may be taken as abnormal as a sign of RA enlargement. So is the P wave duration less than 80 milliseconds in neonates or 100 milliseconds in children? So 120 milliseconds is the cutoff in adults. So here you take it as 80 for newborns and 100 milliseconds in children. And the PR interval, is it more than 80 milliseconds but less than 200 milliseconds? If the answer is yes, then it falls in the normal category. If it is more, then you are dealing with a long PR where there will be a heavy dissociation. Or if it is less than 80 milliseconds, then you will be dealing with a short PR. Q wave. So Q waves can be normally present in the pediatric ECGs. But what is the amplitude of the Q wave in each lead is given by normograms or pediatric ECGs. So when you interpret Q waves in pediatric ECGs, see if they are falling less than the age-specified normograms. If it is deeper in a particular lead, then it may be an abnormal ECG. So Q wave may be significant in pediatric ECGs also, and we may have myocardial functions in newborns or pediatrics also. So if Q wave is there, do not dismiss it as normal irrespective of the amplitude. So see the amplitude, whether it fits in with the clinical scenario, and if the child is otherwise normal, then it is okay. But if it is very, very large compared to the age-specified Q wave amplitude for that particular age, then you take it as abnormal and then evaluate further for a particular cause that you are thinking. So all Q waves are absent in V1 and V2. So where are the Q waves normally present in an adult ECG? So in which all leads Q waves can be normally present? Without MI being there, without any constant being there. So lead 3, yeah. Somebody was telling lead 3. Lead 3 may have small Q waves. Apart from that, any other chest leads which can have Q waves. So why V5 and V6 have a Q wave? So because of septal depolarization. So septal depolarization normally happens from left to right. So because it happens in this direction from left to right, Q wave by definition is a negative wave. So it happens in this direction, so it will be present in the V5, V6. So these are the left-sided leads. So left-sided leads are here, and the axis of depolarization is in the opposite direction. So you get a Q wave with the V5 and V6, which is normally, which is a normal feature. So if Q waves are absent in V5, V6 and present in V1, V2, then what is it signify? So V1, V2 is somewhere here. That is more likely right-sided, more likely RV. And if septal depolarization is happening in the reverse direction compared to what it should be, then you may get a Q wave in V1 and V2. So what is the condition which causes that? So is there a condition where the ventricles get reversed? Where the RV is in the place of the LV and the LV is in the place of the RV? The previous session, all of you are so active and getting up and answering. Like, it was a fight almost, no? Like many people wanted to answer. So nobody is interested in pediatrics. So anybody can try to volunteer, right? We don't expect you to be right, but you can try. So yeah, transposition of gate is what happens. The answer is in the diagnosis that you're doing. So only the gate arteries get transposed, not the ventricles. So RA is connected to RV and LA is connected to LV. But from the LV, instead of the instead of the aorta, pulmonary artery arises. And RA is connected to RV. From the RV, we expect pulmonary artery to come, but instead of that, aorta comes. So that is TPA. So something similar to TPA. So extracardia, the heart is inverted. Okay. So here the atrium itself is inverted. But the RA is connected to RV only. That is not changed. RA is changed in position, but the RA is connected to RV only. So I am asking for a scenario where RA is connected to LV and LA is connected to RV. Single vertical, yeah, it is possible. But any other classic thing which it happens like what we are asking is LA should be connected to RV and RV should be connected to aorta. So basically, LA blood, the pure blood goes into aorta, and RA blood, the impure blood goes into PA. There is no change in that. Only thing is, the ventricles are inverted. That is, instead of the LV forming the pure blood, the RV forms the pure blood. So basically, the child will not have any cyanosis, child will be absolutely normal. Only thing, RV is there in the place of the LV. What is the diagnosis? So in the diagnosis, classically you will find this Q wave in V1, V2, because the septal depolarization in this situation is from right to left. So somebody was telling transposition of great arteries. This diagnosis is corrected transposition of great arteries. So congenitally corrected transposition of great arteries, CCTG. So here the typical anatomy that we were talking will be present. So the important clue to pick up by ECG is the Q waves will be absent in V5, V6, but you will find a prominent Q in V1 and V2. Sometimes we may not find the Q in V1, V2, so you may get a right-sided lead. Like somebody was telling you should take a right-sided lead in the inferior MI. So similar to that, in almost all pediatric ECGs, better to take V3R or V4R, because sometimes Q wave may not be present in V1 because of lead placement. So if you get a V3R, if you document a Q wave and absent Q wave in V5, V6, then we may be dealing with the CCTJ, and you may refer the child for echo because of that. So you would have identified it earlier than the echocardiogram. So then after doing that, you come to the QRS duration. So Ashwin, if you are going late, then please. So QRS duration or the QRS complexes within the specified duration, like 120 milliseconds, and QRS amplitude. So QRS amplitude is the R wave smaller than the S wave in V1. So the R wave smaller than the S wave in V1. Okay, so if the answer is yes, then it is normal, right? So if it is abnormal, then there is reverse progression. And is there absence of overlap of R wave in V6 and S wave in V5? This means that the R wave in V6 is so tall that it overlaps with the S wave in V5. That means we might be dealing with the left ventricular hypertrophy. So is it present like that? And then you calculate the QT interval. So QT interval, you use the Bassett's formula. There are many controversies. They say Bassett's formula is not good, but it is very handy. It is easy to apply. So you still algorithms recommend Bassett's formula. So you use the Bassett's formula, calculate the corrected QT interval. Why you should calculate the QT interval? So the answer is given here. If the QTC is more, we may be dealing with the long QT syndrome. So it may be a predisposing thing for sudden cardiac death. So although it is rare, it is always better. So somebody gives you a pediatric ECG, always document what is the QT and what is the corrected QT. The corrected QT is going more than what it is for the expected gender and the age. Then you it may be a long QT syndrome, so you may need to treat the same. And then go to the T wave. The T wave is positive in V5 and V6. So if it is inverted, then what are the things that we are dealing with? And ST segment, whether there is any elevation or depression which is present in any one of the leads, and if it is there, then what are we dealing with? So like this, you start from P wave and go till the ST segment and see everything in the pediatric ECG, because all this may be a particular diagnosis and we may be dealing with something abnormal. So if any of the above answers are no, or there are clinical concerns, then you ask for a second opinion. So what are the red flag signs? So if somebody is telling about the history of syncope in a child, especially when the child exerts or goes for swimming, that may be a classical history of a long QT syndrome. So you guys would have read in pathology, right? Of the molecular features of long QT syndrome. So and whenever there is a family history of sudden cardiac death or arrhythmias or ICD implantation or a pacemaker implantation in a child, then it may be a red flag sign. And whenever there is a history of chest pain, but many children will be complaining of chest pain, you evaluate the ECG will be normal and the echo will be normal, then you reassure the child. But whenever there is right ventricular hypertrophy or left ventricular hypertrophy or SVT changes which are present in the ECG, then we may be dealing with something abnormal. And whenever there is low QRS voltage, we will see in the subsequent slides some examples. And whenever there is PR segment depression, we may be dealing with something ominous like pericarditis or myocarditis. So this is just the normal values for corrected QT in boys and girls. It is different for the two genders. And what are the normal values for the various ages is given here. So anything more than this, we should suspect long QT. So we'll go one by one. We'll go to the rate. So you know how to calculate the rate. So we have discussed it in the morning rate. Yes, like 300 by R roughly. There are many other methods to calculate the rate, but roughly we'll stick on to one method. So calculate the ventricular rate and the atrial rate separately, and then see if heart block is there. If these two are different, then we may be dealing with heart block. So the heart rate for the various ages have been given by two important studies. The most important study that everybody quotes in pediatric cardiology is the one by Davidson et al., which was published way back in 1979. They say because of the changes in technology and by using digital ECG, some of the values given in Davidson et al. Are not appropriate at present. So the other study which has been quoted very frequently is the second study, which was published in 2001. So you can use one of that. You have to get the normal values. Some of the snapshots from those articles I will be showing in the slide. But both these are open access and you can download this and just have as a reference when you are interpreting. So normal values for various ages. The first value is for boys and the second value is for girls in all the rows. So first gives the heart rate in beats per minute. So you see that the normal heart rate for newborns is somewhere around 160, 150, which is very, very abnormal for an adult. And 1 to 3 months, what is the heart rate? So first is boys, second is girls. Similarly, P-wave axis, what is the P-wave duration, what is the PR interval, what is the QRS axis. So you find that the newborns have a normal QRS axis somewhere around 110 degrees. Gradually it comes to the artery rates. And then the QRS duration and the corrected QT, what is the normal values for boys and girls is given here. So this is for 5 to 8 years till adolescence, the normal values of the second reference. So then going to the rhythm. So can one of you help me interpret this one? This was one of our patients. So what is the P-wave rate? We can focus only on lead 2. So whenever somebody asks you to interpret rate and rhythm, you see the lead 2. So lead 2, what do we see? More number of P-waves are there than QRS. And there is no relation between P and QRS. Like P is going on independently. Like there is a P here, then there is a P on T, then there is a P coming here, then there is a P here. So there is no relation between P and QRS. So when the P-wave rate is different and QRS rate is different, and PP interval appears to be normally preserved, QRS also appears to be, RR interval appears to be normally preserved. But there is no relation between P and QRS. So what are we dealing with here? Complete outlook. So complete outlook, we thought like is a feature of sclerodermatous heart block and only elderly people will be having complete outlook, right? So but pediatrics also can have complete outlook. So this is a 6-year-old child who was asymptomatic, doing well. She was just brought to the emergency department or somewhere. Like the doctors happened to see her and the ECG was taken and the ECG is showing this. So here again, can you interpret lead to the same diagnosis? Okay, so complete outlook. So this is another strip which is showing that complete outlook. Like RR interval is fixed, PP interval is fixed, there are many P's. And there is no relation between P and QRS. So these are all examples of complete outlook. So what are the conditions associated with congenital complete outlook? So many of you would be working as interns or final year degrees in newborn ICUs. Newborn ICUs, all the newborns will be connected to ECG. They will be sick for some other reason and you will be putting them on monitor. So child will be otherwise okay, but you find the heart rate to be around 50-60. This will be normal for an adult, but you find the heart rate to be very less. So in that case, what do you think? So immediately get a ECG. If you find complete outlook, probably you are dealing with congenital complete outlook. So what are the various conditions that can cause congenital complete outlook? So most important reason is autoimmune. Like mother may be a SLE mother or a Johan's mother, and there may be presence of anti-Ro or anti-La antibodies, and that might have been possibly transmitted to the child, and that might have caused complete heart block in the child. But the good news is complete heart block occurs only in 2% of fetuses, even when the metabolic serology is positive. So if you screen and you find that this is present, even then not all the babies will be affected. But if you find that one baby has been affected, the subsequent pregnancy, there is a high risk, almost 1/5 of chance of getting a complete heart block in the next baby. So this is the autoimmune cause. Apart from that, are there any structural reasons for complete heart block in children? So the common conditions are the ones which we discussed already, like Q86 absent and present in Q1 diagnosis CCTGA. So CCTGA, there is an annual chance of 2% chance to get complete heart block. So if a baby has been diagnosed to have CCTGA in utero, now many babies get echoed and antedatally. So if it has been identified to have CCTGA, our job is to keep doing ECGs every year. So because you know that there is a 2% chance of getting CSP, so always repeat ECG whenever you get in contact with the child and see if CSP is already occurred. So if it is there, then double-ended left ventricle is another condition where the features are almost like CCTGA, and because the anatomy is like that, you have a high chance of CSP happening. What is left ventricle isomerism? So other name is heterotaxy syndromes. So what is heterotaxy? So simply we can remember as same-sidedness. Like now we have different sidedness, right? Like our right side of the body has different organs and left side of the body has different organs. But if it is same-sided, like both are having features on the left side. So that is heterotaxy. So if you have left-handed isomerism, you will have left atrium on both sides. So you don't have a right atrium. So you will not have a SA node at all. So the generating node is absent, so you will be having a complete heart block. So these are the conditions which frequently have a complete heart block, and if it is identified, then treatment may involve implantation of a permanent pacemaker. But usually, if you find congenital complete heart block as a newborn, you don't implant pacemaker, but you wait. If the child is otherwise asymptomatic, as we saw in the case example, there is a 6-year-old child who has a complete heart block but is asymptomatic. So you can keep on following up till the heart rate falls to a critical level. There are some higher signs like your white QRS complex, if it is present, then it may be an indicator for placing a pacemaker, or if symptoms are there. So symptomatic CHP is an indication for placing a pacemaker. If the child has had one episode of syndrome or weakness, then that is an indication. But otherwise you keep following up the child. Primary reason being putting a pacemaker as difficult in a small baby. So it is done transvenously, right? You have to get the femoral venous access and then put in a lead, and then the pacemaker is placed here. So small baby might not have enough size for getting in a venous lead. So that is the reason we usually wait unless it is mandatory, like the child is symptomatic. If it is required, then surgically you can place the pacemaker in some other part of the body, like over the abdomen or somewhere, and then without the transvenous lead, it can be placed. So once the child is reaching a particular age, say 10 years or above, when you can put in the transvenous lead, you change it over to a transvenous pacemaker. So coming on to axis, the normal QRS axis, as we saw, varies with age. In adults, the normal axis is somewhere around minus 70 to plus 90 or plus 110 degrees, depending on the various references. And we see that right dominance is present in units normally with a mean QRS axis of around plus 75 degrees, the range being around plus 60 to plus 160 degrees. And in full term units, the range is plus 55 degrees to plus 200 degrees. By 1 month of life, the upper limit of normal increases to plus 160 degrees. And in a preterm newborn, it is different. So we can remember these normal values before we interpret. So anything which is going much more larger than this right axis deviation which is displayed may be abnormal. Otherwise, we may be dealing with a normal value in a U1. So, is there an axis for T wave and P wave also? So, the normal axis for P wave and T wave is from +0 to +100 degrees. So, within that it is normal. So, we will see why it is important. If the T wave axis is abnormal, that is T wave inversion has happened, then we may be dealing with either myocarditis or myocardial ischemia or ventricular hypertrophy. So, we will come to P wave. So, whenever we find large P waves, we saw like more than 3 millimeters can be, till 3 millimeters can be normal in humans and infants, but if it is more than that, we may be dealing with the right ventricular enlargement. And more than 2.5 millimeters, beyond 6 months of age, may be right ventricular enlargement. And the P wave duration is long. Long is not the same long as in adults, so it's only 80 milliseconds or 100 milliseconds depending on whether it's a newborn or a child. And P wave axis, we saw the normal P wave axis 0 to 90 degrees. Abnormal P wave axis means that the rhythm is originating somewhere away from the synovial node. So the synovial node is here, and then the crux is here. So from the synovial node, it travels towards the crux, the normal connection. So because it is traveling in a direction from right to left and from above to below, the P wave will be normal in, positive in the inferior leads. So 2, 3 AVF we will have to see, and AVR we will have to see. AVR is here, so because it is going away from AVR, AVR will have a negative P, normal. And P wave will be always positive in the inferior leads. So this is normal. So in case it is not arising from synovial node, say we saw the example of a left atrial isomerism. There is no synovial node. So instead of the synovial node, some other pacemaker will start doing the activity of the SA node. So usually it is somewhere in the right atrium. So it happens somewhere in the coronary sinus ostium, which is lower down in the right atrium. So if it happens like that, you see that the RA is here, and if the rhythm originates from somewhere here instead of here, it goes upwards. So your inferior leads will all have a negative P wave. And depending on the direction that it travels, the area of P wave may be positive or it may be negative also. So what are the examples? So whatever we discussed, keeping that in mind, can interpret this easily. So the inferior leads, what are the P wave axis like? So we are seeing negative P in lead 2, lead 3 and in AVR, and we are finding a positive P in AVR. So what are the possibilities? So we know that we are dealing with a rhythm other than sinus rhythm. So what are the conditions that can cause this? So it can be a normal variant. If the heart rate and the PR interval are normal for age, then it may be a normal benign variant which can be just left like that and can be followed up later. It may be atrial tachycardia which is manifesting in this way. But if it is an atrial tachycardia, the heart rate has to be fast. So this particular child, most probably it is a normal variant. Other possibility is it may be a superior sinus stenosis ASD. So what are the types of ASD? Ostium secundum, ostium primum, then sinus stenosis and coronary sinus. Okay. So sinus stenosis ASD, what are the types? So it can be superior sinus stenosis or inferior sinus stenosis. So superior sinus stenosis is a defect which happens at the place where the SVC comes and joins the RA. So SVC is here, RA is here. At the SVC RA junction, if there is a defect, then that is superior sinus stenosis ASD. Where the IVC comes and joins the RA, if there is a defect, that is inferior sinus stenosis ASD. So the defect is at the area where the SA node is located, because SA node is also located in the SVC RA junction. Because it is in the location of the defect occupies the area of the SA node may be displaced somewhere. So the activity is being started by some other part of the RA other than the SA node. So commonly you will find pro-atrial rhythm in sinus venosus AIC, which may be the, you may pick up the diagnosis based on that. So if you find that, one thing, if the heart rate is very fast, you suspect a tachycardia. And then we'll see the subsequent slide how we will the tachycardia. Then you inform the electrophysiologist. This problem is there. But if you find that the heart rate and PR interval are normal, it can either be a normal variant or it can be sinus venosus AIC. So if it is sinus venosus AIC, then confirm it by either a CT or echo, and if it is there, then you ask for surgery. So this child, you find that there is a fast rate that is going on. So whenever you have arrhythmia, you give adenosine and then see. So if refer the child to the electrophysiologist so that the child can be evaluated and ablation can be done if it's required. Because if the tachycardia keeps going on, what are the problems that can happen? Tachycardia induced cardiomyopathy can happen. Yeah, heart rate which is going much more faster than a normal rate can cause the LV function to decline. So that is really risky. So at the earliest you have to refer the child to the electrophysiologist. So now we go to the PR interval. So short PR is less than 80 milliseconds. If it is associated with the delta wave, then probably we might be dealing with the pre-excitation. And a prolonged PR may be a manifestation of the posterior. So Q wave up to defined amplitude can be normal in pediatric ECGs. So this is from a reference article which gives the normal values of Q waves in the two references that we discussed based on the age. So for most ages we find that 3 millimeters is a cutoff. So if anything deeper than 3 millimeters might be a abnormal Q wave. So what is the condition where we can find Q waves in a pediatric ECG? So what are the conditions where coronary arteries are affected in pediatrics? So Kawasaki disease. So Kawasaki disease, there may be dilatation of the coronary arteries in the initial stages, and later it may become stenosis also. So whenever you have a child with Kawasaki disease, you keep following up the child by echocardiography or CT coronary angiogram to see the coronary sizes. Sometimes they may present with acute amyloiditis. What is anomalous origin of LCA from coronary artery? So left coronary artery, instead of originating from the left sinus of the aorta, originates from the pulmonary artery. So the pulmonary artery has very low pressures. Because the pulmonary artery has very low pressures, the left coronary artery will not have an anticlinal flow. Instead of that, the right coronary artery, which is normally arising from the aorta, will be giving collaterals and it will be getting fed in the reverse way. So at critical instances when the child is having a effort, at that time the child may have a MI. So frequent MIs. So what is the activity in the infant? Feeding is the activity. So whenever the child takes breastfeed from the mother, child will not be able to sustain the breastfeed because the child may be having pain. The child may not be able to express it. So the classical history is intermittent stopping of feeding and trying in between them. So when such a history is there, always try to take a ECG. If you are finding features of prominent Q waves like this, you are finding prominent Q waves in V4, V5, V6. We are finding a prominent Q wave in lead 1. So all these are classical features of AVL. So all these are classical features of Al-Kappa ECG. But unfortunately, the classical features are not present in every case. So then, how do we identify Al-Kappa? So these are the classical features which all should be present. Okay, so Q wave more than 3 millimeters deep should be present. Q wave duration should be more than 30 milliseconds. And QR pattern should be present at least in one of the leads, like one area. We saw that it was present in all the leads in the previous ECG. And there should not be any Q waves in any of the inferior leads, because that may be a feature of myocarditis. So, but these features are not present in every case. When we discuss about the R wave amplitude, we'll see how to diagnose alpha when classical features are not present. So QRS duration, so rapidly we go, whenever it is prolonged, like more than 120 milliseconds, is in adults, like more than 70 to 110 milliseconds based on the age, we may be dealing with conduction defects. So pre-excitation associated with the delta wave prolongs the initial part of the QRS. So you know that there is a slurring of the QRS in the initial part. If a LPBV is present, it prolongs the proximal QRS because the left bundle is involved. If RBV is present, it prolongs the terminal QRS because right bundle is delayed. If an intraventricular conduction defect is present, then the entire QRS is fine. So QRS amplitude, depending upon which leads are involved, it can indicate either LVH or RVH. So dominant R in V1 is a feature of newborn ECG, but gradually it should change over to adult pattern. So if in older children also it is present, then it indicates right ventricular hypertrophy. And a large R wave in V6 overlapping into V5 may indicate LVH. So what are the common causes of RVH and LVH in pediatrics? So what are the common causes of LVH in adults? So one of you can tell loudly here. So systemic hypertension. Then any LV outflow obstructions. So aortic stenosis, aortic hypertrophic obstructive cardiomyopathy. Any of this can be causing LV. So all these are also causes in pediatrics. So RVH, what are the causes? So pulmonary, many RVOD obstructions. So either pulmonary valve stenosis or infundibulous stenosis, double chamber right ventricle. So any of this can be obstruction to the right ventricular output tract, and that can cause the right ventricular hypertrophy. Tetralogy of valve also will have right ventricular hypertrophy. So you already know that RVH may be normally present in newborn. So in a newborn, if you want to identify RVH, what are the criteria? It is very difficult, right? RVH is already present. So there are certain features which can help us identify RVH in newborns. So if there is a QR in lead V1, it may be a feature of pressure overload and presence of upright T in V1, which is normal till 7 days of life, may be a feature of right ventricular hypertrophy, and increased R wave amplitude in V1 or increased S wave amplitude in V6 may be a feature, and RSR dash pattern may be a feature of polymotor. So LVH, what are the features? Any T wave abnormalities in V5, V6, increased R in V6 or increased S in V1. And the caveat to be remembered is in newborn, even if LVH is present, it may be obscured because of the RV prominence. And in a preterm less than 28 weeks, it may show LV predominance because RV predominance has not yet developed. And if the QRS amplitude is large, we are talking about LVH and RVH, but if the QRS amplitude is abnormally low, then you should consider myocarditis or cardiomyopathy. So, what is the definition of low voltage? Like total amplitude of R plus S in each lead is less than 0.5 millivolts, that is 5 millimeters in the LVH. And how should the normal R wave progression be? So, the R wave amplitude of right-sided leads decreases with age, and it increases with age in left-sided leads. And inverse changes are present in the S wave amplitude. So R by S ratio, if V1 remains more than 1 till 3 years of age, but it can remain more than 1 rarely up to 8 to 12 years also. So what is the clinical impression of R wave progression? So in this ECG, you see that S wave is very prominent in V1, then a little bit of R wave comes, then a little bit of R wave increase. But instead of going in the same pattern, suddenly you find that this particular area there is no R wave. And again R wave comes back in V5. So this may be a feature of alpha ECG. So you may not have Q waves, but if there is an abnormal R wave progression, then it may be a feature of alpha. Because this particular, the myocardium overlaying this particular part has undergone an insult, so the R wave amplitude has dropped. So any abnormal R wave progression may be a feature of alpha, because the classical features which we discussed in the previous slide of alpha will not be present in majority of the patients with alpha. So if you find something like this, then you ask for an echo to identify this one. So we'll go to QTC, like how to get the corrected QT. You measure the QT. At the place where the T wave ends, don't put a vertical line, but put a tangential line where the T ends, so that they say is much more appropriate. And then you use the passage formula to correct for heart rate. And prolonged or shortened QTC may predispose to arrhythmias. So we saw in the previous slides what are the age appropriate QTCs. Anything longer than that can be a long QT. So we'll go rapidly. Schwartz has given a score for long QT syndromes. So based on the QRS duration and whether the presence of cross-edge is there, T wave abundance is there, and whether the notch T wave is there, history of syncope and congenital deafness, and family members with definite LQTS or unexplained sudden cardiac death. So you give points to various features. Anything more than 3.5, there is a high risk of sudden cardiac death in a long QT syndrome. So what are the various types of long QTs? I think you guys will be knowing much more than us because you read in depth into pathology. So you identify which type of LQTs you are dealing with because the figures are different and the treatment also is different. So, but common line is beta blockers and recommendation of ICT for the child. So T wave, the T wave should be upright in lead T1 and T2. It is normal for the first 2-3 days of life, and after that it should become inverted in leads T1 to T3. Again, it becomes upright during adolescence. So pathological T wave and SVT changes may suggest pericarditis or myocarditis. Myocarditis occasionally may present with PR depression also. Or it may be a sign of ventricular strain or it may be a sign of ischemia. So normal variants of J-point depression may be early depolarization. A J-point elevation in adolescent boys may be normal ERP. So U waves, I think you will have discussed about U waves. They are small positive reflections after the T wave, and they are best seen in leads P2 or P3. And inverted or especially large U waves should get a second opinion. ST segment, you discussed in depth on ST segment in the ACS session. And even children, there should not be more than 2 mm ST elevation or depression in precordial leads and no more than 1 mm elevation in the lymph leads. So this is an example of early depolarization. You are finding that the J point is elevated in lead P2 and P3, but it may be a benign variant as in this child. But it can be abnormal as in alcohol. So alcohol can present with poor RWave progression, alcohol can present with Q waves in V5, V6, 1ABL as in this example, and also can present with ST elevation as in a common MA. So any of this, if it is present in a child, always think alcohol and try to get an echo and try to identify where the coronary artery is coming from, whether from the aorta or from the coronary artery. So this can be an example of myocarditis. We saw that what was the definition of low voltage complexes. So here you are hardly able to find any QRS complexes, and there is ST depression in lead V1. Also in leads P2 and P3. So we may be dealing with myocarditis. Also, a tachycardia inappropriate for the age. So normal heart rate itself may be higher in children, but it may be higher than the appropriate age limit for the child. And pericarditis can present with characteristic saddle-shaped segments. So you find a saddle-shaped ST elevation with a depression in between, that may be pericarditis. So summarizing, always ask for the child's age prior to interpreting the ECG, and use the checklist so that you go stepwise and don't miss out on any component, and do not miss the red flag sign so that you do not miss the diagnosis. Thank you.
Request all the expert faculty members to kindly come onto the dais for a photograph.
லைட்டை போட்டுக்கலாமா சார்? நல்லா
Request the organizing committee members to kindly come forward.
எடுத்துக்கலாமா? வரணுமா? இந்த சைடு கொஞ்சம் பேர் வாங்க சார். பேக்கில் கொஞ்சம் க்ளோஸாக நில்லுங்க சார். கொஞ்சம் ஃப்ரண்ட்டில் அப்படியே ஓவலாக கொஞ்சம் ஃப்ரண்ட்டில் வாங்க, ஃப்ரண்ட்டில் ஓவலாக வாங்க. கேட்ட போடுங்க. Sir, ready sir? Smile, smile. Smile sir. Sir, wait பண்ணுங்க sir. Video run ஆகுது sir. Wait பண்ணுங்க. ஃபர்ஸ்ட் ஆரம்பிக்கிறாங்க. தேங்க்ஸ் சார். தேங்க்ஸ்.
Our next speaker is Dr. Gunaseenan R, Assistant Professor in Emergency Medicine at Aimhtyhrra.
Okay, so it's been a long day. I'll cut short some of my presentations and stick to the main things. And before going to the presentation, one good news for those who follow cricket and IPL. CSK have won and they have qualified for the thing. And the other thing is, before going to any ECG, I'll ask one question. Can somebody answer this question? It's a basic question, right? So, how many alphabets are there? How many alphabets are there? 26? How many alphabets are there? Ramesh, how many alphabets are there? 26? Anusha, how many alphabets are there? Huh? Which language? Anusha has asked the right question, right? Which language? The question is not complete. How many alphabets are there in English? In Tamil it is 247. So similarly, any ECG if you are trying to interpret, you need to have a context. Okay, there is a question that should be asked. The question is, what is the patient's clinical history and examination? What are we dealing with? Just blindly reading an ECG is not okay. Okay, you always need to interpret an ECG along with the clinical context. Like Sarah was telling, you need to, in pediatric ECG, you need to know the age. Then only you can interpret it. Otherwise, you will not be able to interpret it. Okay. The other thing is, so my presentations are available. If you want, you can take a scan of this and you can access my presentation. And the learning objective for this discussion was, I put 4 actually, but we will stick on to only 1. Okay. So whatever we have been discussing so far is not going to be useful if the ECG is not taken properly. Okay. If the ECG is taken properly, then only you can interpret it. If the ECG is not taken properly, suppose there is the technician now placed the ECG wrongly. Okay. or there is a connection, wrong connection in the ECG machine, what will happen? It will give so many abnormal findings even though the patient is completely normal. Okay. So we go with the case-based discussion. So this is a 55-year-old male. He was hypertensive and he presented to our emergency department with breathlessness. And this is the ECG of the patient. Can anyone say what is the glaring abnormality that is present in the ECG? Yes? Low voltage complexes, right? Can you appreciate, everyone appreciate this? The QRSs are very low in amplitude. But if you see the diagnosis that is given by the ECG, what does it say? On top? What does it say? On top? Left ventricular hypertrophy. So in left ventricular hypertrophy, what should the QRS be? How should the QRS be? It should be very big, right? Because there is more muscle mass, so more amplitude should be there. Morning, Rajesh had an extensive discussion, right? So why is this disparity? The ECG machine is calling it left ventricular hypertrophy, but the QRS complexes are very low here. Yes. Okay. So what is happening here? The standardization is not proper. Okay. So before interpreting any ECG, we need to look at the standardization. Okay. So there are two areas where you need to look at the standardization. One is this box on the side. Okay. And the other is on the bottom of the ECG paper. There will be many numbers. Okay. 2.5 millimeter per millivolt, 25 mm per second, AC 50 Hz, 0.5 to 35 Hz. So many numbers are there. Among these, the numbers we are interested in are the millimeter per millivolt and millimeter per second. So what should be the normal millimeter per millivolt? 10. Normal standardization is 10. But here what has happened? They have reduced the standardization to 1/4, 2.5 millimeters only. Okay. So that is why the ECG waves look very small. But in fact, the ECG waves are actually LVH. This ECG belongs to LVH. So standard calibration in ECG is, if the ECG is taken at 10 mm per millivolt and 25 mm per second, it is standard calibration. Without this, there are many things which we cannot apply. For example, the rate formulas. Whatever formulas for the rate should be applied only when the speed of the paper is 25 mm per second. Okay, morning Anusha discussed, right? And whatever formulas for LVH that we have discussed should be applied only when the standardization amplitude is 10 mm per millivolt. Okay. Then why we are altering these calibrations? Because there are some use for this. Okay, so we can detect some low voltage amplitude. If the amplitude is really low, you can increase the standardization to make the QRS look bigger. Okay, and if the QRS is very large and the waves are overlapping, you can reduce the standardization like this in this example. Okay. The fallacies are that the waves may look abnormal. Okay, it can be very tall, mimicking hyperacute T waves, hyperkalemia or LVH. If the speed is slow, it can be wide, okay, mimicking wide complex tachycardia or bundle branch block. And if the amplitude is small, it can mimic low voltage. Okay. Yeah, so this is the previous ECG with the standard normal calibration. Okay. So here, if you can see, LVH is present. The waves are overlapping. And in this ECG, you see, it is, what is the standardization? It is double standard, right? The tower, ideally the tower should be 2 large box. Okay. Here it is 4 large box. So it is double standard. Okay. Because they wanted to look at the P waves. The P waves were very small here. So we wanted to look at the P waves. So we increased the standardization. Okay. So the second patient, a 30-year-old male, presented to me with complaints of atypical chest pain. And this is the ECG. What is happening here? What is the rhythm? To simplify, we'll say what is the rhythm? What is the rhythm? Regular. What about the P waves in 1 and area? The P P wave in one is negative and the P wave in AVR is positive. So what is this? It is an abnormal result, right? But no. Okay, here what has happened is there is a limb displacement. Okay, somebody has changed the right arm and left arm lead. So how can we diagnose this? Is by looking at the AVR. Okay. So you see lead 1, there is a negative P wave, negative QRS and negative T. And in lead AVR, there is a positive P, positive QRS and positive T. Okay. In AVR, ideally it should be like that. So AVR lead is here. It is looking at the heart from this area. So whatever waves that are recorded by AVR will be negative. So it is called as universal negativity of AVR. All the waves P, QRS and T should be negative in AVR. Then only the ECG is taken properly. If the lead AVR is showing positive P, positive Q and positive T, then the leads are reversed. Only AVR can be positive in some conditions like DCA positive, but P and T also are positive in AVR. That means it is wrongly placed. So it is a universal lead AVR has been changed from universal negativity to universal positivity. That means right arm and left arm displacement. Okay. So again, so universal negativity in lead 1 and positive P wave in lead AVR indicates right arm, left arm lead reversal. And what is the close mimic of lead reversal is dextrocardia. Okay, the heart itself is rotated. Instead of rotating the leads, the heart itself is rotated. But how can we differentiate dextrocardia and limb lead reversal? Is here the R wave progression will be normal. The R wave progression will be normal. What is R wave progression is the R waves will gradually become tall from V1 to V6. Whereas in dextrocardia it will be a reverse R wave progression. Okay, so the R wave is tall in V1 and there is no R wave in V6. That happens in dextrocardia. It is like taking a right-sided lead for a patient. Okay, the heart is this side and you are putting the leads on this side. Okay, so this is a patient. It was a very interesting case. He was referred to us as a case of lateral wall MI. Okay, this was the ECG that was taken in the outside hospital, and when we took an ECG, this was the ECG. Okay, so in the outside hospital ECG, where in which leads ST elevations are there? Yes, 1 and AVL, right? And there is ST depression in lead 3. Okay, whereas in our ECG, the ECG that we have taken in our hospital, where is the ST elevation? Yes, 2, 3 and AVF. Okay, so previously it was lateral wall MI and now it is inferior wall MI. How can this happen? Within 30 minutes or so, the MI has changed from lateral wall to inferior wall. Can it happen? No. Okay, then what is the possible explanation behind this? Again, there is some sort of lead misplacement. Okay, so here what has happened is the left arm and left foot leads are misplaced. Okay, this clip that we place here and the clip that we place here are misplaced. Okay, how can we identify this? So here we have to look at the P wave. Okay, the P wave, P wave. Normally the P wave should be bigger in lead 2. Lead 1 the P wave will be smaller, lead 2 the P wave will be bigger. But here the P wave is taller in lead 1 and smaller in lead 2. Okay, so here right arm and so how can we identify this? In lead 3 the P wave will be completely inverted and in lead 1 the P wave will be larger than lead 2. Okay, normally lead 2 should have a taller P wave. This is another case which was referred to us. Having a metatarsal fracture, they took an ECG for anesthetic purposes. I don't know why for a metatarsal fracture they have taken an ECG. And they found out that there are some ECG changes, so they have referred to us. Okay, so this is the ECG in the outside hospital. What is it showing? T wave inversions in 2,3 AVF and what else is there? What about AVR? Okay, so some of, like, do you think they are T waves? How should a T wave be? Should be a smooth, round, like camel hump-like appearance, right? But is it that the whatever waves you are seeing, does it look like that? No. Okay. So what is this? Basically, this is an artifact. Okay, and this artifact is very classical because it arises from the pulses. Where if you place a lead clip here, prominent radial artery pulsations can produce artifacts. Okay, which will synchronize in the QRS complex. Okay, so this artifact is called as an electromechanical association artifact. It is very difficult to differentiate and it can mimic an MI. Many of the times people will diagnose this as MI and they may start treatment also, which may be harmful. Okay. And the last ECG I wanted to show was this. Then what is very prominent here? What is the rate? Some people say flutter. What are the diagnosis? If you see the lead AVL or lead 1, how does it look like? It looks like a white QRS complex tachycardia, right? But these are not white QRS complex tachycardia. If you see lead 2, they are completely normal. These are all tremor artifacts. For a patient with Parkinson or alcoholic patients who have tremors, their hands keep on moving and that will produce these artifacts. So whenever you see tachycardia or white QRS complex tachycardia, you need to scrutinize all the ECG leads. Okay, if in at least one lead you see normal waves, then you should think that these are artifacts, because if you diagnose this as VT and start treatment by giving it either amiodarone or shock, it may cause harm to the patient. Okay, clear? Any doubts? So with this, I'll stop this discussion. I have some more, but I'll stop the discussion for the quarter time. So the major learning points are interpret an ECG in the context. The other thing is look for whether the ECG is taken properly or not by looking at the standardization and lead AVR for universal negativity. And third thing is carefully scrutinize the ECG for artifacts before jumping into a conclusion and starting treatment. Okay, clear?
Thank you, sir. Our next set of sessions are on toxicology, and I would like to welcome Dr. Sasi Kumar, Assistant Professor of Emergency Medicine, Aimhtyhrra.
Good afternoon, everyone. So my topic of discussion is regarding toxicology and ECG. Okay, this basically I will discuss regarding different poisoning and what are the different ECG changes which can be there. Okay. So before proceeding to the topic per se, like how many of parametrics here? Okay. How many are interns? How many are PGs? Okay. That's the final case scenarios will be there. I'll be dividing you into different groups. I'll be like a quiz will go. Okay. So before going on the topic per se, these are different mechanisms by which the poison acts on causes cardiotoxicity. Okay. One is ion channel blockade. Okay. Another one is pump blockade. This is sodium potassium pump blockade. Another one is beta receptor blockade. Some toxins can cause direct myocarditis, toxic myocarditis. Okay. There are different ion channel blockade can happen because of poisoning. That is what sodium influx channel blockade. Another one is potassium efflux channel blockade can be there. Beta receptor blockade can be there. Calcium channel blockade can be there. Now, of course, sodium potassium is found. These are all the channels based on which your action potential, ventricular action potential, and SAO action potential is happening. Okay. So this you would have read, right, in physiology. Different phases are there. Phase 0, phase 1, phase 2 and phase 3. And phase 2 is based on calcium influence. And phase 0 is sodium. So whenever, suppose different drugs acts on, causes sodium channel blockade. Okay, so you should know which drugs are causing sodium channel blockade and which drugs are causing potassium channel blockade. So based on this, different morphological changes can be there in ECG. Okay, so one important thing is, at phase 0 level, the QRS duration depends on that. Okay, whenever a drug acts on sodium channel blockade, causes sodium channel blockade, this QRS duration will prolong. That's one important thing. Another one is phase 3. Whenever some drugs causes potassium channel blockade, it causes QT prolongation. Like this. Okay. Phase 0, that is sodium channel blockade toxicity, that causes QRS prolongation, whereas phase 3, that is potassium reflex blockade, causes QT prolongation. These two common important things you should remember. The same thing can happen with regard to SA node and AV node pacemaker potential. Okay. The same sodium channel blockade can cause decreased AV conduction and decreased SA node conduction also, which in turn causes bradycardia. Okay. So what is meant by TOX syndrome? What is TOX syndrome? Please, post-graduation, from this group. What is TOX syndrome? Cholinergic TOX syndrome, symptom-mimetic TOX syndrome, right? Okay, basically it's a constellation of symptoms and signs based on which you can find what probable poison patient will have taken. Okay, that is purely based on symptoms and signs. Like in OBC poisoning, what are the symptoms patient can come with? Lacrimation, doubles you would have read, right? Like that. Okay. So based on these symptoms, without knowing the history person, you can find probably the patient has taken OBC. Like that, something called as ECG TOX syndrome is there. Here again based on signs, symptoms along with ECG feature, we will find what toxin patient has taken. Okay. So basically they have divided the ECG TOX syndrome into 3 different categories. One is patient can have sinus rhythm. Okay. In that patient can present with long QTC and other things. Okay, we will discuss regarding this. So some patients can present with bradycardia. Okay, again we will discuss in case in this what are the different ECGs can present with bradycardia. Yeah, and so again some poisoning patients can present with tachycardia. Okay, this also will discuss based on case scenarios. Okay. Okay. So now we will divide you into 4 groups. Okay, this will be group 1, that will be group 2, that will be group 3, and this will be group 4. Okay. The first case scenario I will give. This is a 25-year-old male on antidepressants. Okay. Came to ER with an unconscious state, brought to ER in unconscious state, history of seizure was present. The ECG recorder is shown below. This is the ECG. Basically, a patient who was on depression on antidepressant drugs with history of seizure was brought to ER in unconscious state. This is the ECG. What all findings you can see? Anyone from this group? From this group. The tachycardia is there or bradycardia is there? Tachycardia. White complex and narrow complex? White complex. Any visible periods are there or not? Saturated periods are there, but you can take it as ventricular tachycardia also. Actually, this is a sinus tachycardia patient. Okay. So, anyone knows the diagnosis of this patient? TCA poisoning. Okay, I have given history as antidepressants. The most common antidepressants which is TCA, tricyclic antidepressants. Many more antidepressants are there. These antidepressants has a specific property of sodium channel blockade. What it does, sodium channel blockade causes QRS prolongation. Okay, so QRS prolongation, that is white complex tachycardia. One more very important finding is with regard to AVR. There will be positive R wave in AVR. That is very important finding. Okay. So, for paramedics, you can take this as a take-home point for this case. Any patient with poisoning, ECG is a must. It can give a clue for diagnosis. Okay. So, any sodium channel blocker poisoning will have white QRS. That's a take-home point. Okay. One more important thing: most of the commonly used drugs which we use, like phenytoin, lidocaine, carbamazepine, all class 1 antiarrhythmic agents have sodium channel blocker property. The patient is taking these drugs in excess can result in features similar to this ECG. White complex tachycardia can be there along with the dominant RV in AVR. Okay. So these are the ECG findings in sodium channel blocker toxicity. Okay. White complex letter will be there, and these two are the terminal RV more than 3 mm in AVR or RVS ratio more than 0.7 in AVR. This is a classical finding in sodium channel blocker toxicity. Okay. Now of course this sodium channel blocker can also causes ventricular tachycardia also. Okay. Understood? So these are common drugs: lignocaine, phenytoin, carbamazepine, antidepressants, all has sodium channel blocker toxicity. Okay. So this is a case 2 from someone from there. A 30-year-old male landed up in ER with knowledge history of herbicide poisoning. This is herbicide which has been taken. Okay. Patient had oral ulcers, breathlessness, AKA, and fulminant hepatitis. Okay, these are the findings, just X-ray findings of the patient. This is the oral tongue findings, and that's the compound taken. Obviously, what's the compound patient has taken? Paraquat. What's the most common ECG finding in paraquat poisoning? Summer? We do thyroxine supplements for these patients. Okay. So again, different herbicides are there. Okay. So one among the herbicide is paraquat. So whichever herbicide patient is taking, you have to confirm the compounds first. What type of compound it is. Pneumothorax also. Okay. And for PGs, toxin related T3 and T4 suppression can be there. High steroid, like one of the treatments for paraquat is high dose steroids, and cyclophosphamide as well can be given. Because of high steroid per se, T3 suppression can be there. So because of that, patient can develop hypothyroidism like features and bradycardia. Okay. So one more very important for PGs is oxygen should be avoided even though patient is having hypoxia. Unless it's required, oxygen should not be given for paraquat poisoning patients. Okay. The patient is having saturation of 92, 94 means it's fine. We may not give oxygen for those patients. Okay. Unless it's required, really required. So third case scenario from that group, a 65-year-old male, known case of resistant hypertension on multiple antihypertensive drugs, lands up in ER with bronchospasm, like some breathing issue is there, hypotension, bradycardia, and altered mental status. Okay. And his blood sugar is 40. ECG recorded is below. Patient basically is having hypoglycemia as the bradycardia, hypotension, and he is on some antihypertensive drugs. Okay, this is the ECG recorded. What features are there from that group? Sinus bradycardia only. Okay, so what poisoning you are suspecting in this patient? Beta blocker or calcium channel blocker? Beta blocker or calcium channel blocker? Poisoning. Why? Bronchospasm. One more important finding is hypoglycemia. So these two important things, that like beta blocker poisoning patient will have hypoglycemia. Those patients can also have bronchospasm and other features. Okay, that's a differentiating feature between CCP poisoning and beta blocker poisoning. Okay. So if any hypertensive patient with hypotension, these two are common cardinal symptoms. Okay, hypotension and bradycardia. You have to suspect antihypertensive tablet poisoning. Probably it can be CCP or beta blocker. Okay. So it can be either beta blocker or CCP poisoning. How to differentiate is based on blood sugar levels and bronchospasm features. Okay, that's very important. What's the antidote of choice for that patients? Most of the patients will present hypotension, right? So antidote of choice is high dose insulin therapy. That's called high dose insulin therapy. Let's say therapy. Insulin plus dextrose. Insulin at the dose of 1 units per kg will give. For DKA usually use 0.1 units per kg, whereas here you are supposed to use 1 units per kg. Okay, this is fourth case, this group. Okay, a young couple went on a honeymoon trip to China. Okay, to their bad luck, they developed fever, headache, and myalgia. Okay, due to local people's advice, they took some Chinese herbal medicine for their ailments. On the next day, both developed nausea, vomiting, hypotension, and tachycardia. Okay, this is the compound from which the Chinese herbal medicine is taken. So anyone can say the diagnosis? Aconite poisoning. Okay, this is an aconite tuber, that's an aconite flowers. Okay. So this is the ECG of the patient. What is the ECG? From this group? Tachycardia is there or not? Tachycardia is there. Arrow complex or white complex? White complex. So white complex tachycardia. But some glaring feature we are seeing here, right? Some QRS complexes are negative, some the next QRS complex is positive. Within the same lead, one is negative, one is positive, one is negative, one is positive. This axis changing QRS complex will happen in bidirectional VT. Okay, this is ventricular tachycardia only, but it's called bidirectional VT because the QRS axis is changing. Within the single lead itself, one is negative, one is positive, one is negative, one is positive. Okay, this is very classical finding of digoxin toxicity. On top of that, aconite poisoning can also have this. Okay. So this is an aconite tuber. This is commonly used in Chinese herbal medicines. Okay. So alternating QRS axis within the single lead, it causes bidirectional VT. Okay. And one more important thing is digoxin can cause this bidirectional VT. Aconite poisoning can cause bidirectional VT. Something called CPVT is there. Catecholaminergic polymorphic VT. CPVT we call it. Some caffeine poisoning can also cause this. And of course, some hypokalemia patients also can cause bidirectional VT. Okay, these are other causes of bidirectional VT. Okay. Fifth case. This group. Okay. A 40-year-old male, a glass designer by operation, presented to ER with skin blisters, dyspnea and seizure. Okay, ECG was taken, but meanwhile patient went into cardiac arrest. And this is the ECG. What findings are there? T-wave. ECG toxicity I told now. Brady or tachy, most of the patients. Decide Brady or tachy? Brady. Okay, what are the finding glaring features are there? So sinus Brady or something else? Or AV block or SA block? This is simple sinus Brady. What other features are there apart from that? Inverted T-wave. Okay. Anything else? The lead to the thing. What's the QT interval in this patient? This is it. QT interval is prolonged. To suggest what? Potassium? Okay. That suggests hypocalcemia. So one important thing is hydrofluoric acid poisoning causes hypocalcemia. Because of that, patient can go for cardiac arrest. Okay. So these are different occupations. Those patients like different occupations where they use hydrofluoric acid as a compound for working. Okay. Hydrofluoric acid poisoning causes hypocalcemia classically. And along because of hypocalcemia, ECG can show QT prolongation. What are different types of QT prolongation you know? This is QT segment, right? This QT prolongation can happen if there is a QRS widening. If this is ST segment, right? So ST prolongs also, QT prolongation can be there. If T wave is becoming wider also, QT prolongation can. These are different possibilities. QT prolongation can happen. In hypocalcemia, how it happens? What's the pattern of QT prolongation in hypocalcemia? It's classically the ST segment will widen. Will be there. Okay. So QRS widening also causes QT prolongation. ST segment prolongation. Okay, this segment also causes QT prolongation. That's classically happens in hypocalcemia. Okay. Another one is because of T wave abnormalities also QT prolongation can happen. That is in hypokalemia. Okay, you will see a T wave, inverted T wave followed by positive U wave. Okay. Again we take it as T wave, QT prolongation will be there in hypokalemia also. Okay. So these are different features of hydrofluoric acid poisoning, and ideally these patients should be treated with calcium gluconate or calcium chloride if it's available intraarterial for this thing. So one more thing is for the blisters caused by hydrofluoric acid poisoning, we generally use calcium gluconate gel. Okay, for as a treatment. Case 6, that group, okay. A 10-year-old female is brought to ER with complaints of abdominal pain. Okay, a child with abdominal pain. Vitals are pulse rate is 40, BP is 60-40, SpO2 is 98% room air, respiratory rate is 20, AFFI, and GC is 15/15, and RBS is 240. Okay, occult shock worked up for everything. Cause could not be found. And this is the ECG. Okay, this is the same case now. This is the ECG. What are the ECG findings? Tachycardia, sinus or something else, or AV blocks, SH block, sinus brady. So patients are in sinus brady. On top of that, patients are in hypotension, bradycardia, sugars are high. What's the diagnosis? I told that any patient with positive history with bradycardia and hypotension, you have to suspect two important diagnoses. One is CCB, one is beta blocker. So this would be what? This is CCB. CCB classically causes hyperglycemia. In contrast to beta blocker positive, this causes hyperglycemia. That's the given history of RBC of RBS of 240 mg per deciliter. Okay, this is a case of CCB poisoning. Okay. Based on sugar levels and bronchospasm history, bronchospasm features, you can differentiate CCB and beta blockers. And of course, isotope of choice for such patients are high dose insulin therapy. Okay. So case 7, a 50-year-old male, farmer by occupation, came to ER with history of unknown weight. Okay, there is a severe pain at the injured site. Chest pain is there, palpitation, excessive sweating is there. Vitals, BP is 200/100. Pulse rate is 140. SpO2 is 87% at room air. Respiratory rate is 27, and ECG is shown below. What are the findings in ECG? Tachycardia, tachy. Sinus or some other, or PSVT or something else. What is that? Sinus? Sinus tachycardia. What are the features? It is so glaring there. Tall T waves, sir. So, what's the diagnosis? Scorpion. Okay, these T waves are classically called as Ashoka tree appearance of T waves. Okay, this almost look like an hyperkalemic T waves, but in scorpion tree these features will be there. Okay, sinus tachycardia with these type of T waves. Okay, now of course treatment is what? Supportive care, prazosin. Since patients are hypertension, is supposed to give prazosin and some supportive care should be there. And these are the features of toxic myocarditis. Scorpion tree induced myocarditis. Okay. So case 8. Stimulation is there. Okay. Troponin is not elevated. It's because of coronary spasm. That's called what? There are different types of STEMI is there. And different types of STEMI mimics, the different causes of STEMI mimics are there. And one of the causes, Cone syndrome. Okay, this one. Firstly, because of allergy, it can cause coronary vasospasm. That can mimic like a STEMI. You should not treat such patients with thrombolytics. You are supposed to give management as you are managing any anaphylaxis. Along with the ASV is different. Even ASV can cause such features. Okay, that's why you have to differentiate these STEMI with STEMI mimics. These are different causes of STEMI mimics. Okay, Brugada syndrome can also mimic like STEMI. Hyperkalemia can mimic like STEMI. LVB can mimic like STEMI. Okay, benign early reposition can mimic like STEMI. There are different STEMI mimics are there. You can mimic like a STEMI. So you have to differentiate these with others so that you can treat appropriately. Okay. So this condition is called as Cone syndrome. Different drugs due to anaphylaxis can cause such pattern. Insect bites can cause such pattern. Scorpion sting can cause such pattern. Snake bite also rarely can cause such pattern. Okay. So this is another case scenario. I think it's the last. Young boy with ADHD gets the fruit and leaves which is grown by the roadside in the village. Following that, patient developed chest pain and lands up in ER. Hypotension, hypoxia is present, and ECG is shown below. So this group, what is that ECG? He has tasted this fruit along with leaves. Okay, normal heart rate, sinus rhythm. Okay. What? Why hypokalemia?
Inverted T waves followed by
Okay, you can see these are the inverted T waves here. Okay. This is inverted TVA and this is an UL. Okay, and that's QT prolongation. So I told hypokalemia also causes QT prolongation, but it's due to inverted T wave and E wave formation. Okay, so this is classically hypokalemic ECG. And what is the poison? What is this? So morning you will discuss, right, how to differentiate hypo and hyperkalemia. Same thing. Odonthalic causing classically causes hypokalemia. And other features of hypokalemia, there can be diffuse gastric depression, TV emission can be there. It's not actually QT prolongation, it is pseudo QT prolongation. And URS can be there. Okay. Treatment is based on potassium infusion. A known heart disease patient with multiple drugs was brought to ER in hypotensive state. Patient avoids cardiac surgery for the past 2 years. Okay. Brought to the complaints of abdominal pain, vomiting and palpitation. ECG shows this one. What is this? Already we have discussed, right? It is bidirectional VT. You have taken ECG after some time, it shows this one. This is non-sustained VT. Okay, these are multiple PVCs. Okay, more than three multiple PVCs is called as non-sustained VT. So basically, what's the poison? Digoxin toxicity. Okay. So digoxin toxicity. Okay. Of course, the treatment is you have to stop the offending drugs and request congestive cardiac monitoring. So digoxin toxicity can cause almost any type of arrhythmia, except atrial flutter and atrial fibrillation and type 2 morbid. How does digoxin act? Sodium potassium ATPase blocker. Okay, that one. And treatment is what? Digipine or Digifab, but it's not available in India. So you have to treat symptomatically. And what is this? So what does it mean? This also got a reverse tick sign. So what does it mean? Anyone? Any patient who is on digoxin will have this sign. It doesn't mean patient is on toxicity. Okay, it means patient is having digoxin effect is there. So based on this, you should not say patient is having digoxin toxicity. Just an effect. Whenever the patient is taking digoxin, all the patients will have such sign. This is inverse tick sign. Okay. So basically, you should not consider this as a toxicity. Okay, that's it. So last case, a female due to marital conflicts conceived decoction of the seed shown here. She was brought to ER. Vitals 90-60, pulse rate is 30, respiratory rate is 28, and saturation is 98% in room here. And this is the ECG. Already they have discussed this ECG. What is the finding? Tachycardia. Narrow complex or white complex? Narrow. White complex. What are the findings? Are there? Sinus bladder or something else? AV block. What is AV block? What more? Complete heart block. So PP interval is different and RI interval is different. Okay, and that's a complete dissociation of atrium and ventricle. This is complete heart block. So diagnosis is what? Yellow letter poisoning. Okay, so yellow letter poisoning can cause any types of bradycardia. Okay, it can cause AV blocks, it can cause SA blocks, depending on the situation. And how will you treat such patients? So yellow letter poisoning is approach for bradycardia and RS. Continuous ECG monitoring is required for such patients. Okay, that's one thing. Approach for all types of bradycardia. And action is based on, again it's a cardiac glycocyte, acts by sodium potassium ATPase blocking action will be there. So if the poisoning causes perfusion affecting bradycardia, basically because of severe bradycardia, perfusion is affected. That's one common indication. One more indication, severe types of bradycardia. The heart rate is going very low. You're supposed to do transvenous spacing for such patients. And this is the treatment. Of course, you can do supporting care also. Okay. These are other cardiac glycocytes. Action is by this. And one very important thing is digoxin can cause both tachycardia and bradycardia. It causes tachycardia because of increased automaticity and causes bradycardia because of vagomimetic effect. And for great toxicity, it has sympathomimetic activity also, and also it has sodium channel blocking activity. This is a summary of whatever we have discussed. Okay, beta block poisoning, calcium block poisoning, cardiac glycocytes. Thank you.
Thank you, sir. I now request Medicine Jipar to kindly come onto the dais.
So this is the last session. So maximum 10 to 15 minutes we will take. So observe this common electrolytes responsible for cardiac function. So whenever you see any cardiac openings from cardiac and delivery, every time they will collect electrolytes, magnesium, phosphate, calcium, potassium, they will ask to collect. But the action potential depends on electrolytes. So this is the normal action potential of cardiac myocyte. This phase 0 and phase 1 is total QRS complex. This phase 2, the platinum phase represents ST segment and the repolarization represents T wave. Okay. So if any, so platinum phase is mainly represented calcium. So any electrolyte system hypercalcium will affect mainly on that ST segment. So hyperkalemia will affect mainly repolarization. So T waves it will affect mainly and ST segment. So normal T wave is like smooth and somewhat asymmetric. It should be like smooth and small only. Around 2-3 mm will be there. So what are these are the electrolyte disturbances that cause significant ECG changes. Only hypocalcemia, hypercalcemia will produce significant ECG changes. As phosphate, magnesium and all. Magnesium also will, hypomagnesium also will produce short QT in phenomenon. Other ECG changes and the electrolyte disturbance will not cause significant ECG changes. So, 60-year-old female brought to ED complaints of generalized weakness and multiple episodes of vomiting. She is on medication for DM and hypertension for the last 15 years. She was operated for diabetic foot for 2 weeks before. So, anyone tell what's the ECG finding this patient? Can anyone tell it's visible? Anyone tell what's the ECG finding this patient? Usually, T waves will be smooth and rounded. In this patient, other is rate rhythm, everything is okay only, except there is tall T waves in the mainly split precardial B12, B6 and some chest leads also, limb leads also showing tall T waves. So it suggests your hyperkalemia. This patient's potassium is 6. This is mild hyperkalemia showing tall T waves. Same. This patient is also showing tall T waves, mild hyperkalemia. So 60-year-old male presented with complaints of weakness. He had no chest pain and initial ECG. So can anyone tell what's their ECG? Available. What's their ECG? I'm not expecting. So just findings were there. Findings are there ECG.
Normal access.
Okay.
Irregular rhythm.
Okay. So in PV hyperkalemia is narrow base, pointed tip other that sharp, apex and symmetrical. In tall TV, in ACs like MI, it's bulky, wide at the base and localized to the anatomical area. But in hyperkalemia, we will find tall TVs mostly pericardial leads and limb leads also you can find, but will be more prominent in pericardial leads.
Sir, can you just go back to the previous scenarios? Previous scenarios. Sir, I have doubts, sir. In this patient is having multiple episodes of vomiting, so is more prone to develop hypokalemia and hyponatremia, and also is a diabetic foot patient, so it will definitely be on insulin therapy. Hypokalemia is more common, but the ECG is showing hyperkalemia.
Presents some AK that also will produce some vomiting. Multiple episodes of vomiting is there, but this patient presented with the AK with the metabolic acidosis. Okay, it's generally weakness, multiple episodes, and then due to CK component. The patient was diagnosed with CK. Uric retention elevated for this patient. Patients showing ABC showing metabolic acidosis. This is our ED patient. So 40-year-old may start with the complaints of altered sensorium. Case is the initial ECG. Adult findings are there. Just we will tell positive, finish it positive. Another 5 6 years one is there.
Normal axis.
Okay.
Rhythm. The rate is around 60 with the tall tilted TS. It's ST elevation. In V1 and V1, V2, V3.
Okay.
Hyperkalemia.
But only hyperkalemic pieces are there. PV is also there. Like normal sinus is only tall TVs are there. Both chest leads and limb leads. Okay. This is the ECG of the same patient after correction of potassium. Still hyperkalemia is there, but amplitude of TVs and came down. So 55-year-old male person who is complaints of bilateral lower limb pain for last 2 days. And examination bilateral lower limb is cold temperature and palpation bilateral. Pop detail, ATA, PT and BP is not palpable. His urine and urobag is showing dark brown color. This is the initial ECG of the patient. You know, what's the ECG finding you were seeing? Or any finding you want, you can tell us, or you can tell him hyperkalemia. White QRS. Some tall TVs are there. Sine wave patterns there. This patient had potassium is 9 or 9.5. Suffering from rhabdomyolysis because of limb ischemia. Okay. So this is looking like sine wave pattern, like severe hyperkalemia is there for this patient. This is the last case is for the patient. Junctional, okay. Tall TVs, the junctional bradycardia is there. So it's we have to rule out hyperkalemia. So these are the ECG findings we will find in hyperkalemia. So first image is a normal, mild to moderate hyperkalemia will find tall TVs. Okay, moderate to moderate hyperkalemia will have PR prolongation and flattening of PVF. Last you will have sine wave effect in severe hyperkalemia. So increased amplitude of and peaking of PVs, QT interval short and normal. Our PVF becomes broader and the amplitude becomes low. Followed by widening of QRS complex, AV connection becomes prolonged, then sine wave pattern will develop. So 16-year-old female male brought to ED with complaints of multiple episodes of loose stools and vomiting for last 3 days. And arrival BP is 80, BP 50 and CR is more than 3 seconds. And this is his ECG. This is classical ECG of hypokalemia. So what are the findings will be there in hypokalemia?
illuminations and the UV. This we have to take the QU interval. So this will be like more than 4 by 5 boxes coming. Okay. So 35-year-old female person with complaints of generalist weakness and malaise. This is it. This is her ECG, initial ECG.
Inverted T waves followed by Q waves. V3 and V4.
So U should be, we have to first see V2, V3. In that leads U will be more prominent. Okay. V2, V3 we are finding some ST depression with UO formation. Okay, some T illumination with the UO formation is there. So this is a 52-year-old female brought to ED with complaints of breathlessness and generalized weakness and arrived ECG. This 2 weeks before the person to Sigma ED. What is the ECG finding in this patient?
Depression in all the leads followed by
Some tachycardia is there. So lead 2, if you see lead 2, what is there? There is no T wave and U waves present. These leads are more prominent comparing V2, V3, V4, V5 in VCs are showing only U waves. So showing U waves, prominent U waves. If you correct for heart rate, it will be like more than 500 kilo. So this patient potential is 1.5 something. We will finish now. So hyperkalemia will find prominent U waves, non-specific ST depression with T wave flattening as the U wave becomes more. So prolongation of QU interval. You should not measure QT and at the end of U, you have to take as QU interval. And fusion of T wave and U waves. We say normal T wave, U will be usually less than 1/4 of the T wave. So if it's in mild hypokalemia, U wave will nearly half of the T wave. In moderate hypokalemia, U wave become larger than T wave. In severe hyperkalemia, both will find out QU only. This is it. 165-year-old male person to ED with complaints of right shoulder pain and back pain for 2 to 3 months. Is visited ED with same complaints for multiple occasions. Can anyone find what's the abnormality in this ECG?
prolonged QTC.
What?
Prolonged QT.
So everything is normal except there is no ST segment, only QR is followed by like ST segment is shortened. Though this it's a classical feature of hypercalcemia. Okay. So if you see this ECG is more classical than previous ECG. There is no ST segment. QRS complex followed by ST segment and T wave is there. There is no like proper isolated ST segment is not there. Look like Osborne wave. AV plasma central will be in severe hypercalcemia. So this will be present in normal ECG. So in the hypocalcemia, the ST hypokalemia there is only Q interval is prolonged, but in the
the sigmas are told like QT interval prolongation may be due to many causes. So one will be like prolongation of QT segment. Okay. In this mainly due to T wave broad and then formation of Q wave in hypokalemia. But in hypocalcemia this is mainly due to QT interval prolongation. So last one ECG of polytrauma patient after massive transmission for blood into the abdomen. So what is there in this ECG? Around 2 more slides on this there. I was telling it's hypo. What? What is again what is ECG finding in this patient? Prolonged QT interval is there and long ST segment is there. Okay? So these are pieces of hypocalcemia. This is ECG of CKD patient on MF maintenance hemodialysis, trace a week. Persistent complaints of breathlessness. What is that ECG? There are 2 electrical disturbances are there in this ECG. Long ST segment. Okay, then and tall T waves. So long ST segment and tall T waves are there. This will be classically present in CKD patients because they are prone for hypocalcemia and hyperkalemia. So hyperkalemia is also there and long ST segment is also there and QT is also prolonged. After correction of potassium after correction of potassium, only QT is this one is a prolonged, but tall T is the corrected. This one more ECG of suggestive hypocalcemia showing long QT segment, long ST segment and QT prolongation is there. So initially I told him hypercalcemia, long QT is due to prolongation of ST segment. So take home point, the main hypercalcemia first you have to at least you find out tall T waves which is pointed, symmetrical and with narrow waves you should find out its hypercalcemia. And hypercalcemia Q interval you have to see hypercalcemia short QT due to short ST segment and hypercalcemia long QT due to long ST segment.
லைட் போடுறீங்களா?
Battery,
I request all our expert faculties to kindly come on to the dais for certificate distribution. Dr. Ignatius, Dr. Shivashankari P, Puniteshwari, Jeevita, Tarika T, Suman Kalyan Sahu, Kiran Shravan,
Center.
Dr. Mansavat Sri Sai Rahul, T. Satvik Reddy, Dr. Kirtana,
கொஞ்சம் ஃப்ரண்ட்ல சார் சார் அப்படியே இருக்கு
Dr. Sundara Mugilangi,
மேடம் யாரை போயிட்டு ஒரு
Dr. Gayatri Karna R,
மேடம் க்ளோஸ்அப் போடுறதா ஒயிட் விடுறதா ஃபுல்லாக ஒரு பக்கம் தான் சார் மேடம்
Aparna Shri, Akash Kumar, Dr. Harini,
அப்படியே 500 தொட்டது போட்டோ
Dr. Babu,
முடிச்சுடுவாங்க வேலையை நம்மள 9 மணிக்கு மேலே ஆகிடும் மேடம் மேடம் சார் சார்
Dr. Arul Selvi,
இங்க பாருங்க மேடம்
Dr.
Madam.
Bhuvaneshwari Velmurugan. S. Niveda.
Madam.
Ashwita V. Pasupati.
Madam.
Muralarasan.
Sir, madam, come on.
S. Santana.
Madam.
Dr. Niranjan Kumar.
Sir.
Vignesh Marimutu. V. Saran.
Sir.
Rajesh G.
Madam.
S. Apurva.
Sir.
Subiksha S. Devanand. G. Hemalata. Tanushree. Gulshan Nisha.
Sir.
K. Deepak.
Bareng, sir.
M. Lokesh.
அந்த டைரக்டா மாட்டி விட்டுருங்க.
S. Mahalakshmi.
இங்க பாருங்க மேடம்.
Gopulashri S. Maid Melinda. Aparna.
Madam.
Shanmuga Priya S.
Iங்க பாருங்க.
P. Nekha.
Madam.
S. Surya.
Madam.
Kavya S.
Madam. battery வைக்குது சார் சார் சார்
UM Kirtika.
Sir.
P. Sandhya. Shakti Balan. Rasika.
Madam, madam.
Dr. Avinash G. Sumati.
Sir.
RTM. Sharad Chandran.
Sir.
Kritika Sridhar.
Madam.
Subhash Setupati.
Sir.
Dr. B. Vijayalakshmi.
Sir.
Kalai Arasan. Jay Durga.
Madam.
N. Shalini. Rifa.
Sir.
Dr. Nikita George.
Battery, flash battery. Sir. கொஞ்சம் க்ளோஸ் ஆகும். என்னங்க அந்த உள்ளார வந்து பாருங்க. க்ளோஸ் ஆகும். இப்போ தரேங்க தலைவரா அது ஒரு பாருங்க ஒரு ஆப்ஷன் அதை ஒரு 2 சார்ஜரோட இதோ பாருங்க பேட்டரி சார்ஜர் ஆமாம் அது இங்கே பாருங்க மேடம். மேடம் மேடம்
Dr. M. Monica.
சார்
Tamil Maran S.
சார்
Diana Shahid.
இன்னும் போடல இங்கே பாருங்க
Darini Devanathan.
சார்
Vijay Kumaran. Naresh Kumar. Monish Shah.
சார் கொஞ்சம் ஃப்ரெண்ட்ல
Dhaneshwar. Krishna.
மேடம் மேடம் சார்
Uma Bharati. Karini. Jyotsna Tejas. Srimati N.
மேடம் மேடம்
Dr. Prashant.
மேடம்
Ilampalti M. Gokula Krishnan S.
சார்
Kanagalakshmi. Dr. S. Kishore.
அப்படியே இருக்கு இங்கே பாருங்க
Kartika Devi. Kritika Devi.
இங்கே பாருங்க மேடம்
Rahul Srivatsava.
சார் சார்
Un día lo voy a hacer presidente de la República de Colombia. Plata.
¿Está ready?
Yo soy Pablo Emilio Escobar.
Ready there, ready there. Ready there.
Ready, sir. Smile, smile. Up there, sir. Smile.